Well, good morning, everybody. My name is Pramod Khargonkar. I'm Vice Chancellor of Research at UC Irvine, and it's my honor to welcome all of you to this symposium, COVID-19 1 year into the pandemic, UCI Scientific Contributions. It's co-organized by our leaders of two organized research units and an academic initiative. Ilham Masoodi, Sangyuk Shin, and Eric Pullman have co-organized this event. And I want to begin by thanking them for doing an amazing job to put together a fantastic program of researchers across the university who have been working on COVID-19 through the last year, and they will share their findings throughout today. I also want to say that this symposium is supported by Precision Health through Artificial Intelligence Initiative at UCI, and that it is the first of several events that we have planned. This one marks the declaration of COVID-19 as a pandemic. But later this academic year, perhaps in May or June, we will do another event where we'll bring together all the grantees who received funding from the internal funding initiative called Craft COVID that we had put together, which was really an amazing collaboration among deans of practically every school on campus, certainly all the College of Health Sciences deans, but also from engineering, physical sciences, social sciences, and so forth. So we will have a symposium that will celebrate the work of all those investigators and what they have done and what the future holds. So look forward to more events of this nature in the coming months. As I think about my own experience with COVID-19, I'm not a researcher in this field, but because of my role as Vice Chancellor, I had pretty close experience with COVID-19 as it evolved. And in fact, one of the very first memories I have of my involvement with COVID-19 goes back to January 29, 2020. Office of Research colleagues, Hung Fan, Jill Kay, Sinki Musto, and I, we normally meet all ORUs once a year. And on that January 29 of last year, we had a meeting with Bert Semler, who was the former director of Center for Virus Research. And I still remember that after we got done with the business of that meeting, I started to talk to Bert about what was going on. And I asked him, are you following what's going on with this SARS-CoV-2? You are the expert in viruses. Teach us about what you think is happening. So we had a pretty lively discussion. And during that time, I asked him, if he thought asymptomatic transmission would be something that we would be worrying about with this virus. And I recall basically his reply as saying, if that happened, it would be really bad. And he didn't think that was very likely. Of course, my memory could be wrong. And if Bert is listening to this, I'm sure he'll correct me. At any rate, that was sort of the beginning of my concerns with COVID-19. And many of you saw we pivoted the research enterprise from full capacity to pretty much shutting it down and then ramping it back up. And through the course of last year, I believe that the research community has done a fantastic job of not just conducting the research, which of course you'll hear about, but also being extra cautious in how we conducted research and followed all the public health guidelines. And I'm very pleased to say that there have been no instances of virus transmission in any research lab that I'm aware of. So we've done just an amazing job of ramping down, ramping up, and conducting the research. as I think about lessons learned, and I think all of us have thought about lessons learned, and you will hear many of them later today. Clearly, there have been some stunning successes that have really been the fruit of scientific research. And I guess above all, one has to say coming up with not just one, but several vaccines is a great accomplishment that builds on years of prior scientific research leading up to that amazing outcome. But there are many other positive developments that one can think about. Development of tests, and you will hear quite a bit of that during today's symposium. And public health guidance and public health recommendations, understanding the spread of the disease, modeling, many areas I think did amazing work that has benefited society. At the same time, if I look at it from a systems viewpoint, and I'm personally, that's my field is systems, you see that the overall outcome has been actually not very satisfactory at the state or national or global levels. Hundreds of thousands of people are dead. Millions have been infected and suffering consequences of the disease. And on the whole, it's been a very difficult year for us as a society. And I think for me, the big issue has been the deep interconnection of people and systems that is really at the heart of our society and our way of life. And this pandemic has, I think, revealed all these deep interconnections. So how jobs and healthcare connects with workplace and home, systemic racism and inequality, all these issues have been brought together because of the virus. One way I like to think about it is many things that are generally not very closely interconnected and are not very interdependent, under the stress of an external stressor like a virus, those interconnections become much more visible. And we saw that certainly in the area of healthcare, in the area of unemployment, and a healthcare system that depends upon jobs, and shutting down of schools. And again, you will hear very good work that UCI has been doing in many of these domains. And I certainly hope that we will learn lessons from past year and use the knowledge that's been generated here at UCI and across the nation for better outcomes in the future. Another thing that I think has been just amazing is collaboration within UCI, across the universities, and actually across the globe. The data sharing, the preprint servers, these are all just amazing successes. Of course, there have been some negatives as well that I won't dwell on. But on the whole, I think it's been a very positive story about scientific research and how it has progressed at remarkable speed in the face of this deadly infectious disease. To close, I started with a personal anecdote about my meeting with Bert Semler. I want the bookend for me personally is somewhat tragic. One of my very close friends and colleague from National Science Foundation that I worked with for many years passed away of COVID-19 last Saturday. So for me, the reality of this disease is visceral. It's very real. It's very emotional, and I think science holds much of the key to doing a better job. And with that, I'm going to once again express a very warm welcome to all of you. I want to thank all the deans and associate deans and center directors who have all worked together in an amazing way to advance UCI in the face of this virus and this COVID-19 pandemic, and has enabled many of our colleagues to make great contributions that you will hear about in the next, throughout the rest of the day. So with that, thank you very much.
Thank you, Vice Chancellor Kargunkar, and welcome everyone. So my name is Tanya Chen. I am an assistant professor at the School of Nursing and also the director of the Infectious Disease Science Initiative. And I have the pleasure and the honor today to be the moderator for the morning session of this very exciting event. And thank you so much for joining us. There's just so much amazing COVID-19 research going on at UCI. And as the Vice Chancellor mentioned, this is just a small snapshot of what's happening on campus. But before we jump in, I do want to briefly go over the format of today's program. So if we can put the agenda up on the screen. Thank you. So you'll find a link to the program agenda in the chat. Hopefully that's there, or if it's not there, then it will be, the link will be placed. So feel free to navigate to the agenda at any time. There was a last minute change. So Dr. Alana Lebron, unfortunately, was not able to make the meeting for her 11:50 talk. And so Dr. Alinda Uloa has graciously agreed to step in and provide a presentation at that time slot. In the morning session, we will focus on the latest research findings at UCI related to epidemiology and public health. And in the afternoon session, we will kind of switch gears a little bit and focus primarily on pathogenesis. Each of our speakers will present their talk for 20 minutes, and there will be 10 minutes for Q&A after each talk. So, please, for the audience, please go ahead and use the Q&A window or a section at the bottom to pose your questions at any time, and I will be monitoring the Q&A box and try to do my best to pose those questions to the speaker after their talks. Please note that we also have a 40-minute lunch scheduled at 12:20, right in between the morning and afternoon sessions, and the afternoon session will start at 1 p.m. We also placed in strategic 10-minute breaks in the middle of the morning and afternoon sessions. So lastly, I do want to just briefly mention that we are planning a cross-fertilization discussion session at 4:20. And the goal of this session is really to discuss what's next in terms of potentially the COVID-19 landscape moving forward, and what's next in terms of the science that we at UCI can promote and to advance so that we can contribute to how the greater society responds to the landscape as things change in the upcoming months and years. So the goal is to really discuss and potentially come up with interdisciplinary collaborations that could advance the science forward. And this is really an opportunity to start that discussion or continue the discussion that's ongoing. So the session is open to everyone. So we hope that you will all join us for that important discussion. Please note that the audio and the video for all the attendees will be turned off for the duration of the program. And again, as I mentioned, please use the Q&A icon at the bottom to submit your questions for the speakers at any time. So at this point, we're going to go ahead and start the program. It is my extreme pleasure to introduce our first speaker, Dr. Allison Holman. Dr. Holman is a professor and my colleague at the Sewell and Bill Gross School of Nursing. And her research focuses on understanding the mental and physical health consequences of traumatic life events. She has been the program principal investigator or co-PI on numerous community-based studies of coping and trauma funded by NSF and multiple other sponsors. So Dr. Holman, please unmute your mic and turn on your camera, and the floor is yours.
Okay, great. Thank you, Sun-Hyuk, for the invitation to share my work. I really appreciate it. And good morning, everybody. So let's get started. There we go. Can everybody see? We're good? Okay. Okay, so for many decades, my colleagues and I have been studying how people cope with major collective trauma. And when COVID-19 happened, when the pandemic happened, it quickly became a challenge that an opportunity and a challenge to understand coping with cascading collective trauma, which is a unique event. And we've conducted research, which I'm going to share with you today. So as we all know, the 2020 was marked by unprecedented cascading traumas. We had the COVID-19 pandemic. We had the economic downturn. We had the racially driven social unrest. We had wildfires. We had the worst hurricane season that we have seen in very many years. And all of these events are going to likely have, from the work, based on the work that we've done, likely to have very significant mental health consequences, both from the direct exposure that people have had to these events, as well as the media-based exposure. And I'm going to talk a little bit today more about the media and its role in amplifying the stress of these kinds of events. So the COVID-19 pandemic ushered in a period of, as I said, of a unique case of collective trauma. Why was that so? Because the COVID pandemic was an invisible threat. It's not like a hurricane that you see the winds, that you know it's coming. It's not like a mass shooting. It's not like these other things, because you don't know who's infected. And it's also unique because you don't know we didn't at the time know how bad it would get. We didn't have any idea how bad it would get initially. It was also a unique event because it created for many people, for millions, billions of people in the world, a very uncertain future. It's like, what's next? What's going to happen next? How are we going to stop this virus from taking over? And then it was also a global threat. It was pretty much, there was no place in the world that you could be for sure safe. I guess maybe if you had an underground bunker in New Zealand, you might be able to, but that's not the vast majority of people on the planet. So it was also unique because at the time that the COVID pandemic was emerging, we were asked to socially distance. And what do people do when they're coping with major events like this? Our natural inclination is to go to our family and friends. And unfortunately, in this situation, we couldn't do that in the same way that we were used to doing it. And it created a bit of a challenge for us in terms of how do you cope with an event like this when you're in the midst of not being able to use your main source of support in the way that you're used to doing it. It was also different because the COVID pandemic took away from us by the fact that we needed to, stay at home and not go out. We couldn't go to the movies. We couldn't go out and distract ourselves and do the things that might help us cope with stress that we're experiencing. It was also a disruption to major areas in all areas of our lives, including our social, not just our social work, but our work life, our worship life, and more. So it kind of took our entire lives and turned them upside down. But there's another way that the COVID pandemic was unique, and this is something that I've been studying since I did my dissertation back a long time ago. I'm not going to say exactly when, but it created what many have called the COVID time warp. And what that was it was an experience where our experience of time changed, and people were often saying things like they felt like time was moving really slowly, or time was moving really fast. Maybe they thought, it's like a week would pass and they'd feel like a week was 10 years. The week would, a day would just move like molasses, and yet a week would move like lightning. So it created this unusual sense of time. And that unusual sense of time, experience of time, is something that's been discussed in the psychiatric literature, and I've used it, I've addressed it and studied it in my research. It's called temporal disintegration. And what it is it's when we have impaired sequential thinking, and we kind of isolate the here and now from the continuity of time. And it's a natural thing to do when coping with a major stressor, because when you have a major stressor facing you, you have to focus on what's going on so you can cope with it. So it's a natural thing to do. But when it persists and goes on for a long time, as it has with the pandemic, it can create problems. So examples of time of temporal disintegration include, as I mentioned a moment ago, time slowing down or stopping, or feeling like you have no future ahead. It's like all of a sudden there's no future. We're just here in this moment of now with nothing happening next. And unfortunately for many people, the experience of time and this change in our experience of time in many studies that we've conducted or that I've conducted has been associated with numerous mental health problems. It's been associated with stress, depression, post-traumatic stress symptoms, and obviously worrying about the future. So what I'm going to share with you today is some research that my colleagues and I have done where we address a lot of these issues, these questions around the unique case of COVID and how it's impacting people and the responses people have had in the United States. And I'm going to argue that the exposure to the media is likely to amplify the public health consequences of COVID-19. And why do I say that? Well, the media is a double-edged sword. The media, during periods of high ambiguity and uncertainty, like the ones we've been facing with the COVID pandemic, we go to them, and that's a good thing. We go to them for trusted information. We seek out information about what's our risk. We seek out information about what should I do to protect myself. So in a sense, the media can provide us with very critical guidance about what we're experiencing and what we can do about it. However, the media can also increase our perceptions of risk and anxiety if the information that it's giving us is communicated ineffectively. When you have bad communication, poor communication of the risk and poor communication of what you need to be doing, then you can actually raise anxiety in people. It's also a problem, media can also be a problem when you overexpose yourself to it. When people see too much of the same footage, for example, of major stressful events that are going on around them, it can actually increase their stress, and that can have downstream mental and physical health consequences for people, as we've shown in our research. And finally, the media is a double-edged sword because rumors and misinformation are spread throughout, especially social media. And this is a real problem, as we know that there was a point during 2020 where we talked about having a disinformation pandemic, partially because we had so much disinformation being spread throughout social media and elsewhere. So what my colleagues and I have done to address some of these questions, to address our questions around the role of the media in coping with COVID-19, is we've conducted a study with a probability-based nationally representative sample of Americans for whom the mental health and physical health were data that was collected on them prior to the pandemic beginning. And then after the pandemic began, we took a random sample of the NORC AmeriSpeak panel of 11,000 people, and they were each, so it's a random probability-based random sample of the American people that was then randomly assigned to 3 cohorts. These 3 cohorts were surveyed for 10 days on 3 10-day sequential periods. So we have 3 different samples collected over the course of a month at 3 different time points sequentially. And the reason we did it this way was because at the time that we were starting, there were 190 COVID-19 related deaths in the US. By the time we stopped, there were 18,000. So the pandemic was clearly taking an upturn. And we thought we wanted to capture a little bit of the change in that early response with these random samples of people. We then followed up the sample in late September, early October with another survey where we followed up with many of the similar constructs that I'm going to talk about in a moment. And we followed the entire sample all at once in that assessment. In our paper that we published last fall, where we looked at some of the mental health consequences of the pandemic, one of the things that we were particularly interested in understanding is what are the early predictors of distress as the pandemic was just starting to worsen over time in that first month. And what we found that indeed, as we anticipated, the early acute stress response. Acute stress is the beginning of it's like early post-traumatic stress symptomatology. And so early post-traumatic stress symptoms were slowly increasing. They were generally low, but they were going up over those three cohorts, as were depressive symptoms. And when you look at acute stress, what we saw was one of the key predictors of acute stress symptoms was media exposure. So the more media exposure people had during that week, during the early part of that pandemic, that first upturn in the pandemic, the more acute stress symptoms they reported to us. At the same time, what we saw, and this is unique to this study, we've studied, this graph that I just showed you, we've seen this in the Boston Marathon bombing. We've seen something similar after 9/11. We've seen it similar after the Orlando nightclub shooting. This isn't news to us, but what we did find in this study that's really important is that because last year was characterized by a series of very lots of conflicting information coming to us from the media. So I'm not blaming the media when I say that, but just that there were many different pieces of information given. Oh, use hydroxychloroquine. Oh no, don't use hydroxychloroquine. Don't wear masks, do wear masks. So there was a lot of conflicting information. And what we found was that the more people were exposed to conflicting information, if you look on the top graph, what you see is that as conflicting information went up in the media, so did acute stress symptoms. And similarly, as conflicting information went up in the media, so did temporal disintegration symptoms of like not feeling like you didn't have a future. At wave 2, we found the same pattern. We see that as people experienced more conflicting information at the time that they were at the time of the surveys, what we see is as media conflicting information goes up, so do post-traumatic stress symptoms. As conflicting information goes up, so does temporal disintegration. So what we're seeing is two things go on. First of all, we're seeing the media is exacerbating the symptoms of stress, but it's also exacerbating our distress in part potentially through this experience of helping like our sense of distorted time. So what do we conclude from this? Overexposure to the news media can amplify distress over time. We've seen this and we saw it very clearly with the COVID pandemic. There can be downstream mental and physical health consequences to this overexposure to the media. We saw that in 9/11. I anticipate that we will likely see that again. We also saw that conflicting political agendas and the contradictory messages that come through the media can be especially stressful for people and important for us. It's important for us to recognize this and learn how to address this. So what are our recommendations? The media needs to convey information to the public without sensationalism and disturbing images. In my prior work, I've shown that exposure to bloody images actually exacerbates, is actually one of the above and beyond the amount of exposure that a person has. If you're exposed to like bloody images in the aftermath of the Boston Marathon bombing, the more you saw that, the more likely you were to report high levels of not just acute stress, but also post-traumatic stress and have poorer functioning 6 months later. So one of the things that's really important to recognize is that it's not just what you hear, but it's also what you see. There's many ways that the media exposure can actually touch us. We also need to have the public try to limit their exposure to media stories. It's important, we've been recommending that people actually select highly authoritative outlets, World Health Organization, for example, the CDC, which is now back on track, and monitor how much exposure you get. I encourage people to pick like twice in a day, maybe get your information, because I think people shouldn't put their heads in the sand. They need to actually get the information, but limit how much time you spend seeking it out and getting it. Maybe a couple times a day, don't sit there and keep looking at it. Is what some people call doom scrolling. And then the public should be wary of the unverified reports that they see on social media. Social media tends to have a lot of unfiltered and unchecked stories. So it's very important. When I say unfiltered, what I mean is you can also get, oftentimes media outlets will review images before they actually decide what they will put up on for the public to see. And unfortunately, in social media, sometimes those images come straight through without having been evaluated, right? Because it's people just posting things. And so we see things on social media that can be very disturbing. So, be careful when you're using social media, but also verify and check. Use Snopes or whatever kind of fact-checking agency you can to make sure that what you're looking at is accurate. Other recommendations are to have healthcare providers be sure to encourage their patients to temper their exposure to the media when they're dealing with this kind of an event. And then finally, I would suggest that because the Black, Latinx, and Indigenous American communities were the hardest hit with the COVID pandemic, one of the things that's critically important is to recognize the role that both the trauma of the pandemic, but also as Vice Chancellor Kagonakar mentioned, there's been, the pandemic sort of brought out all of these other really important stressors in our society. And one of them is the massive health disparities that exist in our society. And they are compounded by the historical trauma that's been experienced by people of color in America and the systemic racism that persists and the poverty that people live with. So all of these things, because of all of these things, our recommendation is that those communities are the communities that need to be targeted with the resources to cope with this pandemic the most. We need to do things like, I would suggest, getting mobile vans for immunizations into those communities so that we can get them immunized as fast as we can. We can get mobile vans doing checks on people, providing testing for people. Whatever the need is of the community, we need to be in those communities and allocating resources toward those communities. So what are the lessons we've learned from collective traumas over the course of the last decades of research? One of the things that's really important to acknowledge is that uncertainty is stressful. Uncertainty is something that, really makes people feel a lot of distress and anxiety. But anxiety here in this situation, instead of thinking of that as being a pathological response, it's not. Anxiety is an appropriate response to the kind of circumstance that we're in. And so I encourage you not to think about a person's anxiety being in a pathological way, but think of it as a normal response to a very unusual and new normal type situation we're living in. At the same time, I think it's really important to recognize that we're not likely to go back to where we were on January 1st of 2020. Not likely to happen. I think we are forever changed. I think the world is forever changed, and hopefully we will pick up and learn lessons from this that we can actually to make the world a better place and prevent the next infection from becoming a pandemic. Other lessons we've learned include, I want to encourage people to remember that people cope with things in very different ways. The variability in response to major collective stressors is wide. And so you might have somebody that isn't feeling very much distress versus somebody who's feeling extremely distressed. At the same time, remember that anxiety is contagious, but so is compassion. And that's a really important piece that psychology has to offer here. Compassion is a very contagious thing. And when we behave in compassionate ways toward each other, we can actually encourage other people to behave in that way towards their friends and their families and their colleagues. And that goes together with something that I think is a really important piece to remember about the pandemic. It started, it's attacked our entire society in many ways, and it's an impact on our social fabric. And one of the things that's really critical in coping with an event like this is to remember the social responsibility that we all have to each other. The idea that America has lived with, that we're rugged individuals and, every person to themselves, well, that isn't a fact. That isn't the way the world works. The world works as a socially woven together place. We all depend on each other to a certain degree for something. And so if we work together, we can save lives. We need to think about this as ourselves as having that social responsibility, and take that, be the person that's willing to do the thing for your neighbor to help build that stronger community. And as each of us does this and shows the compassion towards our colleagues, our neighbors, and actually takes pro-social behavior toward other people, we can help reweave the social fabric that's been torn at by the pandemic and help make us a stronger, more resilient place. So I want to encourage people to think about that and act on that. And without minimizing the distress that a lot of people have been feeling, I also want to remind you that people are resilient. Human beings are extremely resilient. We get up and we get up and we try and figure out how to cope with what's going on. And we often realize that once we get through things, we often realize that we had strengths that we didn't know we had. And we had coping skills that we didn't know we had. So I want to encourage you to look for those in yourselves and your colleagues, your friends, your family. Look for those things. And when you see them, I want you to compliment them on them. Recognize them, give them strength, give them encouragement with that. Those things are really important for helping people cope. So with that, I think I'll open it up for discussion, questions, and I want to acknowledge my colleagues in the School of Social Ecology and the National Science Foundation for their help with this study. Thank you.
Thank you, Allison. That was fantastic. And I think, what you said about sort of time being so fluid and so abstract for so many of us, it just really hits home for sure. I keep trying to arrange meetings for January or February, and we're already in March, so definitely. Right. So I'm going to go ahead and start out with the question, and we do have, and then I'll go to the audience questions as well. But I wonder, in your presentation, you spoke about the association between media exposure and stress. And were you able to find differences in the type of media exposure and in terms of their association with the stress that people might be feeling?
Oh, Sanyuk, you asked the perfect question. Yes, we're looking at that. Maybe I can share my slides again and I'll show you one thing that we've started. This is like hot off the press stuff. Let me share my screen again, if I may. Okay, can you guys see the screen now?
Yes.
Okay. Okay, it's not moving. All right, let's just go down. Current slide. Okay, let's just go there. Okay, so we are now looking at the type of media exposure that people have had, like what is it about the media? We're trying to understand that. The types of media exposure people have when they're looking at it. So we actually asked people, what are the sources of information that you used? And we gave them a list of a bazillion different sources, ABC, CBS, you know, Fox News, CNN. We gave them a ton, like a long list. And then we've done some, my postdoc, Nicholas Jones, has been doing some incredible work with this data. And what we're seeing is that the type of media exposure that people had across time was associated differently with their levels of their reported depression symptoms as well as their worry symptoms. And the way it works is that it looks like people who have an ideologically diverse, so they look at media from a variety of sources, that those types of people who get that kind of work, their levels of depression and worry didn't change over time or worsen. But we see that people who have a far right-leaning or a right-leaning level of diet, essentially media consumption, we see the decrease, lower levels of worry and lower levels of depression in them. Whereas for people who have a more left-leaning, such as MSNBC and whatnot, they would be having slightly higher levels of depression or worry at time 2 relative to time 1. And so we do see that the quality of the media, what you're seeing and where you're seeing it, has an impact on how you're experiencing stress and distress and mental health symptoms. Did that tap your question?
Yeah, and then I'm sure we can dig into sort of the types of media, social media versus mass media, television versus papers. I'm not sure we have the time to dig into all of that, so maybe we can kind of hold that question for our late afternoon cross-fertilization discussion. And there are a couple of questions from the audience. So there's a question about the responsibility to go into communities and make sure that those communities are supported. I wonder if you looked into the incarcerated population in that context.
That's a fantastic. I think that's a really important point to bring up. Yes, I think that's one of the places where we need to be concentrating. I mean, after all, the incarcerated population is a place where many people of color live. And it is, that population has been really just a target for this virus because of the conditions of the living conditions that people are in, as have been, meatpacking plants and other places. So I mean, I haven't personally looked into how we would do that, but I think that's a great idea. And I think that is one of the places where we need to be concentrating efforts on getting some vaccines in and getting people tested as needed, et cetera, and providing them with the care they need.
Great, thank you. And our last question pertains to sort of the post-pandemic period. And especially as, perhaps it's possible that there may be more tendencies to kind of live in a more virtual world versus, in-person interactions. And can you speak a little bit about kind of the role of media in that context?
Very interesting question. I think living in that virtual world, I don't know about other people, but living in that kind of virtual world, I think, and media exposure through the virtual world, I think I'm a little concerned that might exacerbate some of the negative impacts of the media, only because living in a virtual world, it's not as, I don't know about you guys, but it certainly doesn't feel as concrete as living in the world that I was in before the pandemic. So I think there are going to be some risks. There are also some potential benefits of living in the virtual world, but the impact of the media in that space, that's actually an empirical question that we'd have to look at. But I'm a little concerned that it might be one of the things that happens when people are starting to experience distortions in time perception is also that the sense of the here and now becomes a little bit, what is in the here and now becomes a little bit unclear. And if that's happening to people in a virtual environment, that could create problems. in terms of further worsening, exacerbating the problems with time perception and whatnot. So I'm a little, but it is an empirical question. It's a good empirical question.
Great. Thank you so much for your fantastic presentation and
thank you
answering these questions. Great. So we'll go ahead and move on to our next speaker. So our next speaker is Dr. Sunny Zhang. And Dr. Zhang is professor and chair at the Civil and Environmental Engineering. Her research interests are in the area of environmental biology and public health, and her group develops and evaluates engineering technologies for pathogen assessments and removals. So Dr. Zhang, if you can unmute your mic and turn on your camera, I'll go ahead and the floor is yours. So I'll go ahead and pass it to you.
Please swap displays.
All right. Here we go.
Thank you.
Okay, great. Thank you. Thank you for having me here. Good morning, everybody. So we're gonna switch gear a little bit and talking from understand human psychology, human behavior, and looking at our wastewater. So before I start, I want to acknowledge all those collaboration with the local water agencies, and we work very closely with Los Angeles County Sanitation District, Irvine Ranch Water District, Santa Margarita Water District, and Inland Empire Utility Agencies. They are the backbone to support all the sample collections. If you look at this title, Wastewater-Based Epidemiology, that basically says we shed what we eat, but not only what you eat, but also what you have in your system, you're shedding them. This term of wastewater-based epidemiology started from such as, drug abuse. And then if you see the residuals of opioids, and then you see the population of utilization of those type of recreational drugs or other chemicals, but also they can use to track diseases, infectious diseases. And there's very successful case of wastewater-based epidemiology is by looking at the sewage to understand the polio viruses spread. And actually it's very common to see very high level of human noroviruses during the winter season, because noroviruses is described of this winter vomiting disease. And so if we have a very high population of diseases population, you will see them in the wastewater. So this is where the wastewater-based epidemiology starts. Wait a minute, everybody will ask, well, COVID-19 or the viruses SARS-CoV-2 is not a fecal-oral infected viruses, it's respiratory viruses, right? And then it doesn't cause diarrhea. Actually, although we focus on the respiratory or lung infection, very rapidly as the start of this epidemic or the pandemic, we have realized, and actually the COVID-19 patient shed a very large amount of this SARS-CoV-2 viruses in their feces over the course of disease. Actually, they find that this viruses is shedded in the patient's fecal samples long after their nasal swab sample have become negative. Of course, there was some public panic, and there was some report about, flushing toilet and then will generate all those viruses in the aerosols. But one thing is never really completely confirmed is the infectivity of those viruses in your feces. And there are a few isolation of infectious viruses from the feces, but majority of the detection is done by the genomic-based methods. And then, so there are very detailed research done by Stanford, and they find that these viruses can replicate in human small intestines. That's explained that very high loads of viruses in the feces. However, their results also shows that the fluid in your colon and inactivate a very large fraction of the viruses that is replicated in the small intestine. There are diarrhea associated with the diseases, and then with this type of disease with the patient, but that's not the main symptoms for most of the cases in here. Nevertheless, and since the discovery of this type of viruses in feces, there's a lot of effort have going into looking at human sewage. And because of those efforts, there's high concentrations of SARS-CoV-2 viruses are found in human sewage, actually all over the world, with the effort from all the pandemic area. So US CDC put in a major national wastewater surveillance system. This effort is basically trying to track the viruses through our wastewater. There's many advantages with this type of a system. And the first thing is basically, you have a pooled community of samples. You don't sample individuals. If you sample a sewage, a raw sewage in a wastewater treatment plant, you can see the level of the diseases in the community. And also our testing effort is basically sporadic, especially in the early part of the early period of this pandemic. So the testing is in certain regions are more and the others are not available. So there is also a delay. And the other thing is there are asymptomatic cases. Those asymptomatic cases were not subject to testing, and they are very risky for the spread of disease. And those asymptomatic patients also shed the viruses in their feces. And so those are the advantage of looking at wastewater-based surveillance. You can capture the data, you can capture a lot of different cases, and to supplement those in-person testing. So with that type of idea, there's all over the country, there's over 170 wastewater facilities across 37 states in the United States are testing viruses in the wastewater. Actually, it's all over the world. And there is a program in UK, in Netherlands, and this is the sort of an international effort. As part of this effort, this is the concept that we're putting forward to try to understand if we can use this as a tool to track the spread of the COVID-19. We are working with several local water agencies and then to looking into wastewater in our Southern California area. The map you're seeing here and showing actually eight locations of the wastewater sample are collected all over Southern California. And then the first four wastewater treatment facility we sampled is in the county of Los Angeles, and then 3 facilities in the county of Orange. And we also included a facility in the county of San Bernardino. For those of you who don't know what the wastewater treatment plant look like, and there is an image from an airplane or a spatial image. Actually, wastewater treatment plant is very easy to be identified when you take off from our landing to our airport, and they have this very distinct structure to it. So to collect the wastewater from those different diverse wastewater treatment plant, our goal is to compare the SARS-CoV-2 concentration from those different plants. And basically, we're trying to correlate the concentration detected in the wastewater with the community level epidemic. And so that we can validate or support this wastewater-based epidemiology investigation. We also intended to collect long-term data of the viruses in order to track the spread of this COVID-19. And also if, as the cases right now, if the disease and sort of disappeared, subside in the society, what if there is a resurgence of the disease, and then that will be very quickly reflected in your wastewater? That's the goal of the study. Well, before we can go into to analyze the data, to analyze the sample, we have a lot of challenges to deal with wastewater sample, your sewage, because it's a mishmash of a lot of things. You dump everything into your drain, into your toilet, and that's why the wastewater is very complex matrix. It's more difficult to retrieve that trace amount of genomic information than from a human nasal swab or from human, even from human feces. Sometimes the complexity in the wastewater is more complex than the human feces. So this is just an image of some example of untreated influent. Influent is basically raw sewage. After it's treated, it looks a lot better. And then if you put the wastewater, well, this is a fairly cleaned up sample under the microscopy, you can see the bacteria, the viruses, and all the other things that you expected or you don't expect it from wastewater. And I also put a graphic image of wastewater treatment plants in here, and the process of the wastewater treatment are quite involved. At the end of the wastewater treatment, we actually recycle the finished wastewater into our drinking water supplies, but the sample taken is from where the raw water was inflowed into the plant. To get rid of some of those inhibitions, and we adopted and developed a method. This is called the digital droplet PCR. In comparison with traditional PCR, which is you just analyze your sample in a single tube, and the droplet PCR is basically break down that one single reaction into thousands and thousands of reactions so that you form this nano droplet. In this way, you can get rid of some of those interference, the material that interferes with your reaction. The PCR is enzymatic reaction. Anything present to inhibit the enzyme or it will cause your reaction to be failed. And then so the reaction will produce, if you have a positive results, you have this positive droplet. And so this work is being done in the UCI High Throughput Genomics Center. They have this instrument. And so we developed the assay, then we just run the assay in this BioRed instrument at our facility. We also tested two different set of primers that targeting the SARS-CoV-2 viruses. The primer N1 and N2, they both are recommended by CDC, but have not been applied to at the time when we developed this method to apply it to the digital droplet PCR method. We tested the efficiency of those two different sets of primers. We have identified a set of primer, which is you're seeing in here, has a higher efficiency of recover the viruses from the wastewater sample. So we moved forward with applying this detection method to the wastewater treatment plant and the samples we collected. Here is the result from 9 wastewater treatment plants that we have tested. This is a Long Beach wastewater treatment plant. This is Las Cañadas treatment plant, Whittier Narrow, San Jose Creek, and this is called a joint reclamation plant. And all this belong to the county of Los Angeles. Okay, so if you see my cursor, and those are the plants and belong to the county of Los Angeles. And then we have 3 plants here, and a mycosin plant, which is collecting sewage from UCI campus, and of course, and the other regions in the Irvine, Newport Beach, and then some section of the Costa Mesa. And Chiquita plant is in the South County of Orange County. Those 3 plants are from Orange County. And the last plant is from the San Bernardino County. The first thing you can see, the different colored bar here are the sampling dates. And this study is being done only at the beginning of the pandemic. At the beginning of the pandemic between April and June. We're comparing those different wastewater treatment plants with the goal of parsing the association between the concentration of the viruses with the community level epidemic, with the case report. But from this, you can tell, I have all the plants here from Los Angeles. The concentration of the viruses are very different. And that really shows the different communities has a different level of epidemic. But the problem is I don't have the case report and associated with each individual treatment plan region. When I start to do this and people ask and said, okay, Anaheim seems to have very high case numbers. Do you see them in the wastewater? The problem is that I don't have a wastewater treatment plant just collecting from Anaheim. So the Long Beach plant is not only collecting from Long Beach, the district of the city have nothing to do with the sewage community collection system. One thing it shows that yes, the wastewater are very different, have a different concentration, but I cannot match it up with the case report from 3 different counties. So this is during the period of April to June. This is Los Angeles County daily report, of course, going up and down. And then San Bernardino of Orange County is a little less, but I cannot relate this type of epidemiology data and with the wastewater concentration. Give you a little bit of understanding how the wastewater district is being defined. This is the plan, Long Beach Water Reclamation Plan, include the city, a partial of the Long Beach area, Lakewood, Artesia, and Cypress. So those are defined a very complex system. And the other thing add to this issue about individual wastewater treatment plant is that they also have industrial output and they have discharge from business, restaurants, and chemical processing plants. Long Beach also have a lot of the refineries. Those wastewater will mix in with municipal wastewater, and to parse the proportion of the contribution of municipal water is very challenging. So although we can see the different concentrations of the viruses in the different wastewater treatment plant, it's very challenging to relate to the specific community and then give you the detailed information about epidemiology in that specific community. So the second portion of the work, this is a very long-term effort and start from the April of last year, lasted until now, it's still ongoing. There are 2 very large wastewater treatment plants in Los Angeles, and then actually Los Angeles Joint Water Pollution Control plant is the largest plant of wastewater treatment plant west of the Mississippi. We call it the centralized plant. And then the second plant is called the San Jose Creek wastewater treatment plant, is second largest plant in this region. What you're seeing on this graph, and then here is the date of sample collection. The sample are collected weekly or bi-weekly, depends on the supplies. And then for this plant, in the current day is actually ongoing. So the last result is from March. And the black line you're looking at, this basically is the weekly concentration of the SARS-CoV-2 RNA in the wastewater. The red line you're seeing here is basically the 7-day average of case report from the county of Los Angeles. And then similar here, this is black line is the number of the viruses found in the sewage, and then the blue line it's the same actually as this red line here is the report from the County of Los Angeles. You can see the concentration of the viruses in the sewage in the broader sense tracked very well with the case report from the County of Los Angeles. So this suggests that if you look at the big picture, you don't include all those variability from different plant. If you look at individual plant, you're looking at the long-term trend of the viruses, and it's matched very well with the long-term trend of the case report, suggesting there is a good potential to use this sewage tracking as an indicator of the community level of diseases. And this will be extremely important. And if there is a sudden resurgence of this type of diseases in the coming year and in the next winter, and when the next flu season comes. The last objective we did is, this is still the early work. I want to call this proof of the concept. And then we are looking at genotype diversity to track those variants. We designed a primer rather than using the massive sequencing in sewage, which is very challenging. Sequencing the viral genome in sewage is basically needle in the haystack. You try to do that sequencing. We developed this specific called amplification-based sequencing. We designed primers targeting the S protein, and then the first set of primer only designed for this single site mutation in the part of the genome. This type of mutation is a very early mutation and then caused a very rapid spread in Europe and North America. And the second set is in this, it's called open reading frame 8 region, is also a single site mutation. We try to prove concept, can we track the diversity of the viruses in the sewage and reflect the mutation of the viruses, and so that we can understand if there is more virulent strains in spreading in the community. This is the early result and showing the genotype that we identified in the sewage. And then here are the samples, and then here are the control recovery genomes from the database. Using this region, the open reading 8 region, we only detect one genotype. In the S protein region, we detect 2 different genotypes in the sewage of all, 7 out of the 8 wastewater treatment plants we collected. And this is, again, this data is from the early part of the sample between April and June last year. And so we are developing newer primer set to target the new variants, and so that we can targeting those new mutations that are occurring in, well, there's actually a California mutation now. Hope to track the mutation of the viruses from the sewage as well. So I'm going to wrap up here, and then thank you for your attention. If there are any questions, I'm up to it.
Thank you so much, Dr. Zhang. That was fantastic, and I love your images from your presentation. So I think one of the key utilities of the wastewater epidemiology and surveillance is, I think, sort of, as you mentioned, early detection of trends, whether it's going up, going down. And you did show the slide where you're comparing the wastewater detection versus case reports. And I'm wondering if you can talk briefly about sort of, what the time difference is in terms of, between when you can detect, let's say, changes in trends in the wastewater compared to what you're seeing through case detection.
Right. So by individual county, but by individual treatment plant, it's very difficult to relate the relationship because the data is in imperfect, right? And then so if you look at the daily new cases report, sometimes you get negative number because the day before they overcounted. So sometimes if you even get negative number, and in generic, it's about a week after the cases is being reported. Sometimes we even precede the higher level of the wastewater concentration. It's before the case report. So we've seen both cases, but normally track fairly well within a week and a week and a half, 10 days.
That's great, thank you. We do have time for a couple of questions from the audience. And so just as a reminder to the audience, please put your questions in the Q&A function at the bottom right of your screen. So one question was about, with the wastewater RNA detection, clearly, not all RNA detected is infectious. So is there a way to determine the extent to which there's, infectious viral particles versus those that are non-infectious?
Right, a good question. No, you're right. Viral RNA is not infectious, and actually, the goal of using wastewater-based surveillance are not really try to warn you there is a risk of wastewater going to cause infection, but to understand what is the level of people, what the number of people shedding the viruses in the wastewater. So there's no clear evidence that wastewater will cause spread of the disease. And so don't be overly concerned about, food. There is very little evidence about food transmission of these diseases. And same thing with wastewater, there's still very little evidence about transmissions through other than the aerosols.
Thank you. And we have a question regarding, whether the wastewater detection system might be able to predict outbreaks of COVID-19, and I guess it says infectious diseases, so perhaps other infectious diseases as well.
Yeah, that's the goal, definitely. And then if you have it's very difficult to get human to be tested even at the beginning of the pandemic, right? And then we don't need IRB approval to sample wastewater. All we need to do is to, we never stopped, we haven't stopped, and then sampling wastewater to look for the SARS-CoV-2. And then so now we are seeing there are no signals. Actually, we're sampling the manholes at UCI. And so I'm not telling that story. It's too close to home. And then actually University Hills, and then for many faculty who live here, we sample a manhole and then with a flow down from University Hills at the University Club. We see positive signals in the December and January period, and then we cannot see signal coming into February. And so, and I will have an update and then to Bernadette, and I think in a week and a half, and about university manhole sampling. And so thank you for the support from the UCI facilities and then the management to help us to open the manholes in the UCI to do this. Yes, the goal is to track if there is a resurgence of this disease.
Great, thank you so much for your fantastic presentation. So I think with that, we'll go ahead and move on to our next talk. So our next speaker is Dr. Suellen Hopper, who is an assistant professor at public health, and her research investigates messaging around health decision-making and what kind of messages motivate positive behavior change, and also designing effective communication interventions for clinical, social media, and community settings. So if Dr. Hopper can go ahead and, okay, so I see that you're unmuted, your camera is on, and so the floor is yours.
Okay, thank you. Let's see here. We've got the, okay, hello everyone. It's such a great opportunity to hear all the latest research ongoing, and I'm going to talk to you about research that UCI Public Health and the Institute for ICTS, the Institute for Clinical and Translational Science, team is doing around parent-adolescent decision-making for the COVID-19 vaccine down the line this summer. I do want to just briefly mention that I have sort of 3 research studies ongoing. One is about parent and adolescents, getting a pulse on their views about the vaccine that's not available yet for children, but in clinical trials, as well as detecting vaccine expressions of vaccine hesitancy and misinformation on social media, because we have a lot of young adults and a lot of the population turning to social media for their media consumption, and there is a lot of misinformation, and then reaching families through trusted networks. So these are all have sort of a synergy, but I'm going to highlight the first study. Why are we talking to families about vaccinating children? Because a quarter of the US population comprises the child population or children under the age of 18, and reaching effective herd immunity will require pediatric vaccination. So we do have, as of 2019, we have 25 million children just in the age of 12 to 17. So this is coming down the pipeline, and the 2 emergency authorized vaccines, Pfizer and Moderna, do have clinical trials of 11 to 17-year-olds. One of them has enrolled almost 3,000, the other one also about 1,000 adolescents, and those results will be coming out this June. And that will also inform the strategies of the schools reopening and for next fall. So what we did was, in the last few weeks, we've been conducting virtual discussion groups with families. What's a little bit unique about the study is that we are including the adolescent views as well as the parent views. And there are some unique considerations when considering vaccinating adolescents and children. So the immune system really is still maturing and is potentially more reactive. Children are more likely to, by and large, to be more asymptomatic. And the risk-benefit profile, therefore, for vaccinating children is potentially suboptimal. So the things you weigh are a little bit different. And, there are a lot of families out there listening to considerations to vaccinating children coming down the pipeline again. But having said that, these risk-benefit profiles are suboptimal, at the same time, there are direct benefits to children. There is a need to protect children against multi-system inflammatory syndrome, this rare syndrome in children, yet it does impact, so that inflammatory syndrome is about 1 to 2% of children, but overall there have been about 12.4% of COVID cases have been in children, 180,000 cases, 172 children have died from COVID-19. So those are direct benefits. Indirect benefits are protecting family members and, multi-generational households, family within household transmission. So these are some of the unique considerations for why, again, there's, necessary, it will be necessary to vaccinate the pediatric population, but it's a little bit more complicated. And so I'm just going to share with you that we've been interviewing families for the last few weeks. It's sort of still hot off the press. We still have to process the data, but we did interview 12 parent adolescent families. That turns out to actually be well, we had 12 parent adolescent family group discussions with 3 to 4 families in each discussion. So in the next slide, I'll share with you that there are 46 families we've interviewed so far. And we're investigating their general vaccine attitudes, as well as especially for their children, where they turn to for information, what they weigh and consider, getting a pulse on where they stand currently and what they would like to learn more about. And then we also survey them about their parenting style, their history of vaccinating their children, their expectancies, and ranking their concerns and motivators. So this is just the one slide on the demographics of the families we have so far. Again, 46 families, dyads, where the children are between 6th to 12th grade. And there's a diversity of race, ethnicity among the families, ranging from 58% of white Caucasian families, 21% Asian, 14% Latina, 5% American Indian, 2% Hawaiian Pacific Islander, and mixed race ethnicity. We're trying to sample families across a number of criteria that may impact vaccine attitudes. So family, race, ethnicity, parent occupation, multi-generational households, which is 30%, and families where they're with children with chronic medical conditions. That's 26%. So most of the families we've talked to so far did have the adolescents receive the flu vaccine in the fall, which is sometimes also an indicator of vaccine attitudes. And almost all of the adolescents are still being schooled online. So that's really impacted families significantly. There are 2 children going to school in person. And top ranked concerns just generally were side effects in vaccine ingredients, safety, allergic reactions, your typical concerns under these sort of evolving dynamic conditions, where there's a high uncertainty and information coming out is not always there or rapidly changing. Top motivators were really that there are a considerable number of families taking their cues from healthcare provider recommendations. Even though during the pandemic, we are online with a lot of televisits, or not seeing not going to as many clinic visits as perhaps under other conditions. Other motivators are confidence in the development process. So there have been, and I'll show in the next slide, some schools that have really played a significant role in pushing out information to families. And reassurances, so to other top motivators, I apologize if it's not so visible, is that I think observing family members and networks which can go either way about COVID-19 severity and susceptibility. It really is all over the board about perceived severity and susceptibility. So overall, I'm going to share a few slides about adolescent views and then parent views, and share then some social media misinformation and some implications. So overall, the adolescent views, again, we're still processing this data, but among the older high school students, the vaccine attitudes by and large were more favorable. And again, as I mentioned, a good proportion of those high school students had received educational webinars of updates about COVID-19 and the vaccine through promoted webinars with experts and doctors, and that and time, as well as their family household networks, grandparents and parents vaccinated, was really building confidence in the vaccine and wanting to be reassured about that side effects are not severe. So this isn't that surprising, but this is good news that if we keep going with this approach, that it warrants educational approaches, investing in that, because when you have information vacuums, that's when you have false information filling those voids and becomes problematic. Preteens were more reluctant, taking the wait and see approach, wanting to watch others vaccinate first, and that body size and age matters. This is what they were hearing from their parents, and also a significant portion of families not perceiving the risk really that serious, that it was manageable, and that vaccinating children, if that signal comes through down the road, that's mostly for protecting others. I do have here, so adolescents learn from their teachers and parents, from observations who are beginning to be vaccinated. That was already happening in the last few weeks. And then they have the typical questions about, like everyone, like safety and how effective it is, and the transparency of testing, development, and ingredients. So these, to some extent, there's some of what I heard seemed to be regurgitation of some misinformation online, and others is genuine questions that need to be answered. And not all families have access to readily accessible and available information. So people did also, by and large, the perceived risk of COVID-19 is also very much a social mediated risk experience that shapes their perception of its severity. It can go in both ways, as far as it is shaped by your family and whether they get sick and how sick they get, or your family friend networks, as well as the teachers you get and what they share about side effects from vaccinating. There's a little bit of a false comparison or a false choice, because children and adults compare the fear of side effects with the default is just not vaccinating. It's often not compared with the possibility of acquiring severe COVID-19. So some did mention credible sources of information like the CDC and the World Health Organization, and others did mention social media, with the caveat that many did qualify that, saying they know that there's misinformation on social media. So, the 30 and under crowd, they do turn, their mainstream source is social media, but they are quite savvy and realize that comes with caveats. So there were also some interesting cases of adolescents and parents having very different vaccine attitudes. So that will be interesting to see how that plays out, depending on how schools respond. Parent views were, again, more confident with their older children in high school. Again, the current emergency authorized vaccines have included 16-year-olds and older in their clinical trials, and 16-year-olds and older their immune system will be more similar to young adults or adults included in the clinical trial as far as predicting immune responses, although we know that there are a complex array of factors that ultimately shape an immune response in each individual. So parents were not surprisingly less confident about vaccinating preteens. Their perceptions of how their children's bodies would handle vaccination and the immune response had to do with also, the size of their children. If they were bigger and older, that they could handle the immune response more, and reasons parents would vaccinate their children was so that they could return to school, although it's highly unlikely that mandating vaccines will not occur anytime soon. But this is, of course, one of many key tools to bring us back to a new normal. And other reasons parents would vaccinate their children was a high perception of getting COVID and that it would be severe. Confidence in the science to protect, and also to protect children with chronic conditions, as well as others readily admitted they wouldn't do it unless it was mandated by their school. Other parents felt that the risk of COVID-19 was manageable, and they didn't really see it. They had already witnessed it in their household and didn't perceive it as severe. That there was a lack of data. They wanted to see more data on side effects and had turned to natural remedies. Also the notion that natural immunity is just as good as vaccine immunity, which in this particular case is actually not the case. So this is where we're getting a pulse on parents. This is one slide I'm sharing from actually a separate study on automatically, these are the top misinformation topics for about the COVID-19 vaccine, with the blue bar being actually the amount of agreement with misinformation. So if there's, and I apologize. I think when I copied this, we lost some of the examples here. I apologize. I'm going to have to fix that when we circulate our slides. But the blue bar is actually the amount of that the misinformation was not debunked, and the red bars reflect countering misinformation. The gray bars reflect not really having a stance, and the black bars means it's not relevant. So, and I'm going to have to fix this slide. I just wanted to share there is a wealth of misinformation circulating online, and we are in a very unique project with computer science, working on automatically detecting linguistic expressions of vaccine hesitancy, and countering that with accurate information through a variety of different inoculation strategies. There is actually the same metaphor of inoculation used in social science to warn people with messages of misinformation that prepares them for rejecting misinformation and not, so that's a separate project. I just wanted to share a snippet of that. Overall, we see that we do know that vaccinating children will be a necessary strategy as part of a larger strategy to reach herd immunity. And that overall, by and large, at least for the 46 families that we sampled, they view vaccination as beneficial, which is a good thing. It builds confidence in that. And that they do, however, many parents will be seeking reassurance from their doctors. They're hesitant, but they want to be walked off the ledge, so to speak. They want signals of confidence. And I think that, so a lot of people are getting vaccinated now outside of the traditional pediatric setting. They are going to pharmacies, which are busy. And so I do think that a consent discussion will be important with families who are vaccinating their children down the line. This will be coming by the end of summer. Again, it won't be mandated. It will be possibly, what's the word, implemented in a staged phase by having older adolescents be vaccinated first. We'll have to see the clinical trial results coming out in June. There is a lot of confidence that those results will be positive for the 11 to 17-year-olds. There are actually current trials also for younger children. So again, I think consent discussions will be very important. It will be challenging in the pharmacy setting. And also what hasn't really been talked about so much is how to optimize the vaccine experience. There are, there's a number of variables that shape the immune response: age, gender, genetics, sleep, our cortisol levels in the morning versus the evening. And so I haven't heard as much discussion about how to, again, optimize the experience of vaccinating for positive outcomes. Mandatory vaccination will likely not occur at this time. A lot of parents were concerned about that. And investment in community and school education about this is definitely warranted. Continued investment because families want to they're craving being informed. And if we have information vacuums, that leads to being filled by misinformation. So we're going to need to invest in education efforts through a variety of formats and through trusted community members. So to get that information to all of our different communities and families. So I'm going to leave it at that. Again, this is just finishing. This is where we haven't really processed all the data yet, but when we have, it's kind of unique because there have been sort of parent surveys in the last 6 months, but there actually haven't been studies looking at the parent adolescent dyads. And the science is kind of rolling out as we speak. And I think a lot of families are craving the information. So that's what I have to share for today.
Great. Thank you so much for just a really timely topic and very important research. And it's fortunate that we're able to get sort of an early look at what you're finding. So we have a couple of questions. And I think the first question is...
Yeah, I can stop sharing. Yeah. Or should I keep my screen up?
No, I think it's fine the way you have it now. So I think the first question pertains
Somebody
to...
wants to see a slide.
Right. So I think the first question pertains to vaccine denial. So we see a lot, especially in social media. I think these voices of vaccine denial are elevated, and and it almost seems like it's so common that this kind of anti-vax sentiment is so prevalent. But it sounds like you're not seeing that much, at least in your study. And can you speak a little to your experience with perhaps people who may hold those complete vaccine denial types of views?
Yeah, so there were families in our discussions who readily shared with us that their networks are by and large vaccine deniers, and that shaped their opinions. They were clearly more skeptical of everything, of the process of developing the vaccine, the ingredients in the vaccine. And so, we are developing, we're generating actually a list of all the questions that are emerging on social media, because in the end, there's kind of a recycling of a certain group of questions. So we will be generating those questions and also developing answers to those questions. There are a lot. Also, UCI on a weekly basis tries to offer frequently asked questions. So I would say there's different groups of people and families, and there are people who will be very skeptical, and we may never be able to have conversations about, about what are all the variables that shape immune responses, and everybody's entitled to their vaccine attitudes. But there's a whole range of people who are in the middle, who are unsure. And, we call this vaccine hesitancy. Now there's been lately, vaccine deliberations. There is a complex array of reasons for vaccine hesitancy in the middle. And I think, so there'll be ways of segmenting that, and there's kind of a constellation of reasons. There's usually not just one reason why someone is unsure. It's often kind of a clustering of different reasons, and we need to do better. I think today, in the age of vaccine literacy, the onus is also on the information delivery people and systems to deliver clear, concise messaging that addresses these complex clustering of factors. And I think we need to continue doing that, and that we can, if we do that we can shift some attitudes. There's a lot of families that really are just unsure and want their questions answered. So those are the people that we should aim to reach. I think it's a competition in the message environment about reaching people with accurate, helpful information, and how to deliver that in a meaningful way that's meaningful for families. There's a whole range of also the way people receive information. Some people want things very all the science, but other people, there's norms, normative behavior, there's social experiences that shape their risk perceptions, which ultimately drive their vaccine behaviors. And so normalizing vaccination and so it's not always an information deficit approach, although it needs to be that, but it's also about normalizing vaccination behavior and coming and institutional signaling from multiple places, from school and from healthcare workers and from all these different sources, to bring confidence to the signal about when that vaccinating is safe, or what we don't and what we do know. So how families make decisions under high uncertainty is just very complex and all over the place. So we have to deliver messaging that reduces that uncertainty, and then we could hopefully bring confidence to all those in the middle.
I think that ties well with our last question, which is about, what are some factors that are positively associated with kind of, like you said, kind of moving some of these groups towards, higher acceptance of vaccines. What are some of, I wonder if you can, and I think you've touched on this throughout your talk and through the Q&A session as well, but maybe if you can give perhaps one, concrete example of something that can be done that has been shown to be effective in, kind of improving vaccine acceptance or confidence.
Yeah, I was surprised by the older adolescents of the 46 families we've interviewed, the adolescents were quite knowledgeable. The ones who had received these educational webinars through their schools, and schools are trusted, that really had a very positive impact. I was surprised at how much they knew. And there was in contrast to other schools where the kids said, oh, that's not discussed at our school, that's a political issue. So I was also taken aback that was even mentioned. And they didn't know as much. And I think when there's this black box, that creates more doubt. And in this case, the high school kids and the middle school kids who had been exposed to these educational webinars with experts and doctors, coupled with witnessing their parents and grandparents and their teachers be vaccinated and share that experience with them, was actually building their confidence. So some of them have really shared how it turned around, how last summer they were very hesitant, and now in February, that the information they're receiving is really building their confidence, that they've really come around. So that gives me hope. And I think we need to continue sharing, being transparent about what's known and isn't, and also talking a little bit more about optimizing the vaccination analysis through and being aware, being aware of the multiple factors that shape an immune response.
Great, thank you. And thanks again for taking out your time to present really, not even hot off the press, just hot off the computer results from your findings. So fantastic, thank you. So I think with that, we're running a few minutes late, but I think we're doing pretty good in time. So I would say that we take a break. So we have a scheduled break right now for 10 minutes. So if we can come back at 10:55, and we can move on with our next speaker, who is Dean Bodenal-Bala. So please feel free to take I guess it's a 9-minute break now, and then we'll come back at 10:55 for our next talk. Okay, everybody, so we're coming back, and we're going to start the second half of the morning session. But before we do, I just want to remind everybody to please place your questions on the Q&A box to the bottom right of your screen, just throughout the talk, and I will try to get to your questions as best as I can. And also a reminder that this entire day, that all the sessions are being recorded, and they will be posted, and we will send out the link when the posting is available. So with that, I'd like to introduce our next speaker. Our next speaker is Dean Bernadette Bodenal-Bala, who is the director and founding dean of the program in public health. And she is also a professor in the Department of Health Society and Behavior and the Department of Neurology in the School of Medicine. Dean Bodenal-Bala is an internationally recognized expert in the social epidemiology of stroke and cardiovascular disease. So with that, Dean Bodenal-Bala, if you can go ahead and unmute your mic. We can see your slides, but did you?
Can you hear me?
Yes, we can hear you, and I see that your camera is on, so it's all you.
Oh, perfect. Thank you. Really honored to be here. I can't believe It's been a year, and I was thinking about, we were talking before before the symposium, talking with a number of the speakers and thinking about how we all got to know each other a lot over this year. And I'm thinking, you know, life just has a very weird way of taking you in directions you never thought you were going to go. I was trained early on in tropical medicine and infectious disease epidemiology, but my life trajectory really moved to doing a lot of work in chronic illness, including stroke and cardiovascular disease. And of course, I've always loved infectious disease and come here to University California, Irvine to really try to build a public health program. And 6 months later, COVID happens. And I have to say, you know, it's a terrible disease, but from an academic research perspective, I've been excited to be part of this. I think all of us have, in terms of really trying to move, you know, to move us, the science, in the right direction, in terms of preparedness, in terms of hesitancy, just really in terms of a whole systems thinking in terms of COVID. So today I really want to talk about some of the work that myself and others in public health and really beyond, again, it takes a village, it takes a community but I want to talk about some of our work in really using serological surveillance to understand the burden of COVID-19, especially really focused on communities of color. And, you know, probably as early as February, but I would definitely say as early as April of 2020, you know, we, the group here, all started really talking about, you know, who really has been exposed to SARS. And we were all taking bets. Some of us said, well, you know, we think it's been around even earlier. You know, a lot of us felt we all had already had, you know, COVID. And we just had no really good sense of what was going on out there nationally and certainly here in Orange County. We knew that we had small but growing numbers, and that we knew that probably underestimated the total number of infections. And we weren't even talking about vaccines, really. They were very much down the road. And so we really said, how can we address this issue? You know, is asymptomatic a large contributor to this problem? Is it really that COVID is just a very bad disease and you get symptoms and that's it? There was very limited testing capacity, few routine population-based studies at the time across the United States. There was definitely heterogeneous access to testing. Talked about symptoms, and that there was, you know, this differential even in thinking about symptoms. People with symptoms or with minor symptoms really less likely to seek care. And then the data that was out there, the surveillance studies that were out there, a lot of them were using serological assays with insufficient specificity. There was potential in sampling bias. You know, my good friends in LA County, you know, for the entire county, sampled 700 people. And so we were worried about sampling bias and variability in the performance, again, of some of these assays. And so the first thing we did was we worked with Orange County Healthcare Agency, and we said to them, don't you guys want to know? Because we want to know what the seroprevalence of SARS-CoV-2 looks like in Orange County. And with the help of folks from, including Phil Feldner, who's going to present today, you know, we have this great assay. It's not, you know, EUA approved, but it's this great assay that we think is really going to give us a really strong sense of sort of the overall immunological responses to COVID. And of course, Orange County is a great place to do this kind of work because it's large and ethnically diverse, 34% Latinx, 23% or so Asian, and 4% Black. So the sixth most populous county in the United States. And one of the earliest cases, if you will remember, of COVID was here. And we started to see early on, but we did shelter in place, this rapidly accumulating positivity rate, despite, of course, individual and community-wide mandates. And so in partnership with Orange County, we conducted this first surveillance study. And we did this over the summer of 2020. And the thing about surveillance studies is, you know, that all the work is doing it, and then you get these few numbers and that's it. And it seems very anticlimactic, but I'm going to tell you a little bit about the kind of methodology. So we worked with a direct marketing firm, and we used a sampling methodology, which was very similar to a random digit dialing, random digit email technique, looking at Orange County residents only. And we set quotas because we really wanted to make sure that we had adequate distribution of participants by age, by gender, by race, ethnicity, and by income. There would be an email or a phone survey that, again, was a randomly generated number, and then there would be a survey, and there would not be and conducted before an initial disclosure of an antibody test, because at that time there were a lot of people that wanted to get tested, and there wasn't a lot of testing capability. And we didn't know really for the general public, other than for surveillance, what you would do with an antibody test. And it's still unclear, although better now. And so we randomly recruited. We had 11 drive-through sites staffed by UCI students, public health students, medical students, nursing students, around all of Orange County, students and alum. And we used finger sticks, again, courtesy of UCI's Vaccine Research and Development Center. And the nice part about this kind of an antibody test, as opposed to a full blood draw, it really was a finger stick prick, and that really made it very accessible. And so what did we find? So we sampled, we actually spoke to over 5,000 people, and we offered antibody testing. We ended up with close to 3,000 people who actually arrived. We had more scheduled, but who didn't arrive. And then again, over really 5 weeks, in the summer of 2020. And you can see overall a very good age distribution of adults. You could see a reasonably good distribution of by gender, by race, ethnicity, very characteristic of the county at large. We asked questions about household income. We asked questions about whether or not anyone suspected or confirmed of COVID-19, if they had contact with, or if they had had symptoms. And you can see the seroprevalence numbers on this table, and basically an adjusted seroprevalence for SARS-CoV-2 infection rate of about 11.5, rounding it up to about 12% for Orange County by the end of the summer. And if you remember, we went through a small, we thought was going to be a surge, but we flattened that curve. And then in July and August, we had really a little bit more of a surge, not the full surge we had in January, but certainly a surge. And so this antibody seroprevalence reflects sort of those two up curves and then the lulls in between. And what's important, though, is that not only is this a significant prevalence, most of the prevalence rates that had been reported only a few months prior were really down in 2%, 3%, and 4%. This prevalence was really elevated among Latinx populations and among low income households, again, really confirming that this is a disease of disparities. And you can just see here, again, just a few more of the results. And this is looking at the prevalence ratio with 95% confidence intervals, that we really don't see any difference in seroprevalence by age, nothing significant by gender, but certainly real significance by race, ethnicity, with Latinx having the highest seroprevalence, followed by Asians, followed by really whites. We have very few very few Blacks in the community, and so we really couldn't look at them separately. And then household income, certainly under 50,000, but even in the 50 to 99,000 household income per year category, there's a significant increased prevalence ratio, 2.2 prevalence ratio, significant among those with suspected or people who've had contact with those suspected or confirmed of COVID, and even almost a 2 prevalence ratio of those that had reported SARS-CoV-2 symptoms in the last 2 months. So some interesting data there. And so, you know, we publicized this data, and really importantly, we used this data, which was very county-wide, to really work with community organizations to really, and of course the Orange County Healthcare Agency, to really look at, you know, what was going on, what this meant in terms of coverage, and significantly that there were a large proportion of the population of Orange County that had antibodies that we didn't have documented in terms of our positivity rates. This type of conversation on this ACT-OC, this first seroprevalence study, really leads to then conversations with communities who really are experiencing the greatest risk, Latinx communities, and a community like Santa Ana. And so in October of 2020, the mayor of Santa Ana approaches UCI Public Health, again, after ACT-OC, and we know Santa Ana is one of the most diverse cities in Orange County, about 77% Latinx, 11% Asian, and about 9% non-Hispanic white. Over 1/3 of the city's residents self-reports not speaking English very well. So we have English, Spanish, Vietnamese, and other Asian and Pacific Islander languages in the community. Of note, it is extremely densely populated with an average of 4.3 persons per household. And this community has been and continues to be disproportionately burdened by COVID-19. And so we are then asked to come in and do a seroprevalence study for the community to really understand the cumulative incidence of both symptomatic and asymptomatic COVID in Santa Ana, to describe infected individuals based on geography and demographics, and then to really develop a predictive model for COVID-19 antibody positivity. And so we begin to do this. And what's really interesting about this, more so than ACT-OC, is this is a really very much a community participatory methodology. We have a very sort of standard sampling frame. And so we're going to sample random households, and we're sampling households here and not just individuals across the 44 census tracts of Santa Ana, which have at least 50% coverage within the Santa Ana city limits. And we sample within that then 54 census blocks. And we partner with Latino Health Access and Santa Ana United School District to really work on outreach to our Spanish-speaking community, to our Vietnamese community. And we have a series of sort of informational blasts, mailing postcards, hiring community health workers to go and knock door to door and invite folks within these 54 census blocks into this study. And we identify 3 schools to serve as active COVID-19 drive-through and walk-through testing sites. And they are staffed by UCI students, UCI, as well as community health workers. And that's the Santa Ana High School, Valley High School, and Saddleback High School. And we want to be able to have community folks from these census tracts, you know, really to be able to walk or drive in and have this testing done. Blood collection, again, is done through the microarray technology, and then participants are mailed individually, not by household, but individually within 2 to 3 weeks of the visit. And one of the things of interest is that we did households, and so we did ages 5 and up. And so we, for this study that was done in 3 weeks in December, as of course we were surging, we ended up with 18 residents who participated. And among those, that was 2178 households. The race ethnic distribution is similar to the city census breakdown. The overall prevalence of antibody prevalence in the community is about 27%. You can see among children, 28% of children between 5 and 17 were reactive. For no difference by gender, about 28%. For female, 25% male. The adult population over 18, 26% were seropositive. And then by race ethnicity, 29% of the Latinx population, about 15% of the Asian, 12% of the white, and 6% other non-Hispanic. And we had a very, and this is then seropositivity. And I have to say, for ACT-OC, Tim Bruckner really was pivotal in working on that study. Dan Parker as well, and Dan Parker does wonderful work in GIS, and here's the seropositivity by zip code. So it's not just Santa Ana, but certainly there are zip codes which are really sort of hot zones within Santa Ana, and of note that these are the most densely populated census tracts with large households and low per capita income. And again, this seroprevalence is really just adding to this whole, COVID being a disease of disparities. And we can talk a little bit more about that. Just wanted to share some other things that came out of the Santa Ana study. And so we asked about symptoms at any point, as we did with ACT-OC, between March and November of 2020, and also had, of course, present positivity for antibodies. And so of really note here, and we could talk about all of these tables a lot, and I know we have to watch time, but of note here, of the overall sample, 29% of the sample reported having some symptoms, of which about half of those reporting symptoms actually were reactive. And then this just goes down to how many were positive. And so of that sample who had a test for COVID, about 9% were positive. And then what I think is really interesting is the proportion of participants testing positive for antibodies by month of positive COVID-19 test. And so what's interesting here is that we're capturing the antibodies obviously in December, and we're getting from these participants, if they tested positive, when they tested positive. And so this is really interesting because we're now looking at antibodies almost 9-10 months after people are reporting positivity, and you can see the proportion of folks that are testing positive with antibodies having a positive test over the months. And so it doesn't really look like there's a huge drop in antibody, in sort of that immunological profile, even if you go back 8-9 months. So one of the interesting things, we asked a lot of socio-demographic questions of interest to everyone, I think, has been this whole focus on occupation, on essential workers. And so we've been talking since early April about, why is it, everyone's sheltering in place. Why are these communities still having, really horrifically high positivity rates? And it's this essential worker, non-essential worker. So everybody who could stay home and shelter in place was really less likely to be exposed. Everybody who had to be out there in an essential worker role really had this exposure. And of course, the essential workers are living in dense households, in densely populated communities, which of course for viral spread, transmission of the nature of COVID is just very easy for there to be really significant viral spread. So interesting, half of the adult study population reported working mostly outside the home since March of 2020. Only about 18% were able to work from home. Another, though, interesting of the whole population, 32% reported they didn't work at all. And what we did find was that if you worked outside the home or you were not working, you had, your seroprevalence rates were close to 30%. If you were working from home, your seroprevalence rates were about 16%. And so who are those people that are not working at all? The only thing we were able to really find about them was that they were largely older females. And we're wondering, of course, if that then reflects this grandmother or third generation household member. And so we could talk a little bit more about that. It's interesting. And then we looked at work sector by essential workers, and certainly healthcare, food, and critical manufacturing of essential really had high antibody prevalence. Education, lower antibody prevalence, but a lot of educators were able to work from home. And then this is just all of the occupations that we used a validated a survey to look at occupational status, and then this just looks at non-reactive to reactive. There's this huge group of people who don't identify themselves as being in any of these occupational categories, and they actually and in other categories, and so we're assuming that these are sort of in babysitting and sort of parallel economy type jobs, and we need to do more work on that. One thing that's interesting but complex is this whole issue of school and school attendance, and so we enrolled 389 children between the ages of 5 and 17, and we found that, and we asked 3 questions, which I think are confusing. I'll admit it. Were they currently going to school or daycare? Were they not currently going to school or daycare, but in sort of a virtual school, but they had previously been? So they've made this switch. And then not currently or ever in school daycare. And these came from other questions that people asked really more about homeschooling. And so interestingly, we find among those who are currently in school or daycare, and remember, we did not have a lot of school or daycares open, but we had some open. So there's a bias as to who would go to them, that we find this seroprevalence of about 29% in those in, so they're leaving the house. Among those that were staying in the house, about 15% seroprevalence. But then in this not currently or ever in school daycare, a very, very high, but very small number. And I'm not sure, again, who they are. And this is that sort of same group of who are those people who are not working. And why do they have high seroprevalence rates as well? We also asked about health behaviors, and I'm not going to go through this, but only to really say that about 59, maybe 60% of people in the community overall report wearing masks when they are outside and could not maintain social distancing. Everybody is hand washing, which is great. About 15, 16% of people are still attending large social events. And I think almost everybody was masking. 93% were able to get masks and wear masks. And we don't really find huge differences in terms of reactivity, which is something we could talk about. And so finally,
sorry, Dean Boldenau, I just want to let you know this may be 1 minute.
Yeah, I'm just going to end perfect. This is exactly where I want to end, with this predictive model that we put together for COVID-19 antibody positivity. And again, really just to bring your attention to model 3. And I think that that's really the important one. So we know that you are significantly more likely to be COVID-19 antibody positive if you were Latinx, if you were working outside the home versus working in the home, if you were not working versus working at home. And then the very interesting thing, again, in model 3 is there was a 9% increase in being antibody positive for each additional member of the household. And so I'm going to end, not with this, don't even look, I'm going to end with, I'm just going to end with a thank you. Just wanted to thank the, every member of the COVID surveillance teams. Again, Tim Bruckner, Daniel Parker, Emily Drum, who managed to set up and do all the operations, and all of the other students and everybody else that really helped with this. Thank you very much.
Thank you so much for that talk. Just a really striking data that you're showing, and extremely relevant, obviously, to the local epidemiology. So I did have a question, and I think it probably may be related to the final slide that you did not get to show, but I wonder if you can talk a little bit about, I think so much of the higher prevalence appears to be among those who are working in positions where social distancing may be very difficult, and some of these, public health messages about mask use, 6 feet distance, and all of that, and then staying away from other people. And of course, one of the main ways to protect oneself is to not be in indoor setting with people outside of your family. And clearly, some of these occupations you're not able to abide by those recommendations. So I wonder if you can talk a little bit about sort of what are public health implications, and especially kind of looking forward in time to perhaps measures that we can advocate for to prevent COVID-19 spread in these populations.
Yeah, I think that's a really great point. And yes, I was going to try and talk about, a couple of things happened. We put this shelter in place policy, which worked well for everybody who had the ability to stay at home, and in homes that where everybody was staying at home. But the situation in Santa Ana, and I'm sure in other communities around the country, was dense population, not everybody staying at home. People are coming in and out. And when you're in the home, it's almost impossible to wear a mask, to really stay away and socially distance. And so you're ending up with this perpetuation of viral spread. And, early on in the epidemic, we worked with Latino Health Access and other community organizations to really think about, if somebody was symptomatic or COVID positive, could we get them out? Could we put them in some place so that everyone else in the households could be protected? But I think there's greater issues here. Is it right to separate out families, and not everybody will do that. So I think it's a challenge that I think we have to address. The density plus essential worker challenge. We've got to figure out a way to have good public health policy in place, and to really make sure that we don't have this problem next time we end up with a pandemic like this.
Again, thank you so much for your talk. So I'm going to go ahead and introduce our next speaker. And our next speaker is Dr. Carlo Butts. He's a professor at the Institute for Mathematical Behavioral Sciences, and also the Department of Sociology, Statistics, and Electrical Engineering and Computer Science. And also the Institute, also the founding director of the UCI Center for Networks and Relational Analysis. Dr. Butts is the PI of the Networks Computation and Social Dynamics Lab, and his research involves the development and application of mathematical, computational, and statistical techniques in the areas of social and biological network analysis, mathematical sociology, and quantitative methodology. So with that, I will turn it over to you, Carter. Thank you.
All right, thank you. Let me get the slides up here. All right. Well, I want to thank the organizers and of course all of you who are tuning in today and for the panel. What I'm going to do today is share some stuff that I, my group, and my collaborators have been doing over the last year using networks to look at COVID-19. And of course, if we, since the theme today is looking back over the past year, if we bring ourselves back to March of last year, where were we? Well, of course, we were at a situation like was shown here on the right in this graph from The Economist, looking at what was clearly at that time a very serious emerging pandemic with a potential for incredible harm. And indeed, I think even currently estimates are consistent with the idea that if we hadn't put mitigation and measures in place and we didn't have vaccines on the line, we would be looking at even more massive mortality than we've had. We've of course lost 500,000 people in the U.S. so far, but we could have been looking at 3 million or more deaths in the U.S. and just enormous losses. And so in the face of that, what we, like many groups, tried to do is ask, is there something that we can do that might be helpful? And our expertise is primarily in modeling and network analysis. And so we wound up launching 3 different projects in the area. And I'm going to summarize a bit of what we learned in each of these today. One, looking at the diffusion of SARS-CoV-2 itself through contact networks. And using some things that we know about contact networks to look at get some insights into that. Then we also have looked at information spread through networks, particularly looking at information by public agencies that are trying to respond to the event and tell the public how they can be safer. And then finally, we teamed up with a number of folks in chemistry and biochemistry to try to contribute to efforts to find inhibitors for the SARS-CoV-2 Mpro, and I'll talk a little about that as well. So today I'll provide some highlights from some of the things that we learned that may inform both the rest of this pandemic and also pandemics to come. So I'm going to start with this first point of diffusion, and of course that's something that we and many other groups study. And of course, it's an enormous problem in any emerging epidemic or pandemic is trying to figure out where the thing is going to go, and you can't do anything useful if you can't do that. And so obviously you need to do forecasting, but you also need modeling that will let you, after the fact, figure out what's going on so that you can assess interventions and the like. And it was very apparent from the very beginning that the dominant tool that was being used here, which is not surprising, it's the dominant tool in workhorse tool in most epidemiology, was use of compartment models. And so these are models that look like what you see on the right. So this is a very simple example of one, something called an SEI-R model. But what they are is they're systems of differential equations where you kind of put people in little bins or compartments, and then there's people move from one bin to another at a steady rate based on the dynamics of the system. And there are ways to elaborate these. You can have lots of compartments. People split them up by gender, by race, by age, and so forth. But at the end of the day, you fundamentally are still dealing with the system of kind of big bins and people moving back and forth. This is a very powerful framework. It's very simple. It's very computationally tractable. It's fairly intuitive. It's extremely powerful. People use it because indeed it's really useful, but it has some limitations. And one limitation that we were particularly concerned about is that these models are very homogeneous, right? They assume that when you have contacts between the compartments, those contacts are very even, and the probability of yours, say, getting infected by somebody in another group is just a constant probability. And the problem is that we knew from work that we've done on the structure of contact networks that real networks don't look like that, and cities in particular are not compartments. So in the real world, social contacts are not well mixed. We're not equally likely to interact with everyone, and indeed, even if you break things down by demographics, we're still extremely unlikely to interact with most people. And indeed, the dominant factor that structures who we interact with is geography. And because people are very, very unequally distributed in space at all scales, you wind up with very strong inhomogeneities in human contact networks. And so here's an illustration from some work we did many years ago on the right. This is a model from Portland, Oregon, looking at an estimated contact network there, and a diffusion process. And at that time, we were looking at information diffusion. But here I've colored the nodes, the individuals in the network, by when a particular piece of information would be likely to reach them. And you can see there's kind of a lot of staticky stuff everywhere, right? The information goes all over the place in a very patchy way. And that's not just true of information, right? Other things that spread over a contact network often have that kind of property. And so we were concerned about the implication of that for COVID, because of course we could observe that the models people were using assumed very homogeneous mixing. And we knew that that was likely to result in an overestimation of how homogeneous the transmission would be at the local level. And so to try to see if we could find some insights for this, we developed a modeling project. And so this was work that my group did with John Hipp and Zach Almquist's groups. And I should mention in particular, Loring Thomas has done a lot of students, and my group has done a lot of the key efforts here. And so what we did was we built detailed, that is individual level network simulations for 19 US cities based on realistic models of geographical interaction. We put a realistic epidemiological model on top of that and asked the basic question that if you had nothing going on, but just the basic COVID epidemiology and the basic network structure. So if we strip away all of the other complexities of the real world, we take out masking, we mitigation, we take out social distancing, we take out all the other things, and we say, if you had nothing else going on, so it's as clean and beautiful and homogeneous a world as you'll ever get, do you see something that looks like what the models assume, or do you see something that looks much lumpier? And the answer is you see something very lumpy. So this inset plot on the right gives you an example. So here is an example of one set of trajectories from Washington, D.C. And each of these little curves here you can see is the pandemic prevalence within a particular tract. And so you can see that rather than have some nice smooth curve, you have a whole lot of little outbreaks, and those outbreaks can be very aggressively spaced in time. So that even when the pandemic is winding down, even a year or more into the pandemic, you can still get local outbreaks, and you can have communities that haven't been hit, and they haven't been hit, and they haven't been hit for months, and then one day their time comes. And so this is something that's really important if we want to understand what goes on in a disease like this, and that even if you did not have, and we do, of course, other things that can intervene to create disparities in timing and outcome, you're going to get them, and very large ones, just from the fact that the networks that these things flow through are not homogeneous. We can see that further if we zoom in a little bit. So here's a spatial representation and also comparative analysis across cities. So here on the right, I'm showing peak infection days by tract for the cities that we looked at. And you can see there's an enormous variation here by tract and by city. And so again, it's possible that some tracts get it very fast, very early. Others may go for very long periods of time without many cases, and then again one day they suddenly get an outbreak. And even tracts that are very close to each other can have different outcomes. So here we see an example from two illustrative trajectories, in this case in Seattle and DC. And we can see here again that even though there is spatial autocorrelation, you have communities that may be very close to others, and they see very different kinds of outcomes. So again, this is important in that if we want to understand what's going on, we look out in the world and we see these inhomogeneities, which we do. We need to immediately recognize that some of that is something that we would expect to see anyway, just because of the way the process of diffusion works. And so we shouldn't, for instance, first of all, immediately jump to conclusions that because, say, one area currently has higher prevalence than another, then that means that people in one area are behaving differently. That may be true, but it doesn't necessarily have to be true. But it also means, right, that people are going to have very different experiences of the pandemic. And if we want to communicate with them about, for instance, mitigation measures, then we need to be aware of the fact that people will have seen very different things in their communities, and that may shape how they react to us and we tell them. And to get further at that, another thing we've done is tried to look at social exposure. And so here we're not looking just at who gets the disease, but who has contact with someone who has the disease or who has died from the disease. And indeed, in some communities, what you see is, you have people, you have communities where very rapidly, almost everyone is going to know someone who's had the illness or sadly who may have died from it, or many people may know someone who has died from it. In other communities, though, you can go very long periods of time without very many people knowing anyone or having direct contact with people who've had the disease. And this is really important if you want to help change people's behavior, because one of the things, of course, that we've observed in the pandemic many people have been very resistant to public health measures, and indeed some even claiming that this entire virus is a hoax, that the thing isn't real. And of course, there are many things that go into that. There's political polarization, there's education, there's a lot of factors that people focus on. But one factor that people have not focused on perhaps as much is that people really do have different experiences of the pandemic. So if I'm in a community where I don't see people who have the disease, I don't know people who have the disease, I'm going to be a lot more skeptical, presumably, than someone who's in a community where they see it all around them all the time. And so again, it's helpful to recognize that and recognize that that's an inevitable consequence of the way human networks work if we want to be able to be effective in responding in different communities. So those differences in where the disease hits and how fast, of course, affects how people react to the pandemic. It also affects their risk. And these differences can be quite dramatic. So here's an example here of an estimate of the enhancement in hazard of infection just due to a particular network characteristic, in this case in San Francisco. And you can see even down to the block level, there are really substantial differences depending on where you live and whether you're likely to be in a part of the network that's going to expose you to high risk of rapid infection versus something that's protective. And again, that's something that's on top of all the things we've talked about your occupation and other factors, your behavioral factors. They're just these baselines. So it's a bit like living in a floodplain, right? If you live in a floodplain, when the water rises, you're likely to get hit first. Whereas if you're in high ground, you're not as likely to get hit first. And one of the things that we know is that in the United States, there's enormous segregation of cities by certainly by race, and to some extent by ethnicity, and by age to a degree as well. And that means that some communities may indeed also be more likely to be in harm's way. But the way that plays out can be different in different communities. And so this is something we're looking at now to see how much of the basically kind of differential mortality risk you can explain simply by virtue of where people live. And in some communities, indeed, there are groups that do seem to be in harm's way, that we do see being harmed. Interestingly, in some communities, groups that may have negative outcomes in practice are actually being somewhat protected based on where they live. And so what that's telling us is that's telling us about the action of all those other things that contribute to health disparities. And of course, there are many, many things going into it. This is certainly not the whole thing by any stretch, but this is a potentially unrecognized source of risk. That's something that we may want to think about going forward. Now, of course, in all this work, we're talking about the virus moving through networks, but of course, that's not the only thing that moves through networks. Information moves through networks as well, and sometimes that information can be helpful. So if you're a public health agency and you're trying to alert people about what to do in the pandemic, you want to get your message out. And increasingly, public agencies that respond to disasters, including pandemics, use social media as a key tool to reach the public. And of course, social media is very powerful because it gives you a great way to amplify your message. You can put something out there, other people will pass it on to their peers, both online and offline. And that enhances the penetration of your message and the number of times people are exposed to it, which is important for getting people to act. The problem, though, is that in order for that to work, people have to pass your message on. So it's a bit like putting a message in a bottle and throwing it in the ocean. If you're lucky, it floats away and people wind up finding it. And if you're unlucky, it sinks to the bottom of the ocean, no one ever sees it. And so this raised the real question, what are the things that actually are drivers of message retransmission? And so this is something that we've been working with Janet Sutton's group at Albany looking at. And also, I mentioned a lot of the work on this is done by Scott Renshaw in my group as well. What we've been doing is an ongoing study of about 700 public agency Twitter accounts, looking at the style, content, and structure of messages and the factors that drive retransmission, as well as the ways the public agencies are using social media to communicate. So if we go back to the beginning, the pandemic, we can look at the ramp up by public health and other agencies. So here we're looking at one measure of the attention that the agencies are paying, and this has to do with the extent to which they are focusing hashtag activity, which is something they use to flag things on COVID per se. And you can see that at the beginning of the pandemic, there's really not a lot of action. So most of the messaging they're doing is not really COVID related. But in early March, they begin to sort of take notice. And of course, once there's the presidential disaster declaration, all of a sudden, agencies across the country start to pivot and focus really aggressively on the pandemic. At first, focusing on trying to tell people what they can do to stay safe, then trying to build norms around things like masking and distancing. And then finally, they started switching more to dealing with the secondary impacts. So dealing with closures, How do people cope with the problems that are being created by the mitigation measures and shelter in place and so forth. So in that process, of course, they're communicating, 7 days a week, 24 hours a day. We get just to give a sense of what the raw communication volume looks like. Here are plots of the messages that are being posted by these organizations, broken down by the kind of organization. And as we'd expect, of course, public health is very active. Those organizations have a large voice and do a lot of messaging. But one thing I want to draw your attention to is that, especially on a per capita basis, the elected officials wind up becoming really critical. And so from March on, the electeds are really actively messaging. And that turns out to be really important because the elected officials not only do a lot of messaging, but as we'll see in a minute, people pay a lot of attention to what they say. So if you really want to get people engaged and keep them paying attention to what's going on, you've really got to get the electeds on board. Now that raises the question, what is it that cuts through the noise? What is it that gets to people? And so to look at that, we've done some work on modeling the retransmission of messages that are posted to Twitter. And so here, what I'm going to show today is from a study we did that looks at all messages from our sample, which you can see the distribution of the sample on the right, through August. So it's about 400,000 messages. We code the properties of the messages, the features of the context in which the messages are sent, and the counts and so forth, and then use models to identify what are the factors that separate those things that do go on and get passed on from things that don't. And so these are just a few highlights from the many things that go into that model. So here I'm just showing you regression coefficient. So a larger number means that it enhances retransmission. Negative number means that it tends to suppress it relative to baseline. And so the first thing we might ask is, well, do we see signs of temporality here? Do we see COVID fatigue as people are interested in that? And indeed, we do. So public attention, not shockingly, shot up after the presidential disaster declaration, was very big in last March, but it began to ebb a bit, and it's been kind of at a lower level since then. We also looked at things like who is it that people listen to? Somewhere I alluded to the elected officials a minute ago. And indeed, one of the things that we see is that governors are huge. People really pass on messages from governors, to a lesser extent mayors. Very prominent public health agencies like the WHO also have some play. Baseline here, 0 is just standard public health agency, so that's our reference value. And those 4 emergency management accounts, the emergency management folks have been on this too the whole time, but unfortunately, people don't tend to pass their messages on so much. So in this context, people are really not looking to them. They're more looking to the health officials, but especially they're looking to their electeds to give them guidance. Now, what kinds of content do people care about? Well, in many disasters, people are fixated on certain kinds of content, but in this pandemic context, people are really hungry for information. And we find that, in fact, all sorts of information will enhance retransmission. There's a broad demand for content involving the pandemic itself, specific directions on what to do, information on major outbreaks and the like, policies and closures that affect people. On the other hand, sort of generic, like calls to action or resilience, things of that kind, pointers to briefings, these are things people don't care that much about. And if you put those in your messages, they ain't going anywhere. Now, one thing that, to zoom in on one thing that we've looked at that is pretty interesting, and it's something different from what we often find, or another thing that's different from what we often find, is we've looked at the content of images and how those affect retransmission. And there's kind of a conventional wisdom in public messaging on social media is that if you want them to go farther, stick an image on it and it gets people's attention, and that's going to get them to pass the message on. But that's not true here. One of the things that we find here is that if you just stick a message that doesn't have real content on it, and particularly doesn't have textual content on it, like these ones on the far left, it actually will slightly diminish the retweet rate. On average, it diminishes by about 10-12%. While messages that contain useful information, in fact, tend to go out farther. And interestingly, and this is not necessarily typical, we find that in the context of the pandemic, even agencies that are putting in things where they have kind of scans of documents, if the documents are things that really people care about, like closure information and the like, these things actually really will go viral. So the good news is there's a hunger for information by the public, and if you give people messages that are informative, they really will pass them on. But you do have to be aware of what you're putting out there, and if you just stick pretty pictures on things, it's not going to work in terms of getting the message out. Now, finally, in the last couple of minutes, I want to talk about a third project that we've been working on. And in this case, this is where we've joined forces with folks in chemistry and biochemistry to see if we could do something about the disease itself. And so in this work, what we're looking at with our colleagues is studying the structure and dynamic variation in the SARS-CoV-2 main protease, or MPRO. So what MPRO does is that when the virus invades your cells, it has to make a lot of proteins, if you like, sort of molecular tools that it uses to do its dirty work. And it does that by first getting your body to create a long sequence of amino acids. And then it needs these scissors to cut them into little functional units. And those scissors are MPRO. So if you can stop MPRO from working, you can stop the virus from replicating. And so it's an important target for therapeutics. So what we have done in conjunction with the Martin Lab is we've taken all of the clinically identified variants of MPRO, the mutants that have arisen in the population, and we've modeled each one. So we actually model them in explicit solvent. I'm using atomistic molecular dynamics. And then we use protein structure networks and other methods to analyze these trajectories to try to figure out things about how is the thing mutating, to inform the design of mutation-resistant inhibitors, and then also in work we're doing with the NOIC lab, try to understand more about how inhibitors that have been identified work. And so just to give you a flavor of some of this work, here's an example of how we go from a protein to a network. So here on the left, you can see this jiggly wiggly thing. That's the actual model of the molecule itself. In this case, this is zooming in on the active site. And then when we represent that as a network by taking chemical groups in the molecule and looking at which ones are in contact at a given time. And so then we can convert that sequence of 3D structures into a sequence of networks that are easier to analyze. And once we've done that, we can use various tools for network analysis, many of which were originally developed to study social networks, to get insight into the structure, dynamics, and evolution of MPRO. And so to give one example of something that we've looked at flexibility in the structure of the enzyme. And so here I'm showing the two chains that make up the functional dimer, so it's a homodimer of MPRO. And what I'm showing here are measures of flexibility in the structure, cohesion specifically. And at the top line, we have the total structure of the entire protein. And in the bottom, we've broken it down within each chain by the different domains. And one of the things that we can see is that overall, there's a lot of red here. And what that's telling you is that most of the mutants that have arisen, or a large fraction of them, have elements in the protein that are a lot looser than the wild type is. And so we've seen some evolution toward looser structure, but interestingly, that's only in the component parts. So the dimer itself is very conserved. And that tells us that the actually interdomain interface is acting to stabilize these increasingly loose monomeric components. And that gives us some insight into what's holding the protein together and things that might be useful targets for intervention. Of course, we look at the active site itself. That's also where the protein does its chemistry. So here I've zoomed in on a monomer, and in the left-hand side shown what the active site looks at. And what we do is we use what we call active site networks to actually look at the interactions among chemical groups in the active site, which allows us to see things about, for instance, are they heavily constrained and rigid, or do they have more freedom of action? These are things that have been linked to things like active site specificity. And so one of the things we do see is that there is some evidence toward mutants that seem to have somewhat looser active sites, but interestingly, they don't do it in both chains simultaneously. So they'll alternate conformations where one chain will be kind of looser and the other one more conventional, and they go back and forth. We've also used some machine learning methods to actually compare structure in active site conformations, both between monomers and dimers, and also across all the different variants. And so this is a kernel PCA, sort of showing the first two key dimensions in the structure. And you can see there are these sort of two lobes in the conformational space. And these are mostly driven by the presence or absence of this key cis-his interaction between in the catalytic dyad. So that's the main thing that separates the different conformations. And then within that, we see differences based on how many different chemical groups are interacting with the key catalytic residues, as well as overall kind of how much cohesion activity there is in the site. Having quantified that, we can now start to ask questions like, for instance, how much of what's going on is separating the protein in different states, how much has to do with the different mutations, and is that just an overall difference that, say, are there differences in conformation for a given mutant, whether it's monomeric or dimeric, and in the two different monomers in the dimer, or is it specific within, say, the A versus B dimer at any given moment in time? And so when we look at that, what we find is that indeed, there is some mutational difference, and interestingly, it's actually much bigger than the difference between the monomeric state and the dimeric state. And we know the dimeric state is much more active than the monomer. So that's telling us it's not that the active site is different. Okay, it has to do with other things about how the protein operates. But when we cross chain by mutation, we get about 23% variance explained. And that's telling us again that there is some real difference in those mutations, but they do seem to have to do with what one chain is doing at a time. So again, the chains alternate back and forth in the conformational states, and that gives us some clues about what we need to do going forward to find more effective inhibitors, and also to study the dynamics of the protein.
Sorry to interrupt, Dr. Butt, sorry to interrupt, but if we can finish in maybe 1 minute.
Well, that's excellent, because here we are at the end. So I'm going to do exactly that. So I want to wrap it up by again acknowledging both folks on the team who've done key work. So on the MPro work I just described, Liz Deeser and Xixia Zhang. On the diffusion work, particularly Loring Thomas, Peng Wang, in the Twitter work, Scott Renshaw, Sabrina Mai were key players on that, as well as our collaborators you see on the right, HIP group, Zach Almquist, the Sutton group, the Martin Lab, and the NOAC Lab. So that's a bit of a highlight of things that we've been up to and some of the things we've been finding so far. And I want to thank all of you for your attention, and I'll be happy to take questions later.
Thank you so much for a very wide-ranging presentation. So we do have a couple of minutes, and I do have a couple of questions. I think the one I thought, especially your first part of your presentation, focusing on integrating network structures into epidemiologic modeling was just phenomenal, and especially as there's been so much, as you mentioned, so much interest in epidemiologic modeling, and especially forecasting. Have you been able to kind of compare your model that does account for network structures versus other models that don't, and what are some of the main things that you're seeing, especially regarding projections that are coming out of these models?
Yeah, that's a great question. So first of all, I think it's important to recognize that we have lots of different uses of models, and so forecasting models have like very particular kinds of goals and particular structures. The ones that we're using are predominantly aimed toward trying to understand mechanisms and how different kinds of factors do or don't shape the pandemic. So we haven't tried to do forecasts per se. We can say things about what kinds of differences you would see if you use them for forecasting. But to do forecasting, you need very specific kinds of calibrations that of course these models aren't inclined to do. So I want to be just really clear that we're not doing that specific task at this time. But there are people working on adapting models like this to that type of role. The big thing that you're going to see definitely from our standpoint is, one, you're going to have a lot more irregularity. So I think you have to be, you're going to have a lot of uncertainty in predictions, because one of the things you see is that very small things can affect the dynamics, and you can get a community that hasn't really been hit, and one errant pi that takes infection to a community can suddenly result in localized outbreaks. That's one thing which I think the smooth models tend to underappreciate that, and so you should, whenever you look at the current models, you should put a much wider band on those predictions. And you probably notice, right, if you look at the statistics, you see how lumpy the statistics always look, and some of that is administrative, but some of that really does seem to be due to micro outbreaks, and people are seeing that as well. I think a more action item is that in order to do better forecasting, one of the things that we and others, folks like Martina Morris of University of Washington, has also called for is we need to be on an ongoing basis collecting more of the kinds of information that are needed to build these realistic network models, because when the pandemic strikes, it's very hard to get the data you need for forecasting applications, where you really need kind of high quality up-to-date information. And so we need more information on kind of contacts maintained over time to be able to do that more effectively. I think if we did that, we would be able to do a lot better at indicating kind of the uncertainties. I think especially that's where they're going to differ a lot. And then especially when you start getting to smaller scales, when you're at urban scales, especially where a lot of the rubber hits the road when you're talking about real on-the-ground epidemiology. A lot of our stuff, we were just hearing about the county level stuff in Orange County, and understanding the different conditions within even a county. I mean, a county is actually a very big place, so the city is a very big place, is really critical. And I think trying to do kind of micro forecasting, you're not ever going to be able to pinpoint exactly where things are going, but you can do things like evaluate where your risks are, the areas that are highest potential for outbreaks, and get better estimates of uncertainty. And that's something that can inform your planning choices, your triage decisions, and so forth. And I think that's something there's a lot of potential to do. But to do that, we really need to be focusing on some of these kind of discrete structure models alongside the traditional epidemiological models. So as I say, have a lot of value. I'm not saying no one should ever use them, but there are some things that those models are not doing that do matter a lot, especially when you get down to smaller scales.
Thank you again. So I think we'll go ahead and move on to our next speaker. So our next speaker is Dr. Elinda Ulloa, Dr. Elinda Chuli Ulloa, who is an assistant professor in the Department of Pediatrics. And she is also affiliated with microbiology and molecular genetics and a faculty member for program in medical education for the Latino community at the UC Irvine School of Medicine. She's also an attending physician at the Division of Infectious Diseases at Children's Hospital of Orange County. And Dr. Ulloa's laboratory investigates host-directed therapeutic strategies for the treatment of drug-resistant bacteria and difficult to treat infections. So thank you so much for being here, and I will go ahead and pass the baton to you. If you can turn on your camera if you are able to, and also unmute yourself, and it's all you.
Hi, good morning or good late morning. Can you all see my screen now, my slides?
Yes, we can, thank you.
Okay, wonderful. So good morning, everyone. My name is Chuli Ulloa, and I'm a pediatric infectious diseases physician scientist at UCI and CHOC. And today I'll be presenting the results of our very exciting and important project, the Safe School Restart Study, that examined the number of SARS-CoV-2 infections in schools with either remote or on-site learning in Orange County, and also described the immune responses in children with asymptomatic to mild SARS-CoV-2 infections. And so we were inspired to work on this project because at the start of the pandemic, very little was known about COVID-19 in children, particularly the role of children in transmission and outbreaks. And as a result, many schools were reflexively closed globally. And what we know now is that disease severity, thankfully, in children and school-age children appear to be much less than in adults. And data based on epidemiological analyses in Europe and Asia have so far not shown severe school site stimulated COVID-19 outbreaks. That all being said, there have been outbreaks, and schools certainly did not return to the status quo. So most countries implemented physical distancing, stringent hand washing and disinfection, and face coverings. And about 40% of European parents refuse to send their children back to school. All that being said, many national organizations, notably the American Academy of Pediatrics, recommends that schools should reopen when and where it is safe to do so. And this is for many reasons, but schools certainly provide a benefit to families beyond providing education. They also provide nutritional support, healthcare, and social services. And without in-person instruction, children are at increased risk of falling behind academically and exacerbating educational inequities. And here we have a message from our super scholar Ruben. This is at the beginning of the pandemic on the school Instagram that says, "Hello to all my school friends. I hope you are doing well. I miss you all. Hope we see each other soon. Stay safe." So the UCI, CTSA, and the Children's National CTSA quickly organized a group of scholars to sound the alarm. And we generated this report that essentially emphasized the need for more evidence-based guidelines and more research, particularly with regards to transmission of COVID-19 in children, the contribution of children and school reopening on the spread of COVID-19 in communities, the effectiveness of different COVID-19 mitigation strategies, and also the immune responses to SARS-CoV-2 in children. So our ICTS did what CTSAs do best, and we organized a university community partnership to begin to address and answer some of these questions by obtaining the necessary data. And we created a partnership between UC Irvine, the Children's Hospital of Orange County, and our local public health department, the Orange County Healthcare Agency. This is our team that later was expanded tremendously. But at the beginning, it was my co-PI, Dan Cooper, who's a professor and pediatric pulmonologist at UC Irvine and Chalk. He's the Associate Vice Chancellor of Research and also the Director of the ICTS. We had our project director, Diana Stevens, and our fantastic clinical research coordinators, Jessica Ardo and Kirsten Casper. And again, our goal was to begin the necessary research on SARS-CoV-2 transmission in students and school staff as K through 12 schools reopened across Orange County. And in the first part of our study, we wanted to obtain more information regarding SARS-CoV-2 symptoms seen in students and school staff, as well as obtain information regarding the number of SARS-CoV-2 infections in students and school staff, and evaluate the immune responses in the students infected with SARS-CoV-2. And in the second part of the study, we hope to learn what difficulties there are with reopening and ways to reduce the spread of disease. So we wanted to learn more about the COVID-19 mitigation procedures at the respective schools, and also quantify the degree of fidelity to face covering and physical distancing at each school. So in order to carry out this project, we partnered with 4 schools that reflected the diverse population of Orange County, and we ensured adequate representation of low-income, minority, and special needs student participants. Our first school, School A, is a public school in Santa Ana with a population predominantly Hispanic families. School B was a charter school in Santa Ana where more than 80% of students relied on schools for food security. School C was a charter school in Orange that cares for students with special needs, such as those with autism spectrum disorder and Down syndrome. And our fourth school, School D, was a private school in Newport Beach with a population of predominantly middle and upper middle class families. So these 4 diverse schools did have varying degrees of on-site and remote learning. Schools A, B, and C provided predominantly remote instruction, whereas School D had predominantly on-site learning. So there were 2 testing cycles as shown here in each school. The first testing cycle was in October and the second testing cycle was in December. And at each visit, we obtained a brief history and symptom review. We also obtained an anterior nasal swab for SARS-CoV-2 and 21 co-circulating respiratory pathogens. And then we had an optional phlebotomy for SARS-CoV-2 IgG and to examine other immune responses. In total, we had 320 students ages 7 to 17 years and 99 school staff that participated, and roughly 90% also agreed to phlebotomy. So serendipitously, cycle 1 actually occurred when Orange County-wide data revealed relatively low numbers of SARS-CoV-2 cases in the community, whereas cycle 2 occurred at the peak of the pandemic surge in our region, where we had a 10-fold increase in COVID-19 cases. And I'll talk about that a little bit later on. In addition, we also deployed observers to the schools, and these observers visited each school 3 times over a 1-week interval. And that was essentially to assess the effectiveness of COVID-19 mitigation procedures. So our team successfully adapted existing instruments to provide basically a much needed methodology to quantify the degree of fidelity to face covering and physical distancing guidelines in different environments, such as the schools, classrooms rather, versus recess, versus lunch, versus PE classes. And this observation technique is called SOCOM, or Systemic Observation of COVID-19 Mitigation. And the SOCOM data that we collected overall revealed high fidelity at all 4 schools, including School C, which served predominantly children with special needs and presenting additional challenges to COVID-19 mitigation. So about 88% wore their masks, about 91% maintained physical distancing, but The fidelity to face covering and physical distancing guidelines really depended on activity types, and face covering was noted to be lowest in communal dining. So basically during lunch, as one would expect, because you have to take off your masks in order to eat and you're socializing in closer proximities. So now I want to go through the SARS-CoV-2 positivity rates. And I will just say that the children that tested positive for SARS-CoV-2 in our study were either asymptomatic or minimally symptomatic. So we had no positive SARS-CoV-2 individuals were identified in the first cycle of testing. So all positive SARS-CoV-2 tests were from the second cycle. And during the second cycle, a total of 17 SARS-CoV-2 positive results were observed among learners. So that was 5.3% with an average age of 10 plus or minus 2 years. Among the 99 staff and teachers tested, 6 or 6.1% were SARS-CoV-2 positive. And again, all positive tests were identified on the second cycle visit. And so then also here, as shown in this figure, School A had the highest number of SARS-CoV-2 infected learners, whereas School B, that was in the same geographic location as School A, so in Santa Ana, we found that that had the second highest number. So there were 2 on-site learners that tested positive and 4 remote learners that tested positive, whereas School B had the fewest number of SARS-CoV-2 positive students. In terms of symptoms, learners or students who reported symptoms were significantly more likely to have SARS-CoV-2. Conversely, learners who were SARS-CoV-2 positive were more likely to have symptoms. And overall, in this group, cough and fatigue were the most commonly reported symptoms. So to better understand the specific regional impact of COVID-19 at each of the 4 schools, we ended up collecting and collating the countywide COVID-19 case data according to the zip codes of the students at each of the schools during our testing cycles. And then we ended up normalizing our school data to that of the countywide zip code-based case rate data. And when we do that, you see that School A continues to show the highest ratio of learner to local SARS-CoV-2 positivity. So essentially, infection in the schools reflected regional rates. And in this last panel, we have the proportion of SARS-CoV-2 positive learners is shown in the aggregate for on-site versus distance learners across all 4 schools. And while we had the greatest number of SARS-CoV-2 positive students in the distance learners group, there was no statistically significant difference in SARS-CoV-2 positive rates among remote versus on-site learners. So here we have schools A, B, and C, as I previously mentioned, were primarily distance learners, whereas School D, the private school, was predominantly on-site and learners had been attending school in person since the summer. And from these data, they overall suggest that distance learning did not necessarily protect against viral infection. And in fact, here we have one, School A, that had the highest, even though they were distance learning, they had the highest positivity rate of SARS-CoV-2. Now I want to share some data regarding our immune responses. And again, these are immune responses in children that were asymptomatic or minimally symptomatic. And so our analyses revealed reduced frequencies of circulating total and classical monocytes, as well as cytotoxic NK cells, and a decrease, surprisingly, a decreased concentration of key inflammatory markers in the infected compared to the uninfected children. So the infected children actually had decreased levels of TNF-alpha, IL-1, IL-6, and D-dimer. And this is in stark contrast to the monocytosis and heightened systemic inflammation observed in many adult patients. So these findings may begin to explain why children have fewer SARS-CoV-2 symptoms. So the reduced systemic inflammation profile, however, did not indicate a globally dampened or weaker immune response to SARS-CoV-2. And many of our infected children actually generated robust and broad humoral and cellular immune responses to SARS-CoV-2. So as you can see here, there were a substantial number of learners who were found to have anti-nucleocapsid IgG antibodies indicating previous infection with SARS-CoV-2, and IgG positive learners were observed in all 4 schools. However, as with the SARS-CoV-2 RT-qPCR results, there were large differences among the schools that most likely reflecting large differences in neighborhood infection rates. And so, for example, although the physical distance between school A and school B is about 10 miles, the population density and the socioeconomic status of the respective neighborhoods are substantially different. So infected learners also, despite being asymptomatic or minimally symptomatic, had detectable IgM and IgG titers, not only to nucleocapsid, but also the receptor binding domain of the SARS-CoV-2 spike protein. And they were also able to generate neutralizing antibodies specific to SARS-CoV-2. And so these are the titers or the antibodies that correlate with protection because they can block the virus from entering and infecting human cells, helping the immune system clear the virus and prevent future infections. And so what you see here is that every line or every color represents a different participant. And on the y-axis, we have the relative percent infectivity. And on the x-axis, we have the log of the plasma dilution. So higher log values correspond to the increased dilution of the antibodies, which also corresponded with increased infectivity, whereas lower dilutions or smaller log values corresponded to the decreased infectivity. So infected children also had measurable T cell responses to SARS-CoV-2, as evidenced by the presence of interferon gamma secreting T cells following exposure to SARS-CoV-2 antigens that included overlying pools of peptides covering the entire viral proteome. And they were also able to mount, they had a lot of proliferating CD4 T cells indicative of a recent history of activation. And as we know, or we've come to know, CD4 T cells are important in controlling SARS-CoV-2 replication and disease severity. So overall, in summary, infection in the schools reflected regional rates rather than remote or on-site learning modalities. Schools can implement successful mitigation strategies across a wide range of income, school type, and student diversity. And asymptomatic or minimally symptomatic children had reduced monocyte and inflammatory responses, but nonetheless, they were able to mount pretty robust humoral and cellular immune responses. And in terms of our next step, we've just submitted, manuscript was submitted, and the relationships developed to support the community partnership to apply for future grants. Funding has been established, and specifically, we intend to apply for the NIH call for applications addressing post-acute sequelae of SARS-CoV-2 infection PASC with a specific focus in children. So thank you very much.
Thank you so much for that fantastic presentation, Dr. Ulloa. So I guess I did have a couple of questions regarding, I think, I think your data are really, compelling in terms of the neighborhood rates being, very extremely predictive in terms of the prevalence of SARS-CoV-2 in schools. So I guess I'm just wondering in terms of, for future, for mitigation at school, other than the masking and the distancing that you mentioned, what are your thoughts about, I think there's been a lot of attention given to improving, making structural, investment to improve, ventilation and other kind of structural, improvements within schools to also try to prevent transmission in that setting.
Yeah, I think there have been a lot of discussions around that. And I think at the end of the day, I think it would be really challenging, especially to implement those structural changes, particularly at public schools where they don't have a lot of the resources that perhaps other schools such as private schools may have. And so I think that really at the end of the day and fundamentally, we just need to stick to the basics, wearing your mask, maintaining physical distance, and washing your hands, and just try to practice hand hygiene. And so actually today, I believe it was today, they've kind of loosened a little bit of the restrictions. And so I think in schools now, the physical distancing is going to be 3 feet, so long as you're wearing a mask, and then 6 feet if you're unable to maintain the mask on at full time. But yes, I think it'll be really challenging to have all these other structural changes. And if we just stick to the basics, then I think that that is proven to be able to at least mitigate and prevent the spread of infection.
And are there any plans for just kind of following up and with these, with the cohort that you've enrolled, and also perhaps expanding to other schools?
Yes, so if we had $1 gazillion, I would have liked to have included a lot more schools, but in terms of the cohort that we actually examined, yes, we would love to follow them longitudinally to see how those immune responses change over time. And so we do have plans to follow them longitudinally. We also have plans to apply for other grant funding and look at other populations of children that have more severe SARS-CoV-2 infections that requiring hospitalization, and also looking at the immune responses in a population of children that have a delayed immune response. So this multi-system inflammatory syndrome in children, or MISC, and kind of comparing these different groups.
Great, that's fantastic. Thank you for that. I think like you said, you made a really compelling case of the value of partnering with community organizations and with local school districts and community partners, and I think the value will continue to pay dividends moving forward. So again, fantastic work, and thank you for presenting your results to us.
Thank you, everyone. Take care.
Okay, so I think we're doing really good on time. So we're right on schedule. We're gonna go ahead and take a break for lunch and reconvene for our afternoon session at 1 p.m. And I do want to just again remind everybody that this entire day, all the sessions are being recorded and they will be available for viewing afterwards. And also for those of you who have to step away, we will have at 4:20 a cross-fertilization discussion, and everybody's welcome and invited to participate in that. And so with that, let's go ahead and take a break, and I will see everybody at 1.
And then we'll pull down this slide.
And I'm able to share my screen, right?
Yes.
You will be. I guess when Will comes in, he'll take this down.
You can go ahead and share your screen.
Well, let me
right
say
now?
hello first before you share it. And just welcome people.
Okay, that's fine.
It's reading 12:59. I'll wait for people to actually wait for the top of the hour. Okay, then let me just do this. Hi, everyone. My name is Eric Perlman. I'm the director of the Institute for Immunology. Together with Sangyok and with Ilham Masoudi, we helped to organize this conference. And this morning we had a lot of public health talks, which were really intriguing. This afternoon we have a couple more public health talks, but we also have some basic science talks, and that will be starting with Tom Lane. And Tom has is a Chancellor's Professor in Neurobiology. And he has been working in this area for some 20 years. He worked with Mike Buckmeyer, which is probably his biggest claim to fame. And Tom joined the UC Irvine, the Biological Sciences faculty in 1998, then left for Utah, and then came back here and is now continuing to work. And Tom's work is particularly pertinent because he has long experience working with coronaviruses as neurotropic coronaviruses. So his work with COVID is really highly relevant, and it's a pleasure to welcome you, Tom. Thanks for joining us.
All right, thank you, Eric. All right, I'll share my screen now. Okay. And everybody you can see that all right and hear me okay, right?
Maybe make it full screen, Tom. Is that full screen?
It is full screen.
Yes. Okay, great.
Yeah. All right, great. First, I'm going to go rogue and thank UCLA for beating Michigan State yesterday to get into the NCAA tournament and to continue get their next championship, which I know will happen. Also, I'd like to thank the organizers for the opportunity to discuss some of the work that we have ongoing in the laboratory right now. So the overall focus, as Eric indicated in that very nice introduction, is that we've been interested in evaluating molecular as well as cellular mechanisms that contribute or drive host defense, as well as disease in response to coronavirus infection of the central nervous system. And so the majority of our work has been using neuroadapted murine coronaviruses, but within the past year, we've pivoted quite a bit to develop our work on a mouse model of SARS-CoV-2 infection, and that's what I'll be talking about today. So the two areas I want to discuss are studies that are ongoing, looking at the ability of SARS-CoV-2 to infect and replicate in human resident CNS cells, so specifically neurons, astrocytes, and microglia, and then conclude with some of the work that we're doing with SARS-CoV-2 infection of human ACE2 transgenic K18 mice and the assessment of lung pathology, but really what's going on in the central nervous system of these animals. And so I'm obligated to show this slide, although I think you could probably walk on the street and talk to anyone and have a fairly informed conversation on nuanced aspects of coronaviruses. But here is a cartoon depiction of a coronavirus. SARS-CoV-2 is a beta coronavirus that's related to SARS-CoV-1 and more distantly to MERS-CoV. The virus that we use quite a bit in the lab is mouse hepatitis virus. This is also a beta coronavirus. And of course, you have the spike glycoprotein, which mediates attachment to the host cell receptor ACE2 in humans. What I want to really focus on here, that symptoms for all of these coronaviruses are wide ranging, include pneumonia, in some cases diarrhea, and peritonitis. But what we're particularly interested in is neurologic disease, particularly encephalitis and neurodegeneration. And so what's interesting is, unlike infections with the previous coronavirus outbreaks, SARS-CoV-1 and MERS-CoV, neurologic symptoms are common in COVID-19 infected or SARS-CoV-2 infected individuals with COVID-19. And so the symptoms are varied in severity. They can include loss of sense of taste and smell, dizziness and headache, stroke, seizure, inflammation of the brain, which is characterized by encephalitis and meningitis, and then myelin loss. And so here, I'm just going to jump right into it. This is a very nice article that was recently published by Bill Young, who's in the Department of Pathology here at UCI, that shows some of the characteristic pathological features of people that have succumbed to COVID-19, but this is neuropathology, so what's happening in the brain. Some of the aspects, you see swollen astrocytes. You have these very distinctive called Alzheimer type 2 astrocytes. That's because they're originally characterized by Dr. Alzheimer. And then in addition, you see perivascular cuffing and correspondingly immune cell infiltration into the CNS. In addition, here's two nice studies that were published in 2020 This is an article from Akiko Iwasaki's laboratory that shows that she can detect neurons in the brains of patients that succumb to COVID-19. In addition, other histological features include this myelin loss. So this is a sequential series of photographs beginning with an H&E stain where you can see cells congregating in a particular area here. And this is actually in a white matter tract where you see myelin loss. And then these cells that are have infiltrated in were immunophenotyped to be CD68, which is indicative of macrophages or inflammatory monocyte and macrophages. And then finally, axonal damage that can occur. What's interesting is that in the spectrum of papers that have come out over the past year, looking in the brains of these individuals, it's hit and miss on whether they detect virus. They can detect viral RNA in the CSF, but there's not a lot of CNS penetration, at least upon autopsy. Akiko showed clearly that neurons could be detected or be infected by the anti-spike immunohistochemical staining. Other reports have suggested that vascular endothelial cells can also be infected, but there's not a lot of robust infection or at least virus that's being detected in these patients at the time of autopsy. And I bring this up because it's going to be relevant to what I'm going to be showing in the mouse studies. But first, the question that we initially addressed is that is SARS-CoV-2 capable of infecting primary CNS cell types? And so here is kind of basically what we're mainly interested in. Can we take SARS-CoV-2 and then human either neurons, astrocytes, and microglia, are these cells susceptible to infection and can they replicate the virus? So before we began these studies, we worked with a chimeric virus, a vesicular stomatitis virus, VSV. And this virus has been engineered to express SARS-CoV-2 spike glycoprotein. And this was kindly provided to us by Sean Whelan, who's chair of molecular microbiology at WashU. And essentially the cartoon here is very straightforward. He had in his laboratory a VSV that expressed EGFP, which is a reporter gene. And then he was able to engineer a virus in which the glycoprotein on VSV was replaced by the spike glycoprotein of SARS-CoV-2. And so the advantage of this virus is twofold. One, you can do work in a BSL-2 lab, which is actually not a trivial point because it's much easier. And then moreover, you can use experiments or data derived using this virus to inform subsequent experiments that you want to move forward and do in a BSL-3 laboratory. So using this approach, we first needed to get enriched pure cultures of human neurons, astrocytes, and microglia, and we took advantage of just wonderful colleagues of mine here, Dr. Leslie Thompson and Matt Burton-Jones, who were able to provide us these cells. And the neurons were provided by Dr. Smith-Geter. Andrea provided the astrocytes, and then Christina provided the microglia for our experiments. And this cartoon depiction really kind of shows what we wanted to do. So we took the VSV SARS-CoV-2 spike glycoprotein virus, and we infected separate cultures of neurons, astrocytes, or microglia at a multiplicity of infection of 0.1. So that just means 10% of the cells in theory should be infected. And then we looked at defined times post-infection, 24, 48, and 72 hours post-infection, to look at the ability of the virus to be detected and replicate. And we did this by quantification of fluorescence, because remember, this virus has an EGFP reporter gene. We also could do qPCR to amplify the spike glycoprotein, and then also do plaque assays. So here is kind of the overall result of this experiment. This is a low power image of infected neurons at 72 hours post-infection. You can clearly see the neurons that are expressing EGFP in culture. This is a high power image, and what's interesting is you can see not only is the cell body infected, but these long dendrites that are extending from the cell body also have antigen in them. And so that was interesting. And when we did the qPCR for the spike glycoprotein of SARS-CoV-2, You could see very nicely in the neurons this increase in signal over time. So at 24, it increases then to at 48 hours, and then at 72 hours, there's more virus. However, in the microglia and astrocytes, we really could not detect really any signal for spike glycoprotein. All right, so that would argue that neurons are certainly susceptible to infection, but microglia and astrocytes, at least within the context of infection in vitro, could not be infected by this chimeric virus. Importantly, when we added an anti-ACE2 antibody to separate cultures, we were able to block infection of neurons. So this would argue that the virus employs ACE2 on neurons to enter into the cell. So the next experiment was rather obvious. We then moved into the BSL-3, and again, in collaboration with Leslie and Charlie, who provided us these beautiful iPS-derived human neurons, we infected with SARS-CoV-2, but at this time we used a higher MOI of 1.0 because I wanted to make sure we were kind of just pushing the system. But by 24 hours, you could see clearly that there is virus detectable in these neurons. We're using MAP2 to identify neurons. And then again, this is immunohistochemical staining for N protein because this is actual SARS-CoV-2, so it's not EGFP labeled. And by 48 hours post-infection, you can see the virus is spreading. And what was interesting to us, if you go into high power here, at 24 hours post-infection, you can see viral antigen that's really located within the cell body, but not extending down in these dendrites. And much like we saw with VSV SARS-CoV-2 infection of the neurons, similarly, we see that viral antigen is now going down these dendrites, which I think is really interesting. And it lends itself to some just basic biology questions of how does the virus potentially subvert normal neurologic function or neuron function that could consequently have potential effects on cognition or what have you. So then the next question we asked was, does SARS-CoV-2 infection of human ACE2 transgenic mice result in infection of the central nervous system? And so these experiments were greatly enabled by Grant McGregor and Shimako Kawauchi at the Transgenic Core Facility. Their help was invaluable in expanding this K18 colony. And so the importance of these mice is that normal laboratory mice that are used for just, for example, our mouse coronavirus research, you can't use these animals because they do express ACE2, but it's not the form of ACE2 that can bind SARS-CoV-2. So in 2007, Paul McCrae, who was in Stanley Perlman's lab at the University of Iowa, made these K18 mice that express human ACE2, it was engineered to be expressed primarily in the lungs, but I think it might be a little leaky, and I'll show you evidence of that. And we can use this model then as a model to study SARS-CoV-2 induced lung pathology, as well as potential infection of other tissues, including the central nervous system. And so we can infect the animals intranasally with different doses of virus. And then we can extract brains and spinal cords and lungs at defined times post-infection and look at the ability of the virus, for example, to get into the CNS. Is there any neuropathology or neuroinflammation? Correspondingly, we can also look in the lungs and see if there's any infection of the lungs and inflammation. So not surprisingly, when we first started doing these experiments, again, this is a relatively low dose of virus. Higher doses will kill the mice relatively quickly. We removed the lungs, and this is day 9 post-infection. And so this is just H&E staining of lungs. And what's shown, or what I'm trying to convey here, is there's this massive infiltration of immune cells into the lungs following infection with virus. And then when we do in situ hybridization for spike viral RNA, you can see in areas in which there's quite a lot of lung pathology, there's quite a bit of viral RNA. And if we do qPCR on RNA that's extracted from these lungs, we can see a dramatic increase in viral RNA compared to the uninfected controls. And I need to acknowledge Rob Edwards, who's in the Department of Pathology, who has greatly helped these experiments by doing the lung pathology, cutting the sections and providing them to us. And then, of course, Hema Oliveira and Colin, who did the RNA-seq, or excuse me, the in situ hybridizations and qPCR for virus. And so now I'm just in the last portion of this talk, because a lot of this work is really ongoing. It's very slow to wait to get the animals up and running and get viral stocks to do the infection. But I just want to touch on some new data that we have in the lab, or developing data, and that is to go over the fact that we can detect viral RNA in the brains of these animals. We do see glial activation and immune cell infiltration, and then we also have been looking at demyelination, because if you remember, there is literature showing that there are demyelinating lesions in patients that have succumbed to COVID-19. So first, again, it's a 10 to the 4th PFU inoculation of the SARS-CoV-2 K18 mice. We remove the brains and spinal cords at defined times post-infection. And this was actually surprising. You can see in about 50% of the animals, dramatic increase in viral RNA that spread through a variety of distinct anatomic areas within the brains, the cerebral cortex, the hypothalamus. It even can extend down into the brainstem. Not shown here are the controls of non-infected animals infected with, or non-infected animals in which we did the in situ hybridization, which came clean, as well as use of the antisense or the sense probes, which also were clean. So this is real signal. And then correspondingly, we can detect a large increase in viral RNA in the brains of these animals. And then if you go under higher power microscopy, what we found is that in distinct areas, or in areas in which we can detect signal, you can see cells that clearly have a neuronal morphology. And we're in the process of immunophenotyping these cells by doing combined in situ hybridization with immunohistochemistry. And this is just a high power image. And I think what's interesting is, again, much like we saw in vitro with viral RNA and antigen being in the cell body, the virus, we can detect this also in these processes extending from these neurons. In addition, pathological features that we've also detected is meningeal inflammation, and then perivascular inflammation. So immune cells are clearly being activated and mobilized to infiltrate into the central nervous system to potentially contribute to either host defense or neuropathology. Now, these are data that we just got this week, and it's a very nice collaboration that we have ongoing with Kim Green and members of his lab, Dr. Lindsay Hosfield, and then Sungjin Kim. And this is staining for microglia, which is indicated in red. These are red cells. And then inflammatory monocyte and macrophages, which are in green. And what's interesting is you can see that you get very good microglia activation all throughout the cerebral cortex, as well as distinct anatomic regions. And then you get these pockets of monocyte macrophages that are infiltrating into the CNS. And I put this up here, we're calling this the Christmas tree, because it looks like a Christmas tree. But this shows very nicely, this is a perivascular space, or representing the vasculature of the CNS. And clearly these monocytes are employing this highway system, if you will, to enter into the central nervous system of these animals and then migrate out into the periphery, which lends itself to some interesting questions just in the fact of what are the chemotactic signals that these cells are responding to gain access into the central nervous system. And then we've also done RNA-seq on the brains from experimentally infected mice. And so there are 3 groups. We had uninfected animals, and then we had mice at day 8 post-infection, and then day 15 post-infection. And I'm not just going to walk through this heat map, but what these data are telling us so far is we see altered expression of genes that encode for pro-inflammatory factors. So these are dramatically upregulated very early following infection. So this is day 9. And then we also saw disrupted signaling in hormones, so genes that encode for hormones in these animals. And then finally, what was particularly intriguing to me is we saw an increased expression of genes that are associated with depression and anxiety. All right. And so here, I'll come back to that in just a moment, but here for the inflammatory genes, we're seeing microgliosis, so activation of microglia. These are just high power images of EBA stained cells. And then we're also seeing astrogliosis, so activation of astrocytes. So there's a robust immune response that's occurring in these animals. But back to this depression and anxiety, I think one of the really interesting questions that we need to ask ourselves over time is that people that have post-acute sequelae of COVID-19 are also known as COVID long haulers. Of the myriad of symptoms that they are experiencing, which definitely include chronic fatigue, but many of these people have cognitive issues that can include depression and anxiety, as well as brain fog. They just can't think as straightly as they did prior to infection. So I think this is an interesting area of ongoing study that we're going to definitely pursue in the lab. And then finally, I'll conclude here. This is just LFB staining, or Luxol-Fast blue staining of a brain at day 9 post-infection and a spinal cord at day 15. And what was surprising, we don't really see that much demyelination in these animals. We're going to pursue this in more detail. But right now, I think the answer is it's a little opaque. So I thought I would see much more, particularly because there's so much virus in the brains of these mice. So I'm going to conclude. So what we've determined so far is that that SARS-CoV-2 can infect the CNS of K18 mice. It's not consistent. It doesn't depend on the dose. Again, our lab, as well as others in the field, have seen infection of the brain about 40 to 50% of the time. But in these animals, we see widespread infection of discrete anatomic regions. Neurons seem to be a primary target. We do also see glial activation and then correspondingly monocyte infiltration. We're now looking at T cell infiltration of these animals as well. And we'll start quantifying this and start looking at specific responses. I think it's important that we'll also evaluate innate and adaptive immune responses that are invoked at these different times. And then we're very active in evaluating novel antiviral and anti-inflammatory drugs in this particular model, with an emphasis on the lungs, but also looking in the CNS. Now, this lends itself to an interesting question, right? So is the K18 a relevant model for SARS-CoV-2? And I bring this up because what I indicated at the beginning of the talk, if you look at a lot of brains, and we've looked at COVID brains as well, and we cannot detect a lot of virus in the brains of these individuals. So is this a relevant model? All right, because clearly when the animals get the virus in the brain, it goes all over the place. And I go back and forth on this, but then, I think it is a relevant model. And I'll tell you why, because we don't know what the future holds. We didn't know 16 months ago that we would be locked down because of an emerging coronavirus. And with the new strains that are evolving, who's to say over time that there might not be a strain that is capable of enhanced CNS penetrance and replicating in the CNS. So I think we need to be poised to understand what happens if and when the virus does get into the central nervous system, and what factors are controlling both host defense as well as pathology. And then finally, we're doing a series of, I think, very interesting studies looking at comorbidities. So in other words, individuals that have either Alzheimer's disease, HIV/AIDS, and Down syndrome, do you see an enhanced ability of virus to get into the central nervous system of these individuals? And these studies are ongoing. We are getting brains from patients that have HIV/AIDS that succumb to COVID. We'll start looking for virus in the brains of these individuals next week. And we're also getting Alzheimer's brains as well as Down syndrome brains from patients that died of COVID. All right. Now, I do have to make a very, very special acknowledgement. So all of these experiments that we're doing in the BSL-3, they are really time consuming and they're very challenging just because they take a lot of time, and none of this work would have been possible without Hema, Susanna, and Yuting, who are the 3 people that do all of the work that I showed you and not showed you, because we have a lot of data on other projects as well. They always have a great attitude. They have no problem going in there, spending hours and hours and hours collecting tissue, working with these animals. And I can't thank them enough for everything they've done. And then finally, I do want to, this is my lab here. Cynthia is my lab manager that runs everything. Ilhelm has been just an amazing colleague, as well as Isabella and Alan. It's her lab and our lab. that basically manage the BSL-3, at least in biosci, and that in itself takes an enormous amount of work. Colleagues that have also been invaluable are Rob Edwards, Bill Young, Kim Green. We've got a great collaboration going on with Steve Goldstein now, other wonderful colleagues here that we're starting to work with in these areas of research. And for the sake of time, I'm going to stop and answer any questions.
Tom, I'm wondering if you can stop sharing.
I can.
Yeah, if you could just for the sake, we have a really broad audience here. I was wondering if you could just, we've got a few questions here, but I was wondering if you could just mention or expand a little bit on what BSL-3 is for those who may not be familiar.
Right. So that's a type of high containment laboratory, primarily used for respiratory pathogens. And so this is where you have to, I think you saw that in the acknowledgement for Hema, Yuting, and Susanna. You have to wear special gowns and suit up. And it's a very
controlled air supply.
Yeah, you have your own independent air supply. So it's a very controlled environment. And so, you know, it's a lot of work. And as I indicated, we're, you know, not only are we working in there, we're helping manage the facility. So like last week, we had a biosafety cabinet that went down. So that slows down work because we have to work with Anju and Gary and coordinating repair. I mean, I could go on and on. The month before that, we had an autoclave that broke down. So it just takes a lot of time to get this stuff done.
Okay, let's go to some of the questions, although we are.
I think Mike has a question.
Running out of time. I can't imagine Mike would have a question.
Tom, have you sequenced the virus that's coming out of those mice?
Yeah.
Do you see any changes that are mouse specific that might give you a hint about what's going on in the mouse?
Yeah, Mike, that's a great question, and we're moving in that direction. That's exactly what I did when I was in your lab, right? When we were doing the SIV studies in non-human primates, right? So the question to the audience is there a unique aspect to spike or other genes that allow greater CNS penetrance? And that can be informative for potentially, these emerging strains that are coming out, if there are unique sequences that allow the virus to get into the brain and replicate. Mm-hmm. So no, that's something we need to do.
So let me ask a couple quick questions out of this, and then we're going to have to move on to the next talk. So with an early question from Peter Heseltine asking, as VSV will infect many cell types, including neurons, why is it that just having the spike protein is enough to get infection?
Good question. It was a tool. So it has the spike glycoprotein of SARS-CoV-2, and we're just looking at the susceptibility of any of these CNS cell types that may or may not have ACE2, right? And so if they do, they should be susceptible to infection. It's a very just clear-cut experiment, and that's like the first level that allowed us then to go into the BSL-3 to work with the neurons. So it's just it was a very powerful and easy tool to use.
So then Jim Hall asks, what are your plans for behavioral studies for these mice?
Yeah. So I've been talking a lot with Marcelo Wood about this. Can you develop a long hauler model, right? And so it can be done, and that's one of the numerous reasons why I love being at UCI, not only the great science, but great colleagues that have these areas of expertise. So that's a conversation that's that we're discussing right now. The problem is, though, the hit and miss aspect of the CNS infection. But do you need the CNS infection to get cognitive issues in these animals or memory responses? And I think that's a great question. So I think
you're infecting those by inhalation, right? Not by.
That's right. We're not doing a direct intracranial inoculation.
That's great. So then the last one I think I'll ask from Calvin Lee is, you talked about low dose virus for your experiments because higher doses can kill the mice. Mm-hmm. So can you relate that to human disease?
Not really. That's hard. I think, Ilhelm could probably be, could add to this, but if you look at studies on non-human primates, right, you can use a variety of different doses, and you don't see like a classic incremental increase in disease severity. You certainly see it in the K18 mice, and I think you see it in Syrian hamsters as well. Ilhelm, can you add to that?
Yeah, Tom is absolutely correct. So you get pretty much the same clinical disease whether you give a non-human primate 10 to the 4th or 10 to the 6th.
Yeah, but man, if you go 10 to the 5th in these mice, by day 5 or 6, they drop badly.
Okay, one very quick question from WeFam. Does the infection in neurons, does that occur via retrograde, antegrade, or both pathways?
I would love to know. I mean, that in itself is a grant, right? Because I think some of the stuff we could do with EM analysis and other experiments, and then how does it disrupt potentially axonal signaling, right? I mean, that could have subtle effects that have long-term consequences. So we've got an enormous number of questions that we're asking, and we're in the right place to do it. So
well, there's definitely a need to know more about the long hauler situation. This is more and more of an issue, especially as the vaccine comes along and people are being vaccinated and protected. The disease will not go away.
That's right. That's right. And keep in mind, we've been working with this virus for a year.
Right.
So I mean, we've got a lot more to learn.
Tom, thank you so much. That was fascinating and great work by you and the good people in your lab and collaborators.
All right, thank you so much.
Let me now introduce Daniel Chow. And Daniel is one of the co-directors of the Center for Artificial Intelligence in Diagnostic Medicine. Dr. Chow joined the University of California, Irvine in December 2016. He's assistant professor in residence in radiological sciences and neurology. And so with that, his talk today is on predicting COVID-19 patient vulnerability with advanced analytics and artificial intelligence. So Daniel, are you there?
Yep, I'm here. Can you hear me?
Ah, there you are. Yes, we can hear you. We can see you.
Okay. And can you see my slides okay?
Yes.
Awesome.
Beautiful.
All right. Well, first, thank you very much for inviting me to participate in the symposium. And so I'll be talking about how we used advanced analytics and AI to try and predict COVID-19 patient vulnerability. So I just want to say, first as a disclosure, I am not a software developer. For a lot of the technical details, for those who are interested, I would steer them towards my co-director, Peter Chang, who did a lot of the hefty lifting for the actual development and the coding for this. So, as a background, I think one of the things that we saw last year in January was looking at the initial reports from both China and Italy and some of the early characteristics of the COVID-19 patients. Increasingly, we were identifying that there are some patients who, despite therapy, were just refractory. They still required intensive care support, ventilator support. And we knew from some of the early meta-analyses, mostly from China and Italy, that there were potentially up to 70 clinical laboratory imaging parameters that may be useful in separating those who are at higher risk of doing poorly from those who are lower risk. And this goes into one of the challenges for healthcare now, is that there is so much data being generated in medicine. So if you look at other industries, health data is actually growing faster than any other industry. It's growing faster than media, it's growing faster than financial, it's growing faster than manufacturing. So it's difficult, if not impossible, for our clinicians to digest, integrate, and process this swath of new information in real time. On top of that, there was another challenge, and that was our populations were very, very different. This is a CT of the chest of a 34-year-old patient, and you can see in the lungs bilaterally, there are these stereotypical ground glass opacities that you see of COVID patients. And our patients were younger than in Europe and in Asia. They were also sicker. The average number of comorbidities in our populations were between 2 and 3. And also the comorbidities were different. If you look at some of the very early literature from Wuhan, anorexia and hepatitis was some of the stronger predictors of doing poorly. Whereas if you look at the early data from Seattle and New York, it was obesity. And so you can see that we have very different challenges. So, in January of last year, we had started to engage our stakeholders between campuses. And so we were working from teams within medicine, infectious disease, pathology, emergency medicine, public health, nursing, computer sciences, to really figure out what are the important data inputs that we should be looking at if we wanted to build a risk stratification. And I remember, when we were putting together our initial proposal, and this is, there was a question on, big data and AI generally requires lots of patience. And there's a question on, and perhaps naively, like, would we have enough patience to even do this study? And there's one of those things that, well, hopefully not, but, if we do, then, at least we'll have a tool in place. And this is where I think, we're starting to pay dividends from that very, very early engagement. So in March, we were starting to see our first few patients at UCI now. And this is a lab profile of one patient, and in the columns are different dates. And you can see that there's a lot of heterogeneity between ordering habits. So for example, on this day, the doctor wanted to order an LDH. On this day, this doctor said, I just want a procalcitonin. And every single day because you'd have different rotating clinicians or different things, you would have different labs being ordered. And so one of the things that we were able to do, because we were engaged with the hospital, medicine, and infectious disease and pump critical care, we were actually able to just standardize a COVID severity lab panel. And so you can kind of see that you kind of have this heterogeneous mixture of different lab data, and all of a sudden now you have very, very consistent data being ordered. And I think that was one of the really cool things that we saw, that, kind of that engagement loop. And so I really do believe that when you engage our clinical stakeholders early, you end up getting better data and better results. And as a result, within the UC system, we have some of the most clean data for lab profiles in our COVID population. In May, we were continuing on, and now we're starting to see vulnerable populations. We were working with Dean Bernadette Bonabella and identifying lower incomes and Latinx communities who were being particularly hard hit. And by June now, we were starting to have our prototype deployed and right in time for our first surge. And so this is what the COVID risk calculator looks like. It's live here, and you can click on this link, and it will actually take you to a calculator that you can play with. And it's a combination of using clinical inputs, physical exam inputs, for example, respiratory rate, some routine labs that we found to be significant, and then some stuff from our COVID severity screen panel, specifically LDH, troponin, sorry, one second. Troponin high sensitivity, ferritin, procalcitonin, and CRP-HS. And this was done through consensus with our team. And so far we've seen that, LDH specifically and CRP, we keep seeing as recurring lab values. This was from the initial training performance from May through April. So from May through April, we only had about 87 patients who were hospitalized or went to the ER. This was about 3,200 patients were tested. There were 290 total positive patients, including outpatients. And when we drilled down to our ER patients and admitted patients, we got down to 87. And we were able to generate pretty robust analysis for being able to identify those who would go on to critical care, defining as ICU admission, versus those who did not need ICU admission. We had some collaborators at Emory, and we tried out our calculator there, and we were still relatively holding strong for our performance, and we're happy. So by December, we are now seeing our full spike of COVID. This is when things got at our peak. And these are just examples of notes being used. And I think this is one of the things that we really focused on from the very beginning, is how do we operationalize these tools and put them in the hospital? So you can see different clinical notes. This is a patient, 69% chance of requiring ICU or mechanical ventilation. This patient went to the ICU 2 days later. This is another patient, 47% went to the ICU 1 day later. This patient ended up going to the ICU, I think within 2.5 or 3 days. And so what we try to predict for is on admission labs, what is the likelihood of needing critical care within 3 days of admission? One of the really cool things that we saw was that even though our outputs was just this category for this ICU category, we were observing that we could actually use this on a daily basis, and we're actually starting to see that this could actually start to predict things like disease severity. And so that's how it went from a triage tool to a tool to look at disease severity. And also, I know some of the clinicians on the wards were starting to use this for surveillance. One of the things that we're looking at UCI Health now is, how well did this do for predicting mortality upon admission? And you can see that even though our tool was only ever meant to look for critical care needs, it was relatively specific and a pretty strong negative predictive value for looking at mortality. This was the odds ratio, and working with Dr. Wilson, the CMO of UCI Health, along with his team, it outperforms traditional comorbidities. For example, diabetes, being immunocompromised, CKD, and cardiac disease. And so, I think even though this was a quick one-year sprint, I think we were very, very overall pleased with the results. And moving forward now, one of the things that we are beginning to explore is how this tool can be used to either select for therapies, for example, monoclonal antibodies, or can it be used for the hospital at home program? For example, if we identify someone that is of lower risk, would that be a good candidate to maybe monitor at home instead of in the hospital? So those are things that we're starting to explore now, and also kind of trying to adapt this methodology to other diseases as well. And then the one thing that I do really want to emphasize is that this is very much a team effort amongst multiple different specialties and from a very, very frequent engagement loop. For multiple people on this list in the beginning, we were talking almost daily, weekly, and for some of these collaborators, we still talk daily to just check in and see how it's performing. One of the advantages of this calculator is that this actually evolved over time. There were actually 3 iterations of this calculator, and the weights would change over time, but we would always normalize it around 0.3 to make it easier for our clinicians. And in terms of the performance ever plateau, we found that when we got to about, I think, 220 or 300 patients, it started to plateau, and we still do periodic checks to see how it does, and it's still holding relatively strong. And so that's the gross overview for how we were using advanced analytics and AI to try to predict COVID-19 vulnerability.
Thank you, Daniel. That's really interesting, really powerful tool. I was wondering if I'm not seeing any questions here, so those listening, please submit questions in the Q&A. Meantime, I'll start by asking you what your interactions have been with clinicians who are on the floor, especially clinicians who are respiratory specialists who'll be dealing with these kinds of patients.
Yeah, that's a great question. And I think one of the things that we did from the beginning was, before we made this tool, and I think this was actually really important, we didn't come up by ourselves, my lab didn't come up by ourselves that we wanted to make a vulnerable tool. We just knew that we wanted to pivot and try our best to serve and do something for the community. And we actually had reached out to our pulm critical care doctors, our ER doctors, and some of our folks from IDA medicine to say, what would be a good tool? One of the initial ideas we had was trying to predict risk of getting COVID. And they were telling us that that doesn't really serve them too much. What would be better for them is a triage tool. And I think because we engaged them early on and we were working with them to make a tool that would work for them, we had a pretty good adoption. Right now, we're trying to pull how often the labs were ordered and how often the tool was used. And we know it was about over, I think, 1,200 times, give or take. So we know that it was used by ER doctors and the ICU doctors. And so, yeah, so I would say we were pretty happy with that.
Okay, so we have a couple more questions here. Question from Frank Zeidiger wants to know if you can adapt this tool to predict long haulers, how they will survive, how they will manage.
I think that's a great question. I know that there's starting to be a lot of other AI efforts trying to work in this space. And I would say one of the beauties of AI and deep learning is that it's a very, very clean analysis. All I really have to do is change the outputs. So for example, if I know the outputs were COVID long hauler versus non-long hauler, we could actually start to map that out. And so I think that's a project that we would love to do and to be involved in if someone wants to collaborate on that.
Very good. Yeah, and that's becoming more and more important, of course. So comment from Jeremy Wood, some of the early studies out of Wuhan showed that coagulation parameters were predictive of mortality. Could you try adding any coagulation lab parameters to maybe improve the prediction score?
Yeah, so the original prediction score had 27 inputs. We actually had INR, PTT, and I think a D-dimer in it as well. And when we went to our doctors, they were saying that this is too many inputs for anyone to ever use. And so what we did was we took I think the 12 or 6 highest weights that had to be manually inputted. And so that's the ones that we ended up sending on. So things like LDH and CRP and some of the inflammatory markers, they had such strong coefficients and that they just kind of outweighed some of the things like D-dimer and INR and PTT. But we definitely did originally look at it. In fact, you're absolutely correct. If you start putting in more data, you'll start getting a better and better and better result. It does plateau at a certain point. And so we had to balance wanting the doctors to use this and making it simple enough for them to use, but also getting an answer. And so that's how that kind of happened.
Very good. Jim Hall has another question. Do you have plans to recruit other hospitals in the region or elsewhere for that matter?
It's been made fully available. I mean, we track the IP for this. And the funny thing is, we were seeing people from the UK and Germany using we saw IPs from Germany and UK using this tool. I will say that this is calibrated around a UCI health population and our demographics. And I would say that from some of the immediate local hospitals, it would make sense. But for once you start going to different socioeconomic status, the accuracy and the AUC will go down and you probably have to regenerate a new threshold that works for that population. And so I talked to Richard Afable. He's part of the Mirage program. He was the former CEO of Hoag. And I think they didn't really see their giant surge until December also. And I don't think that collaboration just never really got off the ground, unfortunately.
Okay, very good. And so question from Carol Buchainer. Pardon me if I said that wrongly. How effective is the tool if you just use commonly obtained lab measurements versus COVID-specific measurements? Is there an argument for making the more unusual measures more usual? Would these be better predictors, I think she means?
Yes, and that's a great question. So if you're playing with the calculator, one of the things that you'll notice, if you leave out those 5 panels, you will actually still get a risk calculation. So we built the model to work with incomplete data. So if you don't have an LDH or troponin or ferritin, or only 1 or 3 or 4 of those, you'll still get a calculator. So it works best when you have all the values, and when you start having incremental use of the lab values, the performance does start to decline. In general, you need about 6 to 7 parameters to get a reasonable score.
So the other part of Carol's question was, would this be made available to the general public or to caregivers, especially doctors' offices and so on?
Yeah, and so the tool is online and anyone can use the tool.
Oh, great.
So
great, that's great. Any other questions? If there are no other questions, I will thank you. And
first time I have a question.
Yep.
Thank you for that presentation and just amazing work. I'm wondering if there are any plans to sort of evaluate the clinical impact of using this tool versus not using the tool on sort of, what the effect might be.
Yeah, so that's a really, really, really great question. We are working with Bill Wilson right now and Alpesh to try to do that. So one of the things that we saw from the Vizient data is that UCI actually had the best length of stay and mortality index in California. I think we are ranked number 1 or number 2 for all California academic medical centers. But it's hard because there were so many things going on. For example, we had very, very early adoption of remdesivir, and that was led by Lanny and Alpesh. We had mobilized a lot of groups really, really early on. There is an argument to be made about we were starting to see what was happening in New York and starting to make plans. The COVID-19 pathway was also already being worked on in real time. It's really, really hard to attribute how much of an impact this one tool had, on how much did this tool affect length of stay, or how much did this tool affect mortality. We've tried surveys and discussed using surveys, which is kind of a softer science, but in terms of being able to say that, it's this tool that reduced the length of stay, I don't know how we would be able to do that. I think one of the things that we're trying to do is to say, as an aggregate, these are the different things that UCI did as a strategy for COVID, which includes remdesivir, this tool, hospital, home, etc. And this was the results. But being able to attribute the success to any one tool, I think, is really, really challenging.
Thank you. Okay, that's great. Daniel, thank you so much. We're finishing a few minutes early here. So this actually gives me an opportunity to thank the people who've really been involved in organizing this. Ilham, Sangyuk, and I have been full of suggestions and ideas and sent out some invitations, but in fact, most of the work's been done by 3 other people. Rebecca Taylor, who has been the administrator for the Institute for Immunology for several years now, before I was here, and still runs it. More recently, she became the administrator for this Center for Virus Research under Ilham. So thank you, Rebecca, from all of us. Also, Alyssa Sanchez and William Alvarez at the campus for organizing the webinar, making sure this has been running smoothly, which it certainly has. So again, I thank all 3 of you on behalf of all of us, of the organizers, and all of us. Phil, are you ready to talk?
Oh, sure.
Okay. Let me just give you a brief introduction here, Phil, before you get in there. I'm just going to read your entire bio sketch here, if not your whole CV. That'll make up the 10 minutes at least. So no, Phil is an institute unto himself here. He has been involved in vaccine research for much of his career. He developed what's called a primary protein microarray core for biodefense, and including setting up a core for the International Center of Excellence for Malaria Research. He is working on some 30 different infectious microorganisms, including viruses, bacteria, and parasites, using protein array technology, which he may tell you a little bit about. His current studies involved in his involvement in the vaccine. He's the director of the UCI Vaccine Research and Development Center here at UCI, which is an ORU, and has developed an antibody array for SARS-CoV-2 together with other viruses, and has done some 12,000 fingerstick blood specimens from the Orange County community, some of which Bernadette talked about this morning. But it's been a yeoman's work, Phil, and so please take it away.
Oh, thank you so much, Eric, and to everybody who's supported us for this last year. It's great to have an opportunity now to show some of the data that came out of this to all the supporters. Are you able to see this first slide now?
No, we're still seeing you.
Okay. Let's see. Oh, here we go.
That's it. That's great, Phil. Just make
Okay,
it full screen.
there we are. You already heard a little bit from Bernadette. It was great to hear Bernadette's summary of some of the interpretation of the data that we've generated. Our lab has been generating the data and making some of our interpretations on the immunology, but a lot of this work was intended for epidemiology, and it's just a thrill to see how that is coming together and informing us so much. I'll just give you a little bit of background on what this protein microarray is. I use this slide. It's not a SARS-CoV-2 slide. It's a malaria slide. It's a good example because there are people in the world who react tremendously to malaria antigens in sub-Saharan Africa. And then there are people like most of us here in the United States, we don't ever get exposed to that parasite. And so what we're looking at here is a protein microarray that has 5,200 different proteins printed on it. You can see the spots here. Each spot is a different protein, and we can know the coordinates of the protein, so we know what the amino acid sequence of each protein is on this array here. And on the left is the array probed with a person who's naive to malaria in the United States. And you see very, very little cross-reactivity against any of those proteins. But a person living in sub-Saharan Africa, even children, react to thousands of proteins from this parasite. And we can measure the intensity of all of the spots on this slide. And the intensity of this signal is proportional to the amount of antibody that was in the sample. The probing of these arrays is quite simple. Once we've made the array, you can see in this cartoon below, there's a protein there. And when we put the patient's sample in, we just allow that sample to incubate with the array. The antibody finds its target protein. We wash and then add a fluorescent secondary antibody and then wash that. And then we end up getting an array that we can image on a fluorescent imager. I'll show you in a moment. You can see the size of this. It's about the size of your thumbnail, this array. So today we're going to talk about the coronavirus antigen microarray. And the proteins on this array are mainly just two. There is the nuclear protein and the spike protein, but we have segments of the spike protein on the array. There's 10 features that you'll hear in the later slides. So this is the example of an array like this, a coronavirus array. Here, the red spots are intense signals derived from antibodies that are present at a high level in the sample. If it's a green spot, it's lower level, and if it's blue or black, it's down to negligible or zero level. There's 16 arrays on each microscope slide that we print, and you can get a sense of the scale that we've been producing these now. We've probed 10,000 samples and made over 2 million measurements with this. There's 37 antigens on the array. They're printed in triplicate so that we can get a statistical conclusion from each individual array rather than just having a single spot to interrogate. And in one study, for example, that Bernadette talked about this morning, we had 3,300 47 samples, that many spots, and we measure both IgG and IgM separately. The list of antigens is shown here. There's 10 SARS-CoV-2 antigens on the array. NP is listed on the top. We have different RBD variants and some S1 and S2 variants on the array. There's also SARS, other novel coronaviruses, SARS, the original one, and then MERS. There's 3 antigens from MERS. And then all these common coronavirus antigens, I think sometimes we call this causes of common cold. We have those on the array, and also a collection of influenza antigens. So this is a workflow. We start out by printing these protein microarrays with a robotic printer, microarray printer. It's running here. So it's able to pick up all of the different proteins and print them in a precise location on the array to produce those images that we've been looking at earlier. Once the arrays are printed, they're stable and can be stored for many years. When we set up an experiment, there's 16 arrays on each microscope slide. There's a chamber that goes over the slide so that we can put 16 different individual samples into each well and get the results from those 16 samples. This is what I showed a little bit earlier, that we call it the primary antibody. That's the antibody that comes from the patient, is incubated with the slide first. That antibody finds the antigen, and then we can probe with either an IgA secondary antibody that detects IgA or IgG, and they can have different colors so that we can get both IgG and IgA and IgM actually from the same sample from the same array. When we get the picture, we're using a camera system now instead of a laser scanner. And then once we get the images, they need to be quantified. And we have software to quantify all of the spots. And then computational analysis part of the pipeline starts, comes in. We have quite a suite of R scripts now to do a lot of this analysis. And this picture here is intended to highlight that we're using fingerstick blood here all the time. Bernadette brought that up this morning. We can do all of this with a very small amount of sample. Just a couple microliters is enough to get this result, and that's easy to collect into capillary tubes by fingerstick. It makes so many things a lot simpler if you don't have to do phlebotomy to generate this data. We would have never been able to do this size and scope of the project that we did here if it required phlebotomy. This slide really summarizes almost the entire year that we did. So I'll give you some more details on it, but this is the 10,000 samples that we probed from either from Orange County in Bernadette's summary, residents of the Orange County area, or the UCI healthcare workers collection. I'll show you that. So the results of this are shown in this bar graph on the right here. And when we started out in Santa Ana in the summer, there was a 13% positivity rate there. And we took another collection late in November, and it went up to 26%. And in the last week of December, after Christmas, it had jumped up to 36%. And at that point, we were thrilled because we could see a trend that was perhaps over a year or so could reach herd immunity. We always were talking about herd immunity. And this was really exciting data at that point. At the same time, at the UCI Medical Center, we have a captive population there. And in May, we were very early in getting these samples probed in May. There were 5% of them positive. And about 6 months later in December, that had gone up to 13%. But we saw this as an indication that there was good transmission control measures at the hospital, and it was going up more slowly than it was in the surrounding community outside the hospital campus area. But on December 16th, they started the vaccination campaign at UCI Medical Center. And this is another amazing story. I guess we're going to hear about that from Susan later. Within, I think it was 3 weeks, they had 6,000 people already vaccinated. And in the last week or two of January, we collected from the hospital. And that seropositivity rate went up to 78%. This was ridiculous. It was shocking to us to see that kind of performance. I guess you could have predicted it from the efficacy data that the companies were showing, but we're usually skeptical of things that seem too good to be true in science, and that one seemed too good to be true. But this is our own data. And this shot up, and it was spectacular. This is an amazing, amazing vaccine. We were pretty confident in this number, but we wanted to see another number. So at the end of February, we got another collection, and that went up to 93%. So this is real, what's going on here. If you look over to the left, you can see other examples. I'll show you a little bit more of this. You can follow the immune response in individual people. This is one of the people from our lab who was vaccinated with the mRNA vaccine. And here we're plotting all 10 of the antigens that we had on the array. And you can see this very nice time course. Some of the antigens come up before 7 days, and some take a little bit longer to come up, and you get a response to the prime, and then after the boost you get another response. And we're going to continue to follow these people to find out what the waning response is like to this vaccine. I don't know if this means it's starting already to decline. We're going to find out. And this is an interesting antigen. I'll tell you a little bit more about this. This is the NP protein. The NP protein is not in the vaccine. These are all spike derivatives. So this vaccine is causing a nice response to the spike. And because there's no NP in the vaccine, we don't get a response to the NP. So what can we learn from this? We can ask and inform about answers to questions of this kind. Could I have immunity to the COVID-19 virus? How long does it last? Do I need the vaccine if I had COVID before? Can I go to work yet? Which vaccine is better, and when do I need another shot? So I'll go through some of the data a little bit more detailed so that you can get a sense of how we analyze and interrogate these results. This is a heat map. This is usually the first thing we do when we get a collection of specimens analyzed. In this particular heat map, there's 371,000, what was it? No, 3,347 specimens from that many people, finger stick blood specimens. And this is the other amazing thing about this whole collaboration here is that the our public health department took responsibility for getting all these samples in drive-through collection centers around Orange County. So here is the list of antigens on the array, like I showed in an earlier slide. The SARS-CoV-2 antigens on top, the SARS and MERS and common coronavirus and influenza antigens. And I guess starting with the common coronavirus antigens, let's look at this. Wherever you see red here, it means there was a lot of antibody in the samples. When it's black, it's kind of an intermediate amount. If it's gray or white, it's there was very low amount of antibody in the sample. So the antigens are in rows here. There's common coronavirus, flu antigens here. And just so you're aware, every column, if you can see these thin lines on the top, that's an individual sample. So we're looking at all the individual responses from all of the individual samples on this heat map. And what you can see is that almost everybody has lots of reactivity to coronavirus. Then also everybody with flu exposure every year and flu vaccination, we all have a lot of antibody to flu antigens. But for the novel coronaviruses, and especially SARS-CoV-2, there are, I'll show you in a moment, that this earlier in the outbreak, almost nobody had any antibodies to SARS-CoV-2. But now this is a recent collection from Orange County, and there are positives, obviously positives in this collection. And we use this orange and blue classification here to show which ones are positive, predicted positive by an algorithm that we use, and those that are negative. Let me see if I can get to the next slide. Okay. I want to let you know that everybody who gives a sample gets their own individual report sent to them by an email attachment. It's shown here. I won't go through it, but everybody will know who gives their sample precisely what their antibody levels are against all 10 of those SARS-CoV-2 antigens. And this is what the this kind of data looked like in May at the very earliest time during the outbreak after it started. What you can see is almost everybody here is gray. And 4.7% of these people way to the left are classified positive. In December in the hospital, we went up to 13%, still quite low. But then weeks later in January after vaccination, all these people, look at all these people, how positive they are. Amazing. And then in February, at the end of February, just the majority of the people that were in this collection were seropositive. I'll point out a couple things. This is the, we already pointed this point before. The NP protein doesn't react in vaccinated people. That's evident here. So this is these are vaccinated people. They're not reacting to NP because NP is not in the vaccine. And here it is at the later time point. We did notice something from this, that the people who have NP reactivity, because they were previously exposed. So when we see NP reactivity, it must have come from the infection because it didn't come from the vaccine. So this is these are people who had the infection and recovered from it. In those groups, we feel that they have been primed. And so they induce a stronger response to the vaccine than the people who were never had never experienced a exposure. And we could prove that result with this analysis comparing the NP reactive people to the people who were not reactive to NP. And if they were reactive to NP, they reacted more to spike than the non-reactive people do. That was true for all of the different antigens that we had on the array. And this is a survey of 9 people from our lab, so you can get an idea of the time course, the longitudinal response to the vaccination, and a sense for the diversity in the responses that people have to this vaccine. This is one of the older members of our lab, and he responded to the prime with a fairly weak response, but he made a nice response to the boost. And then another individual had a nice response to the prime and also a nice boost. This is an interesting example of the one person in our lab who recovered from actual case of COVID. And so what do you think is happening there? The baseline reactivity to all these antigens is a lot higher in her because of the previous exposure. And she did respond when given the prime, and she actually had quite a severe hyperreactivity to the vaccine. She complained that the vaccination was worse than the infection. But after the boost, she didn't continue to go up. You can, what is this blue line here? This is the NP. Look how low the NP is in many of these other members of the lab. But then there are some members who probably did experience a prior exposure because their background is elevated. Some of the people responded more to the prime. You can see this member was already quite reactive after the prime and didn't go up much farther after the boost. So the point is that everybody responds differently to this vaccine. We can quantify be more quantitative about the antibody responses by doing titers. So that would be taking a one-person sample and doing serial dilutions of it and producing titration curves. So you can see here the titration curves for this individual are shifted pretty far to the right. If you look at what his response was before the boost, this is after the boost and this is before the boost. Before the boost, the titers are lower, and after the boost, the titers are higher. Same with this other member in our lab. If we plot these titers on this two-dimensional plot here, we can compare the response. This is the boosted response from one individual in our lab and the other individual in the lab. What's interesting about these 4 specimens in the front, they are from recovered patients who were convalescent and had the infection and recovered. What you can see from this is that the titers of their titers are lower than the titers that are induced by this vaccine. This is a spectacular vaccine. It's I don't think we would have been expecting it. Actually, the FDA wasn't expecting it either, and they were prepared to approve something that would work much less well than this. So why do the mRNA vaccines work so well? This is the virus and the vaccine. The RNA is made from the viral RNA, and it can enter cells, but in order to enter cells, you need a special lipid nanoparticle. We are referring to it as the secret sauce. You need that in order to get the RNA into the cells. And then when the RNA gets in and the protein is expressed, we now know that we can generate a powerful immune response from that. This nanoparticle has been studied for a long time now, and it has been shown for many years that the nanoparticles can introduce the RNA into cells. So there's a history and a legacy to this. And I got a email from my colleague at Syntex back in 1984. He took his lab book entries. His name is Rick Roman, and this is the synthesis that he did. It's called DOTMA now. And we published that it delivered nucleic acid into cells in PNAS in 1987. And this is the reagent. When I left Syntex, they gave me this as a souvenir. This is the liposuction reagent that we sent around to people before it became commercialized. And this is the first RNA delivery paper, was written by Bob Malone. And this is the lipoplex that is the particle that makes this all work. And I wanted to show this timeline here because it's an example of what happens in science, how things can start a long time ago, and then it takes many years of investment and literally thousands of people who have been working on it during this time. There was the liposuction reagent, and then direct gene transfer into mouse muscle, and nucleic acid vaccination was studied and supported by investors and by the NIH. And all of this work has come together, and we were poised today to respond this way to this crisis. And I just think that that's an amazing success. That's what we talk about, that sometimes science can be prepared to respond to things. I think people expect us to be able to do that, and sometimes we don't match their expectations. But boy, this time it's amazing. So Pramod asked us to look ahead. So what does all this mean to us? Looking ahead, the COVID response landscape changes so rapidly. So what seems like the right thing to do today changes tomorrow. And I think that's one of the things that, the pace that everything's been going at, it's very atypical. We usually get ideas and write a grant, and a few years later start doing things. But this has just gone at just a totally different pace. We have PCR testing. The PCR testing will tell us if we're infected and could infect somebody else. The thing is, this vaccine is working so well that there are going to be fewer and fewer people testing positive. And what happens when there's fewer people testing positive, the positive predictive value declines. We're right now at about this point with the PCR testing, but we're going to be heading in this direction, and the positive predictive value is going to go down. So we need to think about how we're going to use the PCR test in a declining positive predictive value. And how does the, come on. This is where we are actually with the antibody test. It's a different kind of test. It has different questions and different consequences. I'm immunized, you can't answer these questions with the PCR test. Am I immunized? How long does it last? Can I go to work yet? Which vaccine is better? When do I need another shot? These are the kinds of questions we can ask with the antibody test that we can't ask or answer with the serological test. We're right here now around our area in the hospital where all this vaccination has been going on. So the positive predictive value of the PCR of the serological test is very, very high. It's not this way all over the country, but I would probably say it's probably somewhere in here still a very high level. We're going to want to know who's negative for antibody, who is not immune, and there the negative the negative predictive value is going to be important. We're going to want to say you're negative for antibody, you should get vaccination. That's the kind of information, actionable information we would want to apply. So this has just been spectacular. Our lab doesn't collect any specimens except from some of our lab members, a few people, and we've collected 10,000 specimens. So that obviously that was being done by lots of other people. And Bernadette and Daniel Perker were leading the public health program, and Sebastian Schubel, the hospital network. And these are some of the key people in my lab, but everybody in my lab actually works on this as a team. So I don't know if I have a minute or two for questions, if you'd like to ask some questions.
That is great, Phil. We're not able to activate our videos here. Not sure if you can fix that.
Oh,
this is actually to start my video. Okay.
Oh yeah, there. Okay.
Am I here now?
Yeah.
That was great, Phil. I mean, really a tour de force, no question. Beautiful technology, beautiful application, and just classic responses. I mean, for those of us who teach immunology to, undergrads, grad students, and medical students, the response from the vaccine and the absolute to the spike proteins, and the absolute absence of a response to the nucleoprotein is just textbook. I mean, that is just classic. Yeah. So, we're going to use those slides for teaching the coming up.
Yeah, I don't think we could have hoped for that. It's beyond what I think even what the FDA and other experts predicted would happen.
Right, no, it's remarkable.
Yeah.
A couple of questions. One is one of the things I noticed anyway was that the older members of your group, no names mentioned, of course, Phil, there wasn't a lot of response to the initial vaccination. You really needed the boost before you see this further. Is this something you can generalize to folks over a certain age?
Well, we can generalize it from our population so far, but what this really needs, I've been talking to our colleagues, it's easy for me to say, let's set up a clinical protocol where we have a statistical sample of people of different ages, but it takes a real commitment to do that. And but that would be the ideal thing, and we're going to want to do that kind of thing. We're going to want to do it with the Moderna and with the Pfizer vaccine, and then with the J&J vaccine, and to compare all of these.
Right. That's one of the questions that came up was, are there any data for similar experiments participants who were vaccinated with J&J vaccine?
Yeah,
we'll be able to get those samples, and I'm sure even though we're not doing AstraZeneca here, it's being used around the world.
Yeah,
even in Europe after that hiccup, they're going back to it. So it would be good to find the results to those as well.
Yeah, that's the thing. I don't know how to bring this across, but what was so unique about this is that we were committed here to collect these samples. So just to say that the samples are going to be available because there's going to be a lot of people getting the vaccine, they aren't going to be available to use in a trial unless somebody sets up that protocol and then goes out and collects the samples. So it's there is that hurdle.
Bernadette and Danielle are going to be quite busy, it seems.
Yeah.
To move ahead with that. So, question from Nick Warren: any idea regarding the titer of boost with vaccines for people who are immunocompromised?
We don't have that classification. There may be something. We have biorepository samples, and it's loaded with metadata, and we haven't parsed through all of that data yet. And there is that information, and I believe we have some of those kinds of trends that the response is weaker in the immunocompromised, but we'll be able to make a clear assertion of that.
Jim Hall has a one-word comment: spectacular, with 2 exclamation marks. Okay, so that's it's good when you get 2 exclamation marks. So note from Calvin Lee, let me just read this. In your array data set, have you compared the naturally occurring immune responses with vaccine triggered immune responses? And how will the patterns look like? But I thought you showed that.
Yeah, I can just summarize it again, that people who had a previous exposure react more strongly to the vaccine with a stronger antibody response than other people who were naive.
And he also asked, could you relate that to how long people were sick, or even how sick they were?
I wouldn't say that we have a statistical sample of that yet. There's a lot more work that we're going to do with the biorepository samples. There we got, and from many of the people in the biorepository, the people who were treated at the hospital, they took blood samples every single day while they were in the hospital. So we were able to get the longitudinal data from them, and we can expect to correlate that with their clinical history.
Okay, Mike, you get the last question.
Phil, you mentioned the common coronavirus. You were talking about OC43 or 229E. And do you expect to see a boost in antibody to the common antigens in those coronaviruses with vaccination as well? You have the discrimination to see that.
Yeah. You ask.
I mean, have you cured the common cold?
Oh yeah. Oh, okay. What we tried to look for first was if we could get evidence of cross-reactivity that people with SARS-CoV-2 infection would cross-react with the common coronavirus antigens. And that is very weak. That it's probably barely statistically significant, but not very strong. And but your question is, does the vaccine? And I guess I was thinking so much about that other question I just told you. I haven't really looked at that part of it. It's probably not very obvious, if at all.
The vaccines are mainly targeting the S.
Yeah.
Okay. Well, let's leave it at that. We're about 5 minutes over, but I think I'm going to take moderator's privilege and say we're still going to take a 10-minute break, and we'll come back at 2:45. Sorry, not 3:45. Back at 2:45. Thanks to all the speakers in this session. Really excellent session, and we'll come back with Ilham Masoudi at 2:45. Thanks. Hi everyone, welcome back. We still have a good cadre of 72 people tuned into this afternoon. So thank you all for staying on and for joining us. Thanks again to all of our speakers. And so let me start this session by introducing Ilham Masoudi. Ilham is a professor in the Department of Molecular Biology and Biochemistry here at UCI. We were able to steal her from UC Riverside back in 2017, and she is now led to, never mind the professor thing, she is the director of the Center for Virus Research, and that's really her claim to fame. But Ilham's done quite a bit of work on pathogenesis of emerging, re-emerging viral infections with some really scary viruses, including yellow fever, Ebola, the H1N1 flu virus, chikungunya, and others. She works with patients. She works on maternal antibodies and transfer through the placenta, and she has now more recently been working on COVID-19. She also works on aging and immunity. She is an outstanding investigator and an outstanding friend and colleague, and it's absolutely my pleasure to introduce Ilham. The title of her talk is Expansion of Pathobionts in the Nasal Microbiome from COVID-19 Patients. That's pretty specific, but okay. Thanks, Ilham. We're not hearing you if you're saying anything.
I'm not. I'm just smiling at you.
You're smiling. Okay.
Thank you, Eric, for that really lovely introduction. And yeah, I figured this afternoon I'd like to present some new and exciting data that was literally generated over the last 3 months from an idea that we concocted in the lab while we're looking at nasal swabs. And so today I'm going to talk to you about the microbiome and as well as the host transcriptional response in nasal swabs. And then we're going to end with a little teaser about to present some of the work that my lab is doing, looking at molecular mechanisms of vaccine responses to COVID, of course. So at this point, we all know that SARS-CoV-2 is a respiratory pathogen. It's transmitted via droplets as well as potentially aerosols when there's an aerosol generating procedure that happens, and much less likely via fomites. And of course, the first route of entry really when it's transmitted via the respiratory route is going to be the upper respiratory tract. We know that airway epithelial cells express very high levels of ACE2 as well as co-receptor TMPRSS2. The virus enters, is able to infect this respiratory epithelium and replicate to very high levels here. And then depending on how that local immune response is generated and progresses, there is a very strong belief that the local immune response in the nasal epithelium can really direct the course of this disease. So if we have a very robust and efficacious early mucosal response with all the right players, with dendritic cells picking up antigen from infected epithelial cells and activating the appropriate T cells in the nasal-associated lymphoid tissue and getting antibody responses in conjunction with a robust innate immune response to occur very rapidly, we can kind of stop the infection in the upper respiratory tract. Whereas an immune response that's not very efficacious or is delayed for whatever reason due to cofactors such as age or smoking history, obesity, who knows what other things, can lead to progression of the disease to the lower respiratory tract and then the ensuing cytokine storm and worse clinical outcomes. However, most of the studies to date have really kind of focused on the immune response in the blood, or to a much lesser extent, the immune response in the lungs. And those were mostly in cases of severe infection. And very, very, very few studies, if any, have really looked at the immune response in the nasal microbiome. So there's a lot of reviews that are written about the potential role of the nasal cavities and the nasal epithelium and the nasal, the associated lymphoid tissue, but there's actually very, very few experiments and primary articles that have addressed this question. And then even less rare is the interplay between potentially the nasal microbiome and infection. So just a brief introduction to the nasal microbiome. So we know now that pretty much every surface in our body has a unique microbial community that is well-defined and quite distinct from other places. And the nasal microbiome is characterized by very, very low biomass and is dominated by primarily actinobacteria as well as firmicutes, which is very different than what we have in the fecal microbiome where bacteroides and firmicutes are dominant. And if we look specifically at what kind of genera is inhabiting this community, we know that Corynebacterium as well as Moraxella and Staph and Strep are sort of like the dominant players in this very low biomass microbial community, which is very different from, for example, a bronchial microbial community, which is a lot more diverse than what we find in the nasal microbiome. And the nasal microbiome as well changes dramatically with age. And I'll just point a couple of things here. So if we focus on the nasopharynx, we can see that it changes quite a bit as we get older. And what I really want to draw your attention to is this little segment here labeled other. And so one of the big changes that occur with age is this expansion of other bacteria that don't quite belong in the nasal microbiome. And this is believed to be mediated primarily by a loss of strict compartmentalization between the various sites. So we start seeing infiltration from the oral as well as potentially other microbial communities into this community. And this is a phenomenon that's referred to as dysbiosis. And so again, in the multitudes of reviews that are out there, it's generally believed that the microbiota plays a really important role, and that in the event of dysbiosis, which is highlighted here, this could lead to barrier dysfunction and failed immune responses. But even these reviews are really focused on the gut microbiome and disruptions in the gut microbiome. And so we thought we should really just investigate what is happening within the nasal communities. And so we, with the help of the COVID-19 Biospecimen Bank, and really huge thank you to Dr. Rob Edwards and Dr. Delia Turfea, who have done just a humongous amount of work to really help us with this. But we collected nasal swabs, discarded remnants from nasal swabs from COVID-19 patients who are at the hospital, as well as patients who had come in for elective surgery who had to get tested because they were at the hospital and everybody was undergoing mandatory testing, as well as healthcare workers. So this is piggybacking on another study that we had looking at asymptomatic shedding and transmission within the hospital setting. And all these swabs, these VTMs, we extracted RNA, and then we leveraged this RNA to do a couple of things. One, of course, look for SARS-CoV-2 by RT-qPCR, but also sequence the viral genomes, carry a nasal transcriptome study, and then took advantage of the fact that there's always a little bit DNA that comes across the RNA extractions to then also use 16 as amplicon sequencing and look at the nasal microbiome in these samples. So from 200 microliters of remnant viral transport media that we were able to collect, we were able to do all of these experiments. And so the first thing that actually made us really happy, because we weren't sure quite about using carrier DNA and following RNA extraction to really look at the microbiome. That has not been done before. And so we were very happy to see that in these samples, we were able to identify the main phyla and genera that usually occupy the nasal microbiome. So in our samples too, Corynebacterium, Staphylococcus, were very dominant, and that reassured us that we really, that our method was not completely crazy. I was innovative instead. But this, even at this big 30,000 foot view, we are able to see that there are interesting changes that are occurring. So if we look at patients in the hospital who are COVID negative and compare that to our healthcare workers who are COVID negative and our COVID-19 patients, we can see that even at this very high view, that there are some interesting differences between these three groups, sorry. So we can see that the Prevotella, for example, the relative abundance of Prevotella increases with COVID-19 infection. So does the presence of a couple of potentially opportunistic pathobionts like Haemophilus and Pseudomonas. There's this really interesting expansion of Burkholderia in healthcare workers. And so this really prompted us to do a lot more analysis. So if we just look at the, we're just now looking at diversity and looking at the number of observed species that we can glance from these sequencing runs. We can see that in the COVID negative patients at the hospital, we have very low diversity, which is what's expected. So the nasal microbiome is low biomass, low diversity. But our healthcare workers had actually a statistically significant increase in this diversity, and so did the COVID patients. And if we look at this principal coordinates analysis, we can see that these three groups of individuals, even though they slightly overlap in this two-dimensional space, they're actually quite distinct. And we can use this PCOA to calculate unifrac distances within the groups, which tells us again about the diversity within each group. And this confirms the data that I showed you in the previous slide, which is that there is more intra-group variability. So there's more, there are more species, there's more diverse bacterial diversity in the healthcare workers and COVID patients relative to COVID negative patients. But there is also more variability within this, both the healthcare workers as well as the COVID patients relative to the non-COVID patients who are in the hospital. We then did a left-C analysis to identify bacterial species that were more abundant in one group relative to the other two groups. And this analysis pulled out a few interesting genera for us to look at. And so again, we can see, just like I showed you in that original bubble plot, that in healthcare workers, we do have this expansion of Burkholderia as well as Klebsiella. And then in the COVID-19 patients, we see an expansion of a ton of opportunistic pathogens. And this is just a subset of those, but Raffia, Acinetobacter, Pseudomonas, and Marxella are more abundant in this group compared to the other two groups. And just to show that this wasn't that the main genera that we know should be very abundant in the nasal community is still pretty abundant and is comparable between the three groups. So this is just showing you Staphylococcus as an example of that. And we were actually able to then speciate the Burkholderia that was more abundant in healthcare workers, and that's Burkholderia cepaceae, and it's kind of been associated with nosocomial infections. We also just at the genus level, Escherichia was more abundant in healthcare workers. But where things get a little bit more interesting is when we looked at Pseudomonas, we were able to speciate that to Pseudomonas aeruginosa, and that was statistically significantly more abundant in COVID patients compared to both the healthcare workers as well as non-COVID patients in the hospital. And we also saw an increase in Acinetobacter levels. And if we, sorry, I forgot to animate this. Actually, if we also look at the Pseudomonas aeruginosa abundance, that increased steadily with the viral load. And so when we categorize these patients into high CT, low viral load, mid CT, medium viral load, and then low CT, we can see that there is a CT dependent increase in the relative abundance of this opportunistic bug. So next, we decided to look at the host transcriptional response and how it differs between, so in this case, we're looking at, we're comparing our COVID-19, the nasal gene expression in COVID-19 patients compared to our healthcare workers. And we find pretty robust transcriptional changes with 200 genes that are downregulated or upregulated. And when we take these differentially expressed genes and ascertain or ask where is the origin of these genes, what are the cell types that are most likely to express these genes, we can see that they're coming primarily from bronchial epithelial cells, some immune cells, trachea, monocytes, and dendritic cells. So this was reassuring that we were not looking at some weird contaminants, and this was really gene expression changes that are occurring within that nasal cavity. So we take the genes that were downregulated and did a functional enrichment on those, and we were quite surprised, and I guess in a way this makes sense, but these genes enriched to gene ontology terms that had to do with, to some level, nerve damage, so response to axon injury, as well as some epithelial cell differentiation, chondrocyte differentiation, sensory system development. And this is really, I think, in line with some of the clinical observations that we now have with COVID-19 patients, loss of smell, and that could persist for a really long time. And when we look specifically at what type of genes are being downregulated, there's a couple of genes here that are really important for either maintaining barrier function or regeneration when axon injury occurs. As well as a couple of solute receptors that we know are important for barrier function. There's a couple of mucin genes in here, again, in line with damage to the epithelial barrier. And then when we look at the upregulated genes, we see very strong and highly statistically significant enrichment to go terms that deal with innate antiviral immune responses. So type 1 interferon signaling, defense response to virus, and inflammatory response. And that's really highlighted here. If we look at this group of genes that enrich into that GO-term type 1 interferon signaling pathway, we can see that this is a very good list of all the interferon stimulated genes that we expect to see. So STAT1 and MyD88, as well as a number of IFIDs and genes that we know are really important for inhibiting viral replication, especially RNA viruses at various levels. We also see upregulation of MHC molecules are important for, obviously that's kind of suggesting that there's probably more robust antigen presentation that's occurring. Upregulation of restriction factors like BST2, which inhibit viral release, and a whole number of other genes that are involved in apoptosis, which is also in line with the damage that's occurring to the epithelial cell lines. So we also then wanted to look at these build genomes from these swabs and to try and look at the diversity of the viral genomes that we have. And this is, again, super preliminary data, but I still wanted to share it. So as others have reported, we get very, very nice genomes that are 100% complete from swabs that have a CT value between 10 and 20. Whenever we get between 20 and 30, then it's kind of a hit and miss. We sometimes get really good genomes, sometimes we don't. And anything above 30 is sort of like, we can sort of kind of assemble genomes, but they're not really complete. Pretty much, we identified a number of mutations in the genomes that we were able to assemble. what I thought was really interesting was that if we look at the relative proportion of genomes with a certain number of mutations, we can see that in the samples with the lower CT, and by the way, these are all mutations relative to the original sequence deposited from the Wuhan strain. But we can see that the swabs that are collected from individuals with a CT value that's between 10 and 20, so pretty high viral loads, harbor more mutations. So they start at 8 to 10 and go up to 14 to 16 mutations, whereas the 20 to 30 have lower, there's just a lower number of genomes with significant mutations in them. All of the genomes that we assembled harbored this mutation D614G in spike RBD, and this is now dominant. This is in circulation everywhere. They also harbored a couple more mutations across all the genomes that we sequenced, and we're still investigating what these potentially could mean. So this is all, like I said, very fresh data. We did identify one of our genomes did have one of the mutations that's been described in the South African strain, but it's in the nucleocapsid protein. And so our job right now is we're trying to place these genome sequences within a phylogenetic tree to look at how they compare to some of the variants that have been described. And we're actually downloading sequences from California variants so that we can look at that. And so, as I said, I'm going to pivot towards the end to sort of give you a little bit of a snapshot of what we're doing in terms of vaccine response. So Phil did a great introduction, and I don't need to go over this, but DNA RNA vaccine sorry, have now garnered emergency use authorization, and now Johnson & Johnson, which is a recombinant adenovirus, is also been able to garner emergency use authorization. And these vaccines are amazing. They're like very immunogenic, and they're eliciting wonderful immune responses. And we wanted to kind of start teasing apart the molecular mechanisms of how we're responding to these. And so this is very preliminary data looking at a total of 4 samples from 2 males, 2 females. One of the males is an older person. A blood sample was collected pre and post vaccination, and we obtained plasma and PBMCs and carried a number of antibody titers, new titers, immune monitoring, and did single cell RNA sequencing in order to understand the shifts that occur in the T and the B cell repertoire with vaccination. So as Phil also showed, this is an endpoint titer. So I'm not showing you all the dilutions. I'm just showing you the dilution at which we achieved an OD of 0.1, which is pretty robust. And this is a log 10 scale. So you can see pre-vaccination, nobody had any detectable antibodies. This is still considered background, but everybody seroconverted very nicely. Nobody has responses to NP, again, because they're not exposed to SARS, they're just exposed to the vaccine. 3 of the participants also developed beautiful neutralizing titers. Again, this is a log 10 of the dilution factor. So can see that the 2 young females generated the most robust neutralizing antibody responses, followed by the young male, and the older male did not quite get, we didn't quite catch the neutralizing antibody. So there could be some interesting changes in the kinetics of the immune response that occur with age that we would love to explore more. This was accompanied with a nice increase in the frequency of interferon gamma IL-2 double positive CD4 T cells. And I realized that the scale is really small, but in order to see significant changes in circulating cells in the blood, you don't need very many cells, very many CD4 cells in the blood to get really to be reflective of a great immune response and immune help that's occurring in germinal centers in the lymph nodes. The other interesting observation that we made was that the levels of HLA-DR and CD86 were decreased. So in the case of HLA-DR, both total and classical monocytes, which are the dominant number of monocytes. And then we saw this decrease of CD86 mean fluorescence intensity that was occurring in the non-classical monocytes. And this was in all the participants. And the reason why I bring this up is this is one of the hallmarks that we see with SARS-CoV-2 infection. So a reduction in HLA-DR is a consistent phenomena that we and others have reported on post SARS-CoV-2 infection. And considering that none of these participants have been infected with SARS, they just got vaccinated with the Pfizer and Moderna vaccine, this is raising some interesting questions in my mind with regards to what S could be potentially doing to myeloid cells, and what sensing of S is doing, and what are some of the inflammatory pathways that interaction with S, with the spike protein, could potentially be doing here. But overall, this is literally a UMAP that we were able to generate late last week. We've been working on teasing apart. So we actually sorted memory B cells and memory T cells and plasmablasts only. So that's why this UMAP, you can only see the B cell subsets and the T cell subsets. But we are able to identify basically starting with immature B cells that are just IgG high and IgM high, to those that are starting to switch to IgG, IgA, or in the process of selecting one of those heavy chains. So we can go from immature to mature B cells in this UMAP. We also are able to identify the different subsets of memory CD4 and CD8 T cells, so central memory and effector memory for both subsets. So what are some of the big changes that we're seeing? So some of the exciting things that we're able to detect right away is that in relative to baseline, so in this, so I forgot to mention that in the single cell RNA-seq, we also added 4 participants before and after, and 30 days after they had SARS-CoV-2, and they all had mild disease that did not require any hospitalization at all. So we would like to compare the TCR and BCR repertoire in convalescent versus vaccinated individuals, which was the goal of this experiment. And so some of the interesting changes that we're able to see is that relative to baseline, our vaccinated individuals have a significant decrease in this immature subset that is only IgM and IgD positive. And they have a big expansion of these IgA positive antibody B cells, producing B cells. In convalescent patients, we see relative to baseline an expansion of this subset that is IgG positive primarily. So that's what's happening in the B cells, and we're gonna start looking at B cell receptor repertoire diversity now and compare it between the vaccinated individuals and convalescent individuals. In terms of what's happening in the T cells, relative to baseline, convalescent patients have an expansion of CD8 effector memory cells, as well as an expansion in the CD4 effector memory cells. In the vaccinated individuals, we see more robust changes in the CD4 subset, and we actually see the appearance of this subset here in purple that I know is really probably hard to see on your screen, but these are really highly activated CD4 T cells, and they increase quite substantially post-vaccination. We also do see a small increase in the CD4 central memory population. And so I would like to thank the lab members. Again, just like as Phil described, it's all hands on deck in the lab. So in terms of the nasal microbiome and transcriptomics analysis, Brianna did the qPCR with Isabella, who's over here. Nick did all the 16S with help from a rotation student who was here this past quarter. Alan did the analysis of the RNA-seq. Sloan and Suhas have been leading the charge on the single cell RNA sequencing. Michael does all of our flow. Amanda's our viral genome sequencing guru. And Michaela does antibody titers. So everybody is got a role. And this work would not have been possible without, again, the COVID-19 Biospecimen Bank. And I really want to thank Rob and Delia for all they do to help. And of course, I'd like to thank the flow cytometry core and Jen for coming in and helping us sort our memory populations, the genomics core that really prioritizes COVID research and has gotten able to turn around sequences for us pretty fast. Of course, my colleagues at the Center for Virus Research and the ICTS for their help getting specimens. And I'll stop here and take questions.
That's great, Ilham. Yet another tour de force. I want one question going back to your microbiome issue, actually. But one going back to the microbiome, did you ever think of looking at the fungal microbiome? I mean, we have yeast, we have all kinds of things.
No, I really actually.
Bacteria.
No. I literally had that conversation yesterday with Suhas and Nick, and we just have to go back and do a different, we have to do an ITS amplification and look at the ITS sequences. And Nick actually has been looking at building a pipeline for looking at the fungome. And we got some great help.
Mycobiome, they call it.
Mycobiome, sorry, the mycobiome. And we've gotten some great help from David Underhill at Cedars-Sinai in terms of pipeline. So yes, it's on my mind.
Glad to hear it. Never you don't want fungus to escape your mind.
No.
So there was a question here that actually ties in with my own question relating to what seems to be the inverse relationship between the amount of virus and the amount of Pseudomonas that you're showing. So it seems to be inverse. The question from WeFam is, because it's a Pseudomonas, is there any evidence? So my question was, which is regulating which? Is the Pseudomonas regulating the COVID, or is the COVID regulating the Pseudomonas? Which is a similar question to WeFam's question, asking if Pseudomonas contributes to the severity of the disease.
Right. So I think Pseudomonas is really the canary in the coal mine. So it's a pathobion and an opportunistic pathogen that loves inflammation. And so in these patients with low CT, which means very high viral load, very high viral application, and those are actually the samples that I showed some of the RNA-seq data from. We're actually working on sequencing the rest of the samples that are in the mid and high CTs. But there is a ton of inflammation that's occurring. And I think it loves inflammation, it thrives. That inflammation and probably a lot of those inflammatory genes are killing off the commensals and therefore making room for this opportunistic pathogen to flourish. So I would say that the SARS infection and the ensuing inflammation is what's facilitating the colonization by Pseudomonas and then the flourishing of that bug.
So just on that note then, does the inflammation contribute to the anosmia, the loss of taste and smell, or is that strictly viral infection as far as you know?
That's a great question. I mean, I was really pleasantly surprised to see that some of those downregulated genes were enriching to these go terms that did with axonal injury and sensory system development. And so I think it's the virus, somehow the viral infection, and potentially it could be indirectly via the inflammation, but I almost think that the viral infection is sort of destroying some of those sensory endings. The nerve endings are somehow getting damaged, and that's what's leading to the loss of smell.
Yeah, because it's reversible. And is that reversible because the virus is gone or because the inflammation goes down?
Right. And it's hard to extricate one versus the other than I will say that we have a number of respiratory pathogens that destroy the nasal epithelium, and we don't necessarily experience the same loss of smell, right?
So Hugh Davis is asking if the single-cell RNA-seq data was from PBMCs, which I think it was, wasn't it?
Yes, so it's from PBMCs. We sorted we sorted memory B cells as well as plasmablasts and memory CD4 and CD8 T cells. And then did single-cell RNA-seq on that as opposed to total PBMCs, because we wanted to be able to capture those shifts in the T cell repertoire. And if we had sorted the entire PBMCs, I think it would have been a complete, there's no way we would have pulled out the clonotypes that we're able to pull right now. And the data is too for me to have shared, but we are actually identifying expansions of specific TCR and BCR clonotypes in response to vaccination.
That's great. Hugh also asked if you would expect to see something different either in the in lymphoid tissue, and I would ask, would you expect to see something different actually in the lungs of infected patients?
Yeah, I mean, yes, the answer to those questions is absolutely, which is why it's great to have animal models to do some of these. So I'm definitely circling back to some of my colleagues at Rocky Mountain Labs, especially my colleague Andrea Marzi, who some of you may have heard, but she has the hamster model up and going, and she has a non-human primate model. And RML was one of the big sites for testing these RNA vaccines. And so we're sort of going back to try and ask some questions about
Okay.
Where do the local events look like in the draining lymph node following an IM injection compared to what we see in the blood?
Excellent. There are no other questions. I think it's time to thank Ilham for an outstanding talk. And let's move on to the next speaker, who is Michael Buckmeyer. And Mike Buckmeyer is another institution unto himself. He's been working in coronaviruses for a good part of his career, was very much involved in the SARS-CoV-1, the first outbreak, where he went to China to actually work in the field with this. And the title of his talk today is the so-called life of a pandemic coronavirus. So Mike, thanks for agreeing to join us here, and we're looking forward to your talk.
Can you hear me?
Yes.
Okay, I'm going to try to make the laser pointer work here. Okay, good. So the life of a coronavirus. When we talk about a virus, there's a great debate that goes on and well into the night with a lot of scotch, and that is, do viruses really constitute life or not? And I think that the issue here that's important is how this virus survives from generation to generation. We've talked a lot about mutants and variants, and I'm very glad that Ilham showed that one slide that showed all the mutations that they found, because one of the things that happens that we don't talk about is all the random mutations. So one of the things I'd like to cover before I finish today is to just bring some of that into focus. So in any event, let's go ahead and start. First of all, the question always comes up, where are we going to be a year from now? And I think that if you look at the history of the coronaviruses, mouse hepatitis virus, porcine transmissible gastroenteritis, turkey, chicken, bovine, feline, human coronaviruses, these have been with us for a very, very long time. Some of these have been with us since the 1930s in terms of discovery. So I think we'd better probably buckle up our shoes and get our vaccines and be prepared to live with this virus for a very long time, unless we can miraculously vaccinate the whole population of the world, which is not likely to happen. But if you look at the human coronaviruses, 229E, HKU1, Hong Kong University 1, the Netherlands 63, and OC43 are common coronaviruses, which cause fairly minor upper respiratory disease. And that should be the goal that we're looking for, that we can live with a disease that's minor. We can't live with a disease that's killing people and that's paralyzing the economy. If we look at SARS in the 2003 outbreak, this caused an enormous scare. This was the first pandemic in the 21st century. And it killed, by today's standards, a laughable small number of people, only 778 with 8,000 cases. But what it exhibited was 10% mortality among the infected individuals. And so we have to bear in mind that these have the possibility of being much worse than we're experiencing now in terms of mortality. If you look at the Middle Eastern Respiratory Syndrome, this hints at this as well. 827 cases, 287 deaths. And SARS-CoV-2 and COVID-19 disease, the current pandemic, we don't really know where that's going to end. It looks like it's becoming a little less problematic, but it may be becoming more problematic if the variants really cause problems. So this is what these viruses first looked like in June Almeida's pictures, basically looking at something that had a large corona of spikes. And this is from Alex McPherson by atomic force microscopy. And this is now what we're up to now. So, those others seem quite quaint from this image. And this is a reconstruction of the virus from an actual image. And it illustrates a number of things. And one, of course, is the spike. We all know about the spike because that's been the target of all of our affection for some time. But what you don't probably know about is this protein here, for example, which is a channel. And that channel maintains pH inside the virion as the virion is passing through the ER. And here's another one. This is the M protein, the membrane protein, which always exists in a dimer and penetrates all the way from the inner part of the virus to the outer part of the virus. And then finally, the lipid monolayer. What you don't see here is you don't see the internal proteins, and that's fine for now. But the uniqueness of this virus is almost solely attributable to that spike protein, which exhibits an enormous potential to infect and to infect very efficiently and spread from person to person very efficiently. And so what we have to look at is, how did this virus come to be? We know that precursors of this virus exist in bats. These were shown as long ago as 2007. So they're really nothing new under the sun, but we never dreamed that they would come out and cause the kind of disease pattern that they do now. So I think we have to bear in mind that although it's very bad right now, there is a mortality rate that's much lower than SARS-1 was, but an infection rate that is much higher. And so it's more difficult to control. The virus is related to the other major coronavirus, MERS, and to human coronavirus HKU1 and OC43, NL63, and 229Es. They're all part of one big happy family. And they're also related to a large number of bat coronaviruses. And that really is the source of these. How they got into humans is an open question. There are two basic patterns that have been suggested. One is that there are random rare mutations that allow the virus to accommodate a secondary host. This was the case in SARS-1 with the civet cat, and then from there to humans. And so we had an easy transmission cycle to pass. And then there is another random rare mutation that may allow the virus to infect humans directly. And may also infect a secondary host. We've heard a lot about secondary hosts like cats and minks and pangolins and all kinds of other animals. And we really don't know whether that's an integral part of the epidemic or not. Or the other possibility is that we have random mutations in this population that will result eventually in a human compatible species. And so we really don't know how this came about. There is the third possibility, which is raised in some circles about whether or not this was created by humans. And the signals for that are just really not there. The virus has a really ornate life cycle for an RNA virus. The virus has, first of all, the largest RNA genome of any known virus. It enters by direct plasma membrane entry, or in some rare cases by acid endosome entry. It's uncoded in the cytoplasm, and then you begin the replication of the virus. And the first thing that has to be done is to uncode this 21 kilobases of non-structural RNA. This is the non-structural ORF1A and ORF1B, and they're only separated by a frame shift. At the other end, you have all the structural proteins, including spike. You have protein translation, you have shutdown of host RNA, viral protein inhibitors, and you also have a number of proteins that are produced by the virus that inhibit the innate immune response. And that's critical to keep in mind when you're studying those responses. There's a unique aspect to these positive stranded RNA viruses that is quite ornate, and that is the formation of these double-stranded vesicles. And I'll show you those in a second. And the other thing, of course, is the transcription pattern and translation of these proteins is in this crazy nested set pattern. So this is a real virus that was designed by a committee, because it obviously doesn't conform to the rules of most any other virus group. If we look at these double-walled vesicles, these double membrane vesicles, these are really important in isolating the viral components. These form the factories in which the virus replicates. This is some pictures taken from Megan Angelini's thesis at UCI in 2014, showing the formation of these vesicles by NSP3, 4, and 7, which are just 3 subproducts of one of the non-structural proteins. And you have this maze-like formation. Well, about that time, others began to look at this with cryo-electron microscopy and tomography, and things began to look much more interesting in terms of what we could resolve. And this is the tomographic reconstruction of these double-walled vesicles. And what you see inside this is you see all of the enzymes that are involved in replication of the viral RNA, and they're inside the vesicle. And then you see pores. I've pointed out a couple of pores and a channel here, which are important in terms of allowing material in and out of those vesicles, but with control. These are ribosomes on the outside. And so what you do is you accumulate these products and you pass these on from one vesicle to the next, depending on the factory, what the factory needs next. And so you'll have nucleic acid made, you'll have nucleoprotein made, which protects the nucleic acid. And then this is passed on to the next stage. And eventually this will then be passed on to the ER. And in the ER, this is one of these vesicles that you see on the surface of the membrane in the reconstruction. So down to the nanomolar level of resolution, you can see that this has structure which is controllable. So it conforms to all of the rules of a molecular pore. And so if you look at this, then the next stage is to pass this on to the transport pathway, basically going into the ergic, and then from the ergic to the Golgi, and then the virus is excreted as a secretory product from the protein, from the surface of the cell. So the virus is not released by bursting the cell open and forcing it out. It's released in a fairly controlled way by releasing, hundreds of particles at a time. I think you can see here there are a number of particles in here. And these are released into the medium. And so the cells can actually go for quite a long time without a lot of cytopathic effect. SARS-1 was much more fusogenic than this virus is. And so this virus may be an important component of the long-term pathogenesis of the virus, the ability to produce an infected cell for longer. Variants are a hot term right now. We talk a lot about variants. I think Phil talked a lot about variants. And variants are an important problem. But keep in mind that the variants that you see are only the variants that survive. And this comes back to this idea that the virus is simply trying to pass its genetic information on to the next generation. And those mutations occur at random. So what we're looking at primarily is we're looking at variants that change amino acid sequence or induce small deletions in a protein. And the protein that we look at the most often is the protein that is involved primarily in replication, entry into the cell, and that's the spike. But these variants existed in other viruses as well. This shows the 4 clades of virus that was isolated from civets in 2004 at the end of the SARS epidemic. And each of these clades had a different potential pathogenicity. And this is the kind of thing we hope for with our SARS-2, is that we'll go to a point where the virus will become less virulent, less dangerous. So if you look at here, we have a prototype group, which was the first group that came out, a low pathogenicity group, a high pathogenicity group, and an epidemic group. And these were all isolated in Taiwan at the end of the epidemic. And when you look at the changes in these, those changes all occurred in the spike. And so we have, again, a similar pattern to what we're seeing here, and they were clustered in the spike. And so you don't have to sort out the numbers here. This is what this looked like in terms of the pathogenicity groups. This group of mutations was associated with low pathogenicity. This group was associated with high pathogenicity, and this with the epidemic group. And so you have a very close relationship between the location of the mutations in terms of sequence number and in terms of the pathogenic potential of the virus. So let's cut forward now to February 18. It should be February 18, 2021. There was an article by Coram and Zimmer in the New York Times where they identified and discussed each of these kinds of mutations that we're seeing in SARS in SARS-2 at the time. And the variants, it's important to know, are generated by point or deletion mutations that occur during the course of replication. They occur randomly in the genome, and only those with neutral or enhancing effects on the viral genome are retained. Others die out. If a virus spins off a mutation that is detrimental to RNA synthesis, even by a small fraction, it will die out, and you won't see that anymore. So it's eliminated from the genome. So this basically is the pattern, again, the nucleic acid pattern of the virus, ORF1A, ORF1B, and then down here, the structural proteins. This big red one is the spike. And keep an eye on the spike because that's an important one, because that's where most of the variants that we've talked about are located. It's wonderful working on this at this particular time in history because somebody else does all the graphics for you. You know, it's amazing the quality and accuracy of these graphics that you can pick up in a newspaper. So the variants that existed at the time this was written, the P1 lineage is an offshoot of the larger B1.1.28 lineage, which was first reported in Japan, but in people who came from Brazil. And so you see the complexity of the spread around the world. In Manaus, the largest city in Brazil, it quickly became the prominent variant. And now the city of Manaus, which is on the Amazon, has had 3 outbreaks of SARS, 3 spikes of SARS, and many of the people who recovered from SARS in the first outbreak had a second infection in the next outbreak, indicating that there is some loss of resistance to the virus in that situation. So this became the predominant variant in other South American cities. It's a close relative of B1.3.51, which is another mutant which has caused problems. And this is where those mutations are. Here we are in the spike again, E484, E417, E501, E501Y, and again, 484, 417. And these are all located within the spike. And each of these variants seems to make the spike either resistant to antibody or more efficient at binding to receptor and holding on. Where has this P1 family been found? Well, it's been found in Minnesota, Oklahoma, Maryland, and Brazil, and Japan. And it's spread around the world since then. But this is a virus that gets around. If you look at the 501 family of mutations, the B1.1.7, the B1.351, and P1 lineages, this is the 501 mutation, and that's right here, again in the spike, and it's kind of deep down in the core of the spike, near the meeting of all of the 3 components of the spike. And so you've got again a concentrated change in the spike, and it seems to change the protein for a tighter fit with human cells. If you look at E484, it independently arose in multiple lineages, and we're concerned that this might be something that is found in samples from Britain. And in fact, it is in samples from Britain. And this mutation occurs near the top of the spike, alters the shape of the spike, and may help the spikes evade some of the coronavirus antibodies. Now, in this virus and in influenza as well, the antibody sites tend to be way out here at the tip because they're very accessible and because they can form decoys. You know, in influenza, you have antibody mutations that occur around a pit, really, where the receptor is located. Really, they really don't affect receptor binding, but they do affect antibody binding. And that's the so-called antigenic drift. And again, the 452R is another mutation that was found in California and in Los Angeles. So this is ours. And again, you have 452, the same mutations that we saw in the other one. And so you have roughly 45% of the samples on February 18 in California showed that variant. So the point is that these mutations are really interesting, but they're not the whole story, because you see that the recurrence of mutations, whether or not they're going to be undefeatable, is not really clear yet. It looks like the vaccines that we're using here, the Moderna and the Pfizer, which are the 2 prominent vaccines now, are not so affected by the vaccination. If you look then at the Medarex paper, which came from UCSF, where is his name here? Dr. Chu. Anyway, Dr. Chu, here he is, Charles Chu. Charles Chu is somebody who we know well because he was one of the components in San Francisco on the Pacific Southwest Center for Emerging Disease. And so we got to know him very well, and he was much younger then, but he's come up with a very interesting mutation, this B1.1.7 mutation that he found in a large percentage of San Francisco residents. And finally, just to provide a little bit of optimism here, there's a really interesting Biomed preprint that's out from a very good group in San Diego that I'm fond of because I've collaborated with them a lot. And that's a paper that is entitled Negligible Impact of SARS-CoV-2 Variants on CD4 and CD8 T-cell response in COVID-19 exposed donors and vaccinees. And the gist of this paper says basically that although these affect the antibody response, they don't appear to have a large effect, if any significant effect, on the T-cell responses. So I think we have to remember always that the T-cell response is important and maybe as important in recovery from viral infection as the antibody is in resistance to viral infection. And so we have to factor that into our thinking. So the thing is not to panic at this point, but to focus on developing approaches that will consider the holistic response and will begin to try to prevent spread of the virus in that way. So let's go back to just a reiteration of the first coronavirus discovered, infectious bronchitis virus in 1931. This is a virus that can wipe out 1 million chickens in a weekend. 229E, the human coronavirus, OC43, another human coronavirus, and the emergence of SARS coronavirus, NL63, HKU1, MERS, SARS-CoV-2, and the SARS-CoV-2 pandemic. And this is basically the log of advancement in terms of understanding the viruses. Polyprotein processing, first coronavirus genome sequence, targeted recombination, discontinuous transcription, electron microscopy is where we are now, and then finally electron tomography, which I've illustrated a small part of. So I will leave it at there and open it for questions. And I think, what do I have to do? Click there.
There we go. That's great, Mike. Thanks for that historic presentation. That's great for historical perspective, not historic. We've got a couple of questions. One is that assuming we do conquer this pandemic during post-pandemic era, do you think patients with severe pneumonia are likely to develop more novel coronaviruses? I mean, where, I guess the bottom line is, where are these mutations coming?
I think these coronaviruses are with us. You know, if anybody's considering a career, I know you are, because I've signed some letters for you. If anybody's considering a career in virology right now, this is open territory. It's going to be with us for another 20 years or more. You know, I've often described this epidemic situation like a plane crash. You know, it hit us suddenly. There was a lot of smoke and a lot of fire and a lot of damage. And it's going to take us 10 to 15 years to figure out what really happened. How important the variants are, how important the mutations, the spread of the virus, what the patterns are, the social economic aspects of it. You know, there are just so many different facets of it as illustrated today. We've got a hugely diverse group of people who's been studying this virus from different angles. Right. So I think that this is something that's going to be with us for a while. So we should be screening for any coronavirus that we know of at this point.
I mean, it seemed like there was this long gap between the previous, the SARS and the MERS outbreak, and then this one.
Yeah. Well,
any thoughts on that? Yeah,
because you know, there's a nice article that was written in 2007, which was a review that predicted this, and I'd be happy to send anybody the reference to it if they want it. But it turned out to be amazingly prescient, because what they said was basically that with the combination of a rich diversity of bat coronaviruses in southern China and the preponderance still of uncontrolled live animal markets, that this was a ticking time bomb. And it has proven to be exactly that.
Mm-hmm.
How long it takes to get there, we don't know. I mean, why did the first SARS virus pop up when it did? You know, and why did it disappear so quickly? Probably because it didn't have the flip out element that allows the infection to be so efficient. Other than that, it has all of the elements of SARS-2.
So on the other side of this, Hugh Davis asks, would you expect to find some immune escape mutations at the T and B cell level that might increase as everybody acquires immunity?
I think we probably already have.
Well, that's part of it, but the mutants that have been described, the variants, so-called, they're still being detected by the current vaccines.
Yeah, they're still there. Well, we think that they are. I mean, there was a report in South Africa that the vaccine was not, I think it was the, which one was it? Was the Oxford vaccine was not so efficient at knocking down that one. So I think that once we analyze all of this data, we will find that there are buried in some of these variants that are much more resistant to antibody than others. And that's why, you know, I think it's really important to understand what the T cell response is capable of doing as well.
Right, right.
And, you know, Ilham is doing this from a very parochial way, looking at every aspect of this. And I think that that's what needs to be done, is if not individually, to combine skills and look at it. Tom has CNS infections and Ilham is looking at immune responses and at co-infections and microbiome. And, you know, that's what we need to know. Phil has certainly covered the antibodies. And so what, you know, there we are. So when I think in choosing, you know, you're probably going to see the money tighten up a little bit now, but that's because so much money has gone into the projects first. But it's been an amazing time, and it's kind of encouraging to me to see this country be able to rally research like it has, in spite of all of the negativity that this last year has had.
Right. No, definitely turned around.
Yeah. We did hit 100 million people today, by the way. Did you hear that? We did 100 million now.
That's ahead of Biden's 100 days.
Ahead of Biden's 100 days. So yeah.
Terrific, Mike. Thanks so much. Let me introduce Susan Wang now. It is indeed a pleasure. Susan is the Professor of Medicine and Infectious Diseases here at the UCI School of Medicine. She is Medical Director of Epidemiology and Infection Prevention at UC Irvine Health, and has a lot of credentials behind her. And today she's going to talk about the outbreaks in nursing homes and hospitals. So Susan, welcome. Please switch on your video if you want us to see you. And
yes,
off.
I should be on now, but
You are.
Good. All right. And can you see the full screen? I have dual display. So are you seeing a presenter view?
No,
or
we are seeing we're seeing the next slide.
how about that?
That's it.
All right. Sorry, takes a while. So it's a real pleasure to be here. I'm transitioning largely to epidemiology, and even more different because we'll be talking about a prevention program that was suddenly started last spring. So it's a real pleasure to be here to share this with you. As you know, Orange County has about 30 freestanding hospitals and 70 freestanding nursing homes with an enormous gradient of wealth from the north to the south. And that really produces quite a bit of disparity, as you heard with Dean Bodenabala earlier today. Nursing homes in particular are really highly vulnerable. You've seen it all over the media, and this is true even before COVID-19, of course. They are elderly. They really do not have a good way to self-care. They have a myriad of chronic diseases. A lot of them are either ventilated or really total care. And overall in the nursing, in the United States, there are over 15,000 nursing homes, and each year about 1.4 million residents are in one of those nursing homes for a period of time. you can see the numbers for COVID-19 cases in the nursing homes. If we see 1.4 million residents a year, you can see the cases are 642,000 in the United States, and that amounts to 130,000 nursing home related deaths. Here in Orange County, 4,700 cases, over 1,000 deaths, and it's really quite staggering. The risk of death really rides between 20 and 25, and in unfortunate circumstances, sometimes as high as 30% death. So why are there so many complexities? It's not just the residents themselves, but the staff, of course, are the main source of importing COVID-19. You can imagine that these residents are largely not mobile. And in fact, at the start of the pandemic, the first thing that regulators did was shut down all excursions. So there was no movement of residents out into the community. There were no visitors coming into the nursing home. And so naturally, the main source that COVID-19 comes into the nursing home are by the staff that come in there to work. And there are a number of staff complexities that are really different in the nursing home compared to the hospital. In the hospitals, the predominant care is given by nurses. There are a number of nursing assistants, a lot of doctors. In the nursing homes, there are very, very few doctors. There are very, very few nurses, and the vast majority of care is given by certified nursing assistants. Most of these have a high school education, and they undergo a handful of weeks of training to become certified. There are quite a few housekeepers, kitchen staff. Those are really the dominant sources, with a few highly skilled workers. These individuals who come into the nursing homes have an enormous amount of social and economic disadvantage. And in fact, it's pretty overt that they don't have a lot of insurance. They have very, very few sick days. And when the first MMWR came out from CDC, and they talked about how it was so remarkable that nursing staff had come in to Washington State and had completely asymptomatic disease. Those of us who know nursing homes really took that as a pretty remarkable lack of understanding of how nursing homes work. And these people will not speak up if they get sick. They will work sick to death. They will work because they can't afford to take a sick day. They will not speak up on any manner of symptom screening unless you're on the side and you're a friend. They'll tell you, but they won't tell their supervisor. So it's pretty remarkable location. You know, in the hospital, we have a remarkable number of people who will screen positive on screening, or they'll self-attest. That's pretty rare in the nursing home. This is the story that I was just mentioning that really set this whole thing off about the nursing homes and led to a very large amount of rapid regulation for nursing homes. But in April, there was, as you recall, a nursing home in Washington State where 101 residents caught COVID-19 through an outbreak, and it led to a 34% mortality. So 34 deaths, really rapid. And this was a pretty urgent phone call that we received, one from the Orange County Healthcare Agency and one from Orange County Medicaid, asking if we would put together a rapid proposal for becoming the COVID prevention team for nursing homes. At the time, our OC cases were small, but they were rising, and they had every reason to be concerned about what would happen in the days to come. One of the questions that you might ask is, why on earth would they call us? You know, we're hospital-based. We do most of our research in the prior years had been done largely in the hospitals, but we did have about 12 years of experience in nursing home prevention studies. Our goal was largely surrounding the prevention of the spread of antibiotic-resistant bacteria. And we had done a number of studies here in Orange County and built kind of like a population laboratory of the region for hospitals, nursing homes, and how they interact either through simulation studies, through mathematical modeling, or through epidemiologic studies, where we would do samples of people from nose, skin, other locations to understand spread. And most recently, we had done a project where we used decolonization. So antiseptic soaps, just replacing basically bathing soap with antiseptic soaps, putting antiseptic ointments or antibiotics into the nose to try to decolonize the very nice pathogenic bacteria that you saw in Dr. Vasadi's presentation. And we had actually demonstrated a pretty remarkable drop in hospitalizations that arise from nursing homes that actually undertake the decolonization regimen. So we saw about a 40% reduction in infectious hospitalizations, and CalOptima saw about an 80% reduction in costs that arose from hospitalizations from nursing homes that were in our project. And that was the genesis of why CalOptima called us. So it's amazing how all these things kind of stitched together. We were not doing public health prevention, but that was the rapport that led to that phone call and led to us pivoting pretty hard from a research-oriented project, many of which had been shut down because they weren't critical, into this program, which was absolutely critical. So this will be a pretty different type of talk. It's going to be very much a prevention story, a lot about a prevention team. There'll be some metrics, but a large part of it was absolutely generated by a request from Public Health and Medicaid. So we created a scope of work that they approved. We basically knew that you couldn't go in. It was really, really hard to go into the nursing homes. Public health could go in. We eventually could go in, and that was really on the backs of 12 years of rapport with certain places. They knew us, they knew the work that we had done. And then of course we were going in having been funded by Orange County Public Health and CalOptima. But we knew even with that, it was incredibly gated for how many people could really walk in. People were terrified. I think they should have been equally terrified of their own staff as they were about outsiders, but you could imagine, as you heard, complete lockdown. So we did a lot of things virtually. We created a rapid set of toolkits, information that they could use. We kind of staged it to be able to be readily available to all of them all across Orange County through a public website hosted by UCI Health, and put a ton of things up there that they could just rapidly use and download. We provided webinars to actually try to get the leadership of the 70 nursing homes to listen to the webinars. We said that we would provide consultative support. You could call us at any time if you were worried. The outbreak response team was, of course, public health. So what public health was saying wasn't that they don't have anything available, but public health is usually a response team. So when there's an outbreak, they would respond, but there was no prevention team. And so naturally, it's far better to prevent than to have to respond. And so our job was to try to prevent, and then if it got out of control, then they were going in to try to contain. We also, from our experience, knew that nursing homes don't operate well by doing self-help. You know, they don't go to they're not looking for a quality improvement program. They are pretty poorly resourced. They can barely manage the things that they're doing at the time. A lot of people have 2 or 3 jobs. They're barely scraping by. They're barely putting food on the table. A lot of them are not the best. You know, a lot of people aren't choosing to work in a nursing home. A lot of them are there because they couldn't get a hospital job. And there's a real mix. There are some that really have their heart in nursing home care, and there's a lot that really don't. And so because of that, we really understood the need that FaceTime and follow-up and consistency and feedback was really important. So we said, you know, I know that there are 70 nursing homes in Orange County, but to the first 12 that raise their hand, we will go in person. We will provide enhanced training. We will do everything we can to support them so they become some of the safest nursing homes in all of Orange County for this time during COVID. So this is just part of the prevention toolkit. You can see the link up at the top. There's a ton of things that you can download. They're downloadable in both PDF format that has all of the logos from Public Health and CalOptima and our logo, and they're in editable format because a lot of people want to switch a few things or put their own logo onto it. We started with visitors and social distancing. You know, what do staff do? This is really important because if the staff are terrified, you can't tell them how to take care of somebody else. And this is something that I think, unless you actually work in healthcare, that usually the public doesn't really understand. They assume that those that are working in healthcare don't have the fear that the public have. I can tell you, as the medical director of infection prevention at the hospital and the medical center, in addition to the work done in the nursing home, that there was absolutely unadulterated terror uniformly across the medical community. It really produced an enormous amount of a range between reasonableness and ridiculousness for what people would wear coming into the hospital. And you really did absolutely have to address that fear first. If you started in by talking about how to take care of a resident, you would get absolutely nowhere with people. So we started first with many webinars, and our very front-facing work was all about staff, all about trying to get them to have a reasonable perspective about how this transmits and what they can do to protect themselves. And once they calmed down, we could move them to how they could take care of others. Our toolkit was largely broken up into that, all about you, the staff, all about taking care of others, which would be personal protective equipment to care for others, and then finally, the environment. We had a ton of frequently asked questions that they could download. We had monitoring logs. We tried to give them everything that they could use on a regular basis so they didn't have to create it. One of the things that you'll realize in a nursing home is if there's any impediment, create a screening log. A lot of times it just simply won't get done. So a lot of help to provide to those who have absolutely no time. We created things like we created a ton of clings, what we would call a cling poster. These are almost like, if you think about super crazy strong Post-its, they kind of go up onto the wall, they protect the art, they don't do anything, they're non-damaging, but they will stay up for months and months. And so we provided a ton of these to try to get visual signs up to teach people about what they need to do. This one we knew they wouldn't do. We put this up and we knew they wouldn't, like I told you, unless they were caught by the temperature screen, unless they were overtly watched to cough, they were really not going to speak up and tell people that something was really wrong. And these were other things that we really tried to teach them. One of the things that was pretty remarkable is at the time when there was so much terror, they really think that, everything from their hair to their souls to, their clothing, everything is going to be a source of COVID. And we really needed to remind them that, of course, you can examine a patient without picking up COVID. There are things you need to wear. We do it all the time. You are way less than 6 feet when you're examining someone. And you have to look in their mouth and you have to, listen to their heart. You're really, really close to them. But absolutely, the main thing besides the things that you wear are that coronavirus will come through your mucous membranes. That is your eyes, your nose, and your mouth, your open mouth. And so it's really critical to clean your hands before you reach up, before you adjust your mask, before you rub your eyes, before you do anything with your face. And that was a large part of what we really tried to teach them. And we'll show you a little bit about that. This is our newest and our latest cling that we're sending out. We are trying to remind them, a lot of people that get the opportunity to be vaccinated, they really want freedom immediately. The minute it goes into their arm, they just want, I think we had several nursing staff that went to the casinos like the day after they got their vaccines. And so we really needed to remind them, one, that the rest of the community is really not vaccinated, and that we really do need time for the vaccine to work. And even so, you still need to be careful while the outside external forces and cases are still high. So fortunately for us, we're making a nice U-turn. But all of this really started in December when vaccines first started to become available to healthcare providers, nursing homes, nursing home residents. And it's pretty remarkable because people don't realize that even as of March 8th, which is not that long ago, the fully vaccinated population in Orange County is 8%. We are lagging the United States, which was around 11% on this day. It's now about 12, a little more than 12%, but fully vaccinated, meaning all doses in, and not even counting a couple weeks past that, which, as you know, you'll need. And we also were still seeing hundreds of cases a day and a large number of deaths. And even in the nursing homes, I can tell you that there wasn't a single nursing home, I think, that I've been in where they didn't know someone, several people who had died. We actually had people, we had staff members die in the nursing homes. I mean, it has been a pretty sobering experience to be in the nursing home community. And even so, it is very, very hard to garner good behavior. So they love these. They were shocked at the 8%, and it does help them be a little bit more attentive to hang on tight until we can be better vaccinated as a community. We did a ton of videos. A lot of people learn by hearing, some people by reading, some people by listening, and by visual cues. And so we really tried to give them every imaginable way that they would need to learn. So as simple as cleaning your hands, the full sequence of how you put on the myriad of personal protective equipment and the right way to put it on and the right way to take it off, a whole sequence. And probably the one that was the most important is the last set. So the first ones, you can tell that the top and the bottom, are all about masking. And it's really remarkable how they really wouldn't mask the nursing home residents. And we kept reminding them that think about how long it took us all to get used to masking. These nursing home residents, yes, they're confused. Yes, some of them are combative, but some of them, you can probably get 30% of those residents to put on those masks, and that mask can really be life-saving. And it was a really, really hard sell. They would put these residents in the hallways. They needed to keep an eye on some of them, but it was really, really hard to get them to put masks on. We started to bring in volunteer masks. We had a lot of people who would give us volunteer cloth masks, soft ones that were multi-ply, that were very safe, that we would bring. They were pretty, and we would give them to the nursing home residents and of course to the nursing home staff, but they couldn't wear them, for patient care. They were really meant for outside personal use. But we could get a good number of nursing home residents, especially those in the hallways that would otherwise be exposing a lot of people to wear them. The middle two videos are just examples of a lot of our use of personal protective equipment. But I'll tell you that the ones that we were absolutely emphasizing in the most emphatic way was the break room. And we have seen this time and time again, both in our hospitals as well as in the nursing homes, is that it's the break room. If you really think about your riskiest time of day as a healthcare provider, believe it or not, it is not providing patient care. Your number one risk of the day is actually eating with your friends. And we saw that time and time and time again, is that the outbreaks would happen because of nursing break room exposure. People who really deeply thought, oh, my friend won't give it to me. And that's where we would largely see it. And in the break room, kind of all normal protective behavior goes away. They just feel like they need a break, and they just want to be able to dissociate and feel like they're themselves again. And therein lies the greatest risk. So we did a ton of break room etiquette, a lot of discussion about how they're taking off their masks. Are they cleaning their hands before they touch their mask? Are they throwing their mask onto a table that was or was not clean, or hanging it over some side that they had no idea where it was? And in the nursing homes, as you can imagine, the environment has been downplayed immensely as a source of kind of fomite spread. But when you are in healthcare and you touch a lot of things that someone else just touched, or when you're having a lot of transfer of equipment, it does become really important that you can imagine that a normal cold could transfer that way. And coronavirus absolutely can if you're doing high touch handoff information. And the break room is constantly being used. The door handles are constantly being touched to open the refrigerator, to open the microwave, and to really sit down at the tables and eat. So we also did webinars. So in addition to the toolkit and the videos, we did the same staging of webinars that we invited the nursing homes to for the same exact reasons. Again, staff, they just could not hear you if you didn't address their protection. We did a ton of in-person training at the 12 sites that signed up for intensive program. We went honestly, staff by staff, we went every shift and made sure that every single shift had an opportunity to hear us about the way coronavirus was transmitted, that you didn't need bleach baths for your shoes coming in. What was it that you really, really needed to do to protect yourself in the nursing home? We also looked at giving them free sweeps. This was before the time that Medicare demanded that all nursing homes swab residents and staff on a generally weekly basis. It was monthly, and then it turned into weekly, and then depending on the tier that you're in, it could be twice weekly, sometimes even thrice weekly. And it really was hard. This was expensive. They didn't really know how to do it. They really weren't good with logistics and trying to get people to do it. Some residents would decline. And so we really showed them for these 12 nursing homes, we kind of set up full logistical support to show them how they could do it, and actually transitioned them really beautifully when Medicare actually said, you actually have to do this now. This is one of, I think, the saving graces in a nursing home setting where they will not speak up, is that you do mandatory testing. And it's really unfortunate, because what we would like to do, and we have set up projects to look at this, is why, like, not just can you force them to do a swab, but more importantly, what are the social economic issues behind why they cannot speak up, or they feel like they will not or cannot do what you're asking them to do. Because of the really tight restrictions in coming into a nursing home, even when we would go in, they really didn't want us there for an extended period of time. And so it was really hard to do staff observations. For those of you who work in a hospital, you know that, and we are required to watch people wash their hands. We have to have an observation set up. We have to make sure, because feedback is one of the most dominant ways that you can actually correct and influence behavior. And so for these 12 nursing homes, we actually installed high quality streaming video. And it was very clear, we notified them at our in-person training that we had no interest in how they were caring for a resident. We were only looking at their behavior and whether or not they were being safe for themselves. And we did randomized sampling of both shifts. So there are 3 shifts in a nursing home, early morning, afternoon, and then night shift. And then we also did it across weekends and weekdays. And a lot of times, as you can imagine, it's only the weekday people that get the feedback, weekday, daytime, and the weekends don't. So what we did is we would randomly sample every week, and we would create these really fun video montages. We would kind of put them together. We would make them fun. We'd have a lot of encouragement. We would still circle the things that were wrong, and we would encourage them to have right behavior. And so what was that? This is the very, very beginning. We were launching 3 nursing homes at a time. And eventually these numbers would all get into the thousands of observations. But you can just see this is the very, very beginning, and you can see that there are a number of % of people who would just come in without a mask, or just walk around the nursing home without a mask. And so that was pretty early on. We had people, if they were wearing a mask, you can see a good number of people would wear it incorrectly. It's hanging over their ear, or it's not covering their nose. But this is the persistent part that we really had to do a lot of education on an ongoing basis, is the amount of times these healthcare workers would touch their face without cleaning their hands. So this was important, not just when you care for a patient, you really should clean your hands. Patients have all sorts of germs. It's one of the problems that we were seeing in nursing homes, is that they kind of converted the nursing home into a one pathogen world. The only pathogen that matters is COVID, and they would actually cohort people who were COVID positive, and they would wear, one gown to everybody, and sometimes they wouldn't even change their gloves. And so all the other things that we have been working on for the past decade, MRSA and VRE and other highly resistant bacteria, you can imagine have this complete ability to spread. And that's what they were seeing both in Orange County and in LA County, that one of the most emerging concerning fungi, so Candida auris, has had major outbreaks in nursing homes because of the lack of attention to other infection prevention processes other than trying to cohort people based on COVID status. So we were watching a lot of this kind of touching of the face. And if they touch the face, because of course you can touch your face, you just have to clean your hands before you do it. You can see that 99 to 100% of the time it was unsafe touching of the face, and same thing, touching of the mask, and almost all the time it was unsafe touching of that mask, to try to prevent people from reaching up into an area where they could really pick up and acquire COVID-19. We have had a chance to start to look at our data over time. Again, they're getting these weekly DVDs that they can play for their staff, and they would do it in their big break room, and the staff would stand around 6 feet apart and watch these videos to see who was caught, that week. And generally, it was a pretty fun time. They would be laughing. Like, we really only did this if they really could see this as a population-based intervention that was really intended to help them. So most of the time, actually, I would say all of the time, that the nursing homes are finding this to be very helpful and again, non-punitive. So we are able to reduce this kind of poor touching of the face and mask from 15% down to 5%. And then they were really wearing, taking off their masks before they walk into the break room, and whether they're eating or not, they're talking to their friends, they're sitting next to their friends, and they really weren't wearing masks even when they weren't eating. And so we've really been able to increase that behavior, that they wear their masks coming into the break room, they only take off their masks solely to eat, and then the mask goes on back onto the face in a safe way. We also have been working with them most recently as we've come through now 2 waves to focus on environmental cleaning. There really hasn't been a lot of attention paid to this, both before COVID, during COVID, and no doubt after COVID as well. And it, of course, wasn't the most important thing when we first started, right? It was all human behavior, touch, other types of ways, droplet spread, of course, on how these things could spread. In the nursing homes, they don't do a lot of aerosol generating procedures, but they do some. So we had to discuss that as well. And ultimately, eventually we got back around to the fact that, the environment is still important for anything that is high touch, and you do need to clean it. And so we put down these invisible markers that we've been using for a number of years now, and you can see it on the right-hand side that they really are invisible, but if you shine a black light on it or UV light, you can actually see the dot. And we use it to train. We use it in the hospital now routinely, but we use it in the nursing homes to teach the housekeepers and the environmental services workers about what they are not removing. So, you can ask yourself, these things, these high touch objects, we're not trying to trick them. These are light switches, these are tables, chairs, these are buttons to call the nurse. These are things that really should be cleaned on a daily basis. So you really should expect the nursing home daily removal rate to be 100%. That's the goal from high touch objects. And you really shouldn't expect 7 days for it to really be removed. And so, we have done this before, that it was actually quite poor. And when we verified it during COVID, the numbers really speak for themselves. 7% of high touch objects actually had the black light marker cleaned. And even if you waited for 7 days, that removal rate would really only increase to 22%. There were a number of nursing homes where in the red zone, that is the dedicated COVID area, the cleaners wouldn't go in at all, would not cross. And so that area would absolutely not be cleaned at all for days or weeks at a time. We had done a number of things, not just the toolkit, but the webinar. We distributed about 1,700 clings. We did a ton of in-services. We've now been moving to vaccine talks to try to address the incredible vaccine hesitancy that exists among a large number of these staff, and ultimately put in about 3,000 video hours to really give them feedback on staff behavior. The vaccine process
Susan,
in the nurse.
We're getting close to time here.
Okay, so I'll just simplify and just say that they're getting about 75% of them are vaccinated, actually 60 to 75% of them, but we really aren't reaching herd immunity. And if we don't do that by the winter time, we'll really see continued outbreaks in this area. And we really are going to have to keep the pressure on before the next winter season. And I'll just stop with 2 comments about our hospital that we actually saw in response to the California variant, a very, very sharp drop right after healthcare worker second dose began. Saw a very striking drop in our UCI healthcare worker cases. Orange is the Orange County cases, but a lot of these are essential workers who are getting vaccinated. And this, the data, which is in submission, that it affects our asymptomatic testing too. We have a robust asymptomatic process, and we're seeing the asymptomatic tests go right down to 0 as well. All right, and lots of vaccine information if you want it. And thanks very much.
It's great. Thank you, Susan. That is a tour de force in terms of dealing with nursing homes. There's no question. I talk to my aunt in a nursing home in Toronto every week, and she tells me, they've all been vaccinated, but then it's lockdown, and then they can't go out again. I think rather than do more questions just now, will you be able to stay on for the discussion after Leslie Thompson's talk?
I will probably have to go, but I can try to swing back in if that would be helpful. But I'll invite anybody.
I think what you're showing is really the sort of thing that we're going to be discussing. If you can, that would be great. But I'll ask one question that's been posted here, Huifan, and that is, are there concerns, once this is over, once everyone's vaccinated? I mean, there's still this risk of infection, and what goes on in terms of training for the help for the nursing home workers, as much as you can do, given the
and I'll be brief, but you're absolutely right. If you think about H1N1, it was our dominant winter flu pathogen for 8 years after they declared the pandemic over, and so we have every imaginable reason to think that this is not going away. If we're lucky, it'll just become a winter virus. And we are absolutely gearing up. Actually, they've renewed our contract to continue prevention so that we can actually renew the prevention right in time for winter surge, which we hope will be low, but we will be gearing up vaccine all the way. And then starting in September, October, we better renew their reminders of what they need to do in case we see a surge.
Great. Thank you so much. Really appreciate it. Our last speaker this afternoon for this session is Leslie Thompson. Leslie Thompson. Dr. Thompson is a Donald Bren Professor and the Chancellor's Professor at the School of Medicine. She's also co-director of the Center for Precision Health and Precision Health through Artificial Intelligence at UCI. And the purpose of this is to seek to improve health and advance treatments through AI and data-driven technologies. Dr. Thompson her own research is primarily in Huntington's disease and other neurodegenerative diseases, but today she's going to talk about precision medicine and the COVID UC Host Genomics Consortium. Leslie, thank you so much for joining us.
Thank you. Let me make sure this is working. Okay, can you see the screen and me and the sound?
Yes, it's all
okay,
perfect.
Great. So this is going to be just a very short talk, a little 10-minute talk, and to give an overview of what UCI is doing as part of this Host Genomics Consortium. So this is something that was initiated by Dan Geschwin and others at UCLA and brought in all of the medical campuses throughout the UC system. And this is to understand the genetic contribution of COVID-19 susceptibility. So the host itself, so all of us, our susceptibility, things that contribute to the VSS score we heard about and other, whether you progress to severe disease, less severe disease, et cetera. And so this includes whole genome sequencing and exome sequencing, primarily from samples from hospitalized patients, and then comparing to the clinical risk factors and the outcomes of individuals. And these are the 5 campuses that are involved. We have biweekly calls. We are going to be sharing all the data. And what has really facilitated this is there's been a big effort. We were able to get 400 free human exomes from Helix. We have over 600 patients subject sequenced to date so far. There was some funds that came from UCLA. Illumina provided sequencing reagents at a very big discounted cost. And UCI, PHAI, our academic initiative that Dan Chow, who spoke earlier, and Peter Chang are part of, and Suzanne Sandmeyer, we've been able to use some of those funds to obtain samples from CHOC and help with the whole genome sequencing costs on those. And this just lists some of the participants in this data gathering and data analysis part of the consortium. It's stuck for some reason. There we go. So why are we doing this? There's clearly some susceptibility and resistance genes that are affecting the outcome among infected individuals. And we've often gotten the question, why are we doing this small population? There's worldwide studies that are going on right now all over the world for susceptibility genes, but we have a unique opportunity given that we have extensive phenotype information and annotation through the integrated UC medical records system. We have a UCI-wide effort, and it leverages this very unique population in California. And we heard a lot from Bernadette and others about the susceptibility of the Latinx population and others. This is another rationale for doing this work. And it's been shown in a number of different viral infections that there are variants that alter the innate pathways of sensing viral infection or T-cell effector responses in influenza, rhinovirus, a number of these different viral diseases. So additional rationale when we were starting was that an early study had looked at about 2,000 relatively generic COVID-19 patients and control patients from Spain and Italy, and they had identified genetic loci, even with these sort of typical cases on chromosome 3, and then also an association on chromosome 9 that associated with the ABO blood group locus. There's been screens in human alveolar epithelial cells that suggest specific host factors that are required for SARS-CoV-2 infection. Some of these, and they cluster into various pathways that are annotated here. So there's been and this is just a snapshot of some of the work that's been going on. Also, genetic type 1 interferon disruption may contribute to susceptibility. There's been a few susceptibility genes that have been identified recently in a publication in Science, for instance, with autosomal dominant susceptibility, autosomal recessive susceptibility genes that are involved in many of these pathways that we've heard about today with the interferon, type 1 interferon immunity. So there's indication that there are these genetic variants that contribute to susceptibility of an individual to progress to severe disease. We've benefited substantially from Peter Chang and Daniel Chow's work on this VSS score. And so we've been able to go through, these are the patients that we've submitted for sequencing, but in some cases, which are the ones that are discordant? So they had a predicted score. So as an example here, they had a predicted score of 0.08, but they ended up with a 1. So they were in the ICU and they were intubated, whereas they should have, anything over about a 3, below a 3 would have been predicted to move forward to severe disease. So we're able to use those scores in selecting patients for the sequencing. And the process is that we've taken remnant samples from UCI pathology and laboratory medicine, and this has been really facilitated by Delia. You've heard a lot about from everybody from Delia and Rob in helping procure these samples. Daniela's IRB and help with that, working with the IRB office. And then we've had to go through and reconsent all the patients that we are now sequencing, because the IRB that is at UCI, the general IRB where patients are admitted into UCI hospital or through the ER, does not allow for genomics. It does not specifically allow one to obtain genetic information. Even though you can do a lot of other things with it, you cannot do genomics. So we've had to reconsent each of these patients, and this is done by telephone. Unimysant has done all this, and then Dan gets on the phone and does the official consenting as the physician and utilizes the biorepository IRB that Daniela had put together. And and we're working now closely with Rob to really see if we can facilitate this for further applications, non-COVID applications, when patients enter UCI to facilitate genomics research and genomics activities on campus. So as of mid-March, we've consented 24 patients, and we've sent 38 patients to UCLA for the DNA prep and sequencing. That's being done by the Armed Services of the US. And so that's moving along. All the data, they've been sequenced. The data has just been delivered to UCI. We're going to be analyzing it, and as well individually for the UCI patients, but then also across all the UC aggregated data as well. So this is part then of these global initiatives that they're all working together to identify this COVID-19 susceptibility genes. You need a lot of power in these analyses to get these susceptibility genes out. And so there's this COVID human genetic effort, the COVID-19 Host Genomics Institute, that are global initiatives that many of the members of the USeq Genomics Consortium are part of. And all of the de-identified genomes collected through the USeq Consortium, or at least the analyzed data, will be shared among the groups. So more recently, we've been working with CHOC on the multi-system inflammatory syndrome in children, this that you've heard about today, this very severe inflammatory outcome in children. And it's surprising actually how many cases of this there have been at CHOC, at the Children's Hospital of Orange County. And even just in January, there were 12 suspected MIS-C cases in January 2021. So we're going back now. UNA has worked really hard at generating this IRB reliance so that we can utilize the biorepository IRB to consent these pediatric inpatients and then also outpatients, so blood for the inpatients and saliva kits that are sent to them for the outpatients. And we'll be focusing on these previously or currently hospitalized children and particularly the MIS-C cases. And this has been made possible through the PHAI academic initiative to be able to fund this. So I just wanted to give this little quick snapshot of where we are and that this exists, and we're doing this at UCI, and it's really been facilitated through this academic initiative. So thank you very much.
Thank you very much, Leslie. That was really fascinating. I think having this go through the whole, I can't start my video. Oh, well.
I'm not sure if I'm doing something.
I think being able to, you can still hear me.
Yeah.
I think being able to do this mass analysis of such a large number of patients, and especially now there's the mysterious or relatively mysterious multi-system inflammatory response in children, that has really become much of a mystery.
And UCI is very unique. I mean, CHOC is, I was just going to say CHOC is unique in that even like the UCLA, they just, for whatever reason, there's a lot of cases there that are, and they're contributing to this study.
I'm not hearing you very.
Oh, sorry. It's fine.
No, I mean.
No, I was just saying that CHOC has quite a few of these patients compared to other sites. So.
What would you be, I mean, I haven't been aware of many studies that are looking at the children at that level and wondering what criteria you might look for. I mean, that's the beauty of taking this approach is it's open-ended and you find what you find. But do you suspect any areas and breakdown in
I wouldn't be surprised.
Exacerbated immune responses.
Can you hear me okay? I wouldn't be surprised if we find things like these interferon, type 1 interferon responses or other immune and inflammatory genes heavily involved in this, but it is fairly open-ended. We're not sure yet. There's been just not that many studies because there are not that many numbers of patients. So we'll see, but that's what I would anticipate.
Yeah, so being able to do this from patients from not just through the US, but doing it throughout the world, that's really going to be an advantage. Yeah.
Leslie, there's a physician, it's Mike.
Are there
Hi, Mike.
Any other questions?
There is a physician down at Children's at San Diego who studies Kawasaki's disease and has a tremendous number of samples from Kawasaki's over the years. And it's very similar to this multivascular, multi-organ disease. It'd be interesting to look and see whether or not the parameters that she's measuring, have any relation at all to what we're seeing in COVID.
Yeah, that's a great point, Mike. I agree completely. We started talking about those kinds of comparisons as well on some of our calls. Yeah. UCSD is part of this as well.
Yeah, her name is Jane Burns.
Okay, thanks. I might write you later to get that.
That's great. That's fine, no problem. She's a good collaborator.
Oh, good.
I think with this, I think we can move on. Will you be able to stay on for our larger?
Yes.
That's a word. Yes. Yes is the word I wanted to hear. So I think with this, I'm going to pass this over to, again, we'll thank all the speakers for this afternoon. It has been a pleasure and an education being the moderator on this, and certainly I'm sure for the audience as well to hear this. And I will turn this over to Ilham, who will moderate the discussion at the end. Thank you.
Well, thank you again, everyone, for sharing all your exciting and unpublished data with us today. That was absolutely great. And for the panelists who were able to stay on, and for the participants who were able to stay on, what we figured we would do for really just the next 30 minutes is reflect on the year that's been and sort of discuss where should we go next, and where are our challenges that are waiting for us. And so I think, earlier this morning, we got a little bit of a challenge from our VCR. And the question was, well, given the amount of progress that has been made over this last 12 months, what does the future look like? I mean, where should we be, what kind of science should we be focusing on? And what are the questions that we should be asking? What should we be building more on, or should we be pivoting to something completely different? And so it's I think that's how I want to open it up. And I'd love to hear back I'd love to hear from everyone. And the participants in the webinar, absolutely, you can use the Q&A to submit comments and impressions and questions. And then I can field those questions back out to the group. I think that one of the things that really stood out to me today is there's definitely a number of organic collaborations that have happened over the last year amongst us at UCI, but there's also a lot of us doing work in parallel to each other, or not quite aware of what is new and what are the areas where we could collaborate on. And I would love to see, I don't know, more of a clearinghouse of what everybody's working on, and intersection points where we could really synergize and build upon the strengths that we each bring to the table. And because I don't think this is going to go away. I mean, I think it'll hopefully just become one of those respiratory pathogens that we deal with, but it would be great to have a very clear roadmap for how to respond to the next crisis. And so I don't know, would love to hear at least other people's comments or ideas for what we do moving forward.
To me, that was one of the outcomes of this meeting here. That we finally took a little time out to check and see what everybody else was doing. I mean, even in working with Bernadette, I mean, we had 7,000 samples that we were, our responsibility was to make the measurements and put it into a form that then they could take it and do the epidemiology on it. And I would have to say, this is the first time I heard that summary of how it was used with interpretation. And it's not because of anything that anything that was lacking, we were all just working as hard as we could to get everything done. So this was fantastic for that. So I think that could lead into what you were just saying. Maybe more than every year, we could get together like this and give a summary report, and find out what's going on. I think it helps people involved to do what they need to do too, to each one to, to organize what they've learned so far and then give a summary report. So maybe that would be some kind of action item that we could implement in the future here.
Yeah, so more checking in with each other in some way.
Yeah, yeah.
Maybe we could use OR's website or some sort of, I don't know, COVID at UCI research website or something, and or like our own Twitter feed for, at UCI COVID-19. I don't know. I'm just spitballing ideas, but somehow to just keep in touch with what, like, because I noticed, I was like, oh yeah, that'd be nice. Phil is looking at all these very, granular details of the antibodies to spike, and we're doing all this B-cell repertoire analysis, and gee whiz, wouldn't it be nice if we actually could, combine forces and do some of these things in conjunction. And looking at Leslie's site, and we were doing transcriptomics, and there's a very high chance that we actually have samples from the same patients.
I was thinking that exact thing, Ilham, that we should coordinate the patients, right?
Yeah,
that would be great. And with Phil.
It would also be nice to actually get some public exposure, get some publicity about this from time to time so people know what's going on.
I think also some of the data coming out from your single cell RNA sequencing data, from Leslie's mass genomics data, especially as I say on the kids with the multiple systems inflammatory response. I mean, this gives us an indication as to where, what to target with these. But it would also, enable being able to get samples from some of these kids would be a big advantage as well, because the sort of thing that you're doing with adults, to be able to do it.
Yeah, we might want to try to coordinate some of that, huh? Because we're just starting to recruit, get those patients.
I think I was amazed. 1,001 patients at CHOP, and are they being followed up once they leave?
Not so much, actually. And a lot of them weren't, hospitalized, obviously, but still, it's a big number.
Yeah. And there's also maybe other things to do, more of a clearinghouse, not only for that, but for example, Julie, who was one of our presenters today, was not in here. We're responding to an RFA that's looking at challenges to the maturation of the child immune system over time with infection. And, so I think we're actually going to be probably contacting the same people you are. And so I think also just from not having patients get fatigued by bombarded by multiple requests. So maybe that's a place where OR could really come help us, create a place where we could all go and check in to see what's happening. And along with some sort of regular, they don't have to be a whole day long, but regular check-ins that once a week one seminar or something where we could see what others are doing, so we can keep in touch with each other. That's definitely something that we can bring up.
Would it be good to organize an exchange with the other campuses that are carrying on similar activities? And have some exchange of information that way.
Yeah, I think that's really valuable. I almost feel like we need to figure out what we're doing before we go and ask for bring other. But yeah.
What we saw today was the start.
Yeah.
More than the start. It was a lot of really good data.
Yeah.
And as soon as Leslie finishes conquering Huntington's disease, she'll be able to spend full time on it.
There you go. Once you've cured Huntington's, that's perfect.
Yeah, I don't know. Sang-hyuk, I don't know if you want to add anything from your standpoint or promote if you're still on. There's something specific that you'd love to see more of.
Yeah, well, I've been listening with great pleasure to all these wonderful talks. So it's just been an amazing experience for me to hear all of you explain what you have done. And I'm, my office stands ready to help. So, but you to tell me what what help my office can provide. I would love for UCI to continue to move forward in this space. I think I heard Mike say this is not going away.
It's not, unfortunately. Yeah,
So,
I mean, I'm sure Susan will concur with us. Her and I are already discussing things like, what can we do to, is there anything from a laboratory perspective that we could help with, like mass screening for, some of the ideas that Susan has with nursing homes and environmental sampling instead. And, so not only at the local level, but just, spreading the reach of UCI to our community. And are there ways in which we could be more helpful? Yeah, so what have we learned in the lab, and how could we apply it in a way that is high throughput, low cost, more engaging, have learned the lessons of some of the inequities that have happened, et cetera. But
a simple thing we should try and do is create some kind of an email alias of all the people who spoke today and many others, just as a way of communicating within the group, right? So I have created this VCR announcements thing on which I send out, whenever I have something to say, I put that out. It's not like a Zot mail that goes, into spam boxes. But I think this group could create an email alias. I can get Greg Ruth to do it for us, so that's easy. And then we can just use that to share, like I'm giving this talk, or we just published this paper, or we are doing this project, and people don't have to read it if they don't have time, but that way at least people can be kept informed.
Right.
So that's one idea that is easy enough.
Yeah, here's the latest.
You have to tell me what else we can do from OR.
Yeah, I mean, here's RFAs that, who else can respond to this RFA? I'm looking for this, or I'm thinking of, I'd like to respond to this. I'm missing this expertise, or does anybody else have any ideas?
So maybe we can have a COVID-19 email alias listserv. People can sign in, and then that can become like an easy communication mechanism.
Also, I don't know, has anybody used Slack? We use it quite a bit in the lab. I don't know how everybody feels about that.
I was just going to mention that too. We use it, our consortium uses Slack, has a Slack channel in lab. And yeah.
I was about to just say Slack as well. I think that would be a good medium for something like this.
Yeah, Slack is an alternative.
I don't know, Carter, Allison, yeah.
You have a comment in the
I was.
Right? So
I was.
Peter Hazelstein. Sorry, Allison. Just real quick. I just wanted to mention that Peter Hazelstein just put a comment about I guess some kind of like a database, like a clinicaltrials.gov, a repository of all the different research activities going on. Sorry, Allison. Go ahead.
Yeah, no, I just wanted to come back to the issue of the mental health side of the house, because I know that we've done a lot of talking about the physical health parameters and the, things all related to the sequencing of the genome and and we need to understand all of that. We also need to understand that interfaces very closely with mental health. And we know that mental health diseases like depression and post-traumatic stress disorder are diseases that also have inflammatory processes associated with them. We know that there is that interface, and when you talk about physical health, you cannot divorce it from mental health. And I guarantee you there is going to be a mental health fallout from this pandemic that is, I anticipate, will have an impact on our cardiovascular health in this country, precisely because cardiovascular health is one of the most vulnerable to the stress-related mental health problems like depression and post-traumatic stress disorder. So I think it's really important as we move forward, as we start thinking about ways of building collaborations and building connections with each other, that it goes into the understanding of the connection between mental and physical health and how important it is to address both. If you want to get somebody well, true wellness is about having good mental health and good physical health. That's true wellness. So I want to encourage us to think along those lines. I'm a little bit pushed to this by David Lenhart from the New York Times, who yesterday published something talking about how Republicans and Democrats had this different way of looking at COVID-19, and the Republicans, they sort of underestimated and Democrats overestimated. All they were talking about, though, was the physical disease. And it's much more than a physical disease. There's lots of people, long COVID, lots of people being left behind with major disability. And so we need to think about that. And we need to, it goes well beyond understanding the physical parameters of this disease. So I'll stop at that.
I couldn't actually
Do you know
agree
if NIMH is doing anything about this? I mean, I have no idea if NIMH is.
They are. Yes, they have their own initiatives, but frankly, the NIMH, I'm going to say something and I hope it's not considered heresy, but NIMH is all about brain science, and it doesn't take into account some of the broader, more holistic approaches to understanding people in their context. And it's really, COVID is a disease. COVID is a disease of a society. It's a disease of a social, that hit our social fabric, and not just our physical selves or our mental selves, but it hit everything. And so I really think that we have to look at it in that more holistic perspective rather than focusing in on just the brain science of it. But they're focused on the brain science, very much so. That doesn't, they are starting some new initiatives toward that end. But yeah, I mean, that's a possibility if people are interested in the brain science and understanding its overlap with mental health stuff. That certainly would be a possibility. Yeah.
There's actually a nice RFA that is coming out of NIAID, but it's circling. I was going to say that's something that could be sent right away as soon as we get our Slack channel up and going. But it's called the Improve Project, and it's very focused on 3 aspects for maternal health with COVID infection. So it's looking at, and I can, like I said, I'll send it around, but it's looking at the impact of COVID-19 infection during pregnancy on the mental and physical well-being of mothers. And I can definitely, I was going to say, I couldn't agree with you more, Allison, because even those who did not get COVID this last year really went through a massive stressful period of time that was incredibly, I mean, completely just, yeah, off the charts, right? Like, I think, you know, I don't know, I'm thinking of like everybody who had to be home, had to be separated from their families, had to take care of small kids, had to juggle 15 things at once. I mean, it's been, you know, lose their jobs, like, et cetera, et cetera. So it's been really stressful. Susan, you don't have to raise your hand. You can turn.
Oh, I just
wanted
to say thank you. Like, I think in many ways, a lot of the ability to reach out across disciplines was really born before COVID. And I think if it wasn't for the vision of many of you on this group to actually start those conversations, it really did jumpstart a lot of reach outs rather than starting from scratch. I do think that the work that the Dean of the School of Medicine with other folks to put some money in for starters, you know, like a lot of folks don't have the ability to pivot from what we normally do, right? And then all of a sudden take on something urgently. And I think a lot of the ability to maintain that is helped by small pilot grants that keep those good ideas burning and give them enough fodder to be able to really step it up to have preliminary data to apply for a proper grant. So I do think that some of the ability to maintain that has to do with the ongoing small pilots that are supported that keep multidisciplinary tests going.
Yeah, no, I definitely am doing things that I never thought I would be doing. I think everyone in this group probably could say the same, right?
Well, I also think there's a lot of credit due to the school and to Promote in particular for, you know, jump starting this a year ago with a series of grants and opportunities for us to you know, to go out and come at this virus from so many different angles, from, you know, the work that you're doing directly with patients. Of course, that took a while to actually get access to patient samples, which was a bit of frustration. But by this point, I think everyone seems to be working together. I think it's been a huge benefit, Pramod, and I think you should be you know, really pleased with what's come out of this. A lot of good things.
If I could chime in, I want to speak to a comment that was made earlier that, you know, well, this won't go away. But I actually want to take a counterpoint to that, which is that whether or not the disease goes away, it will go away in the sense that, you know, the societal focus on COVID as a threat and all of the stuff around that is in fact very likely to ebb once the emergency is passed. And we know that because, you know, all sorts of you know, disasters, even really serious ones, come through, and it's quite remarkable how quickly people forget and move on to the next thing. And so that, you know, there's a saying in the hazards community, you know, never waste a good disaster. And of course, disasters are not good, but given that we have to endure it, you know, we want to try to make the most of the opportunity that gives us to build for the future. So I think in terms of people thinking about, you know, what kinds of things UCI can do, and especially this initiative can do, I think it's also important not to build around COVID per se, not that we, you know, there's still plenty of pandemic left and there's a lot of important work to do. And so I do not in any way want to denigrate that. But I think we also want to be thinking about how investments that are being made in institutional infrastructure or projects that are COVID, like, can be pivoted back into all the other things. I mean, this initiative, which I think is a really important one, was, you know, founded, originally motivated obviously by other diseases, and it was founded at an auspicious time in a way, as others have commented today, because it was there to catch this event when it happened. But I think if we can use this as an opportunity to raise the profile of the importance of infectious disease research, which maybe not everyone appreciated why that was really important, you know, a year and a half, 2 years ago. Now they know, right? And they will forget it again, but at least there's going to be a time window, right, in which before they develop those antibodies and are immune to the pitch. And so while that's there, I think it would behoove us to think about, you know, what can be done to use this as a way of building into all the other important ongoing infectious disease threats, because obviously once COVID's gone, there will be many more coming down the pike, and there are many that have not gone away, right? Not only in the US, but worldwide. And so this is an opportunity for us to then use this to boost the initiative and boost other activities on campus, not just for this, but for the future as well. And that's just the one thing I would suggest is when creating things, you know, it's fine to put a COVID spin on it, but I would suggest making sure that it's always set up in such a way that it can then move on to other things in, you know, as we look to the next 5 years, you know, 10 years, when this pandemic will start to become a distant memory for people, which will happen faster than we think, is my prediction. Well, we'll see what happens, but that's how it's always worked in the past. So.
Now, I really appreciate you saying that, Carter, because poor Pramod has had to deal with me saying over and over again that immunology and infectious disease research on this campus has kind of like fallen off the wayside, and like nothing like a pandemic to kind of have a wake-up call. And we all really have to take a hard look about how we're organizing our efforts around infectious diseases on this campus. And you know, I mean, Sang-Yuk and I mean, thankfully met pre-pandemic, but barely, right? I was in your office at the end of January going, oh my God, we really need to get ahead of this and, you know, request money to look at asymptomatic shedding amongst like healthcare workers, right? And but yeah, I completely agree with you. So I really do think that we need to do a postmortem on where our infectious disease immunologists, virologists, you know, mathematical modelers, like nursing, where are all the people who peripherally touch, are interested in this field? Where are they located? How do they talk to one another? What brings them together? What sets us up for, you know, being able to pivot quickly, respond quickly, write the next U19, write the next, I mean, we have to do this. We absolutely have to do a little autopsy on the situation when the dust settles a tiny bit.
Well, today we've really had a cross section of that, of both the public health side, the mathematical modeling side, the basic research side. and I think they're all intertwined. I mean, from you know, what Allison was saying regarding depression, what others were saying, Carter, I think, was saying, and in healthcare disparities, and you know, from what Susan was saying, that you've got healthcare workers who are so poorly paid they can't afford to miss a day of work, and so they become you know, a danger to those they're trying to take care of. I mean, all of these things factor in together in terms of our understanding of healthcare. It has been quite an education to see how much has been out there. It was Mike who showed the diagrams from the New York Times that came out just whenever it was, a few weeks ago. But you know, we're getting an education every day on what the different vaccines are, and the community is paying attention. I mean, the whole population is getting a lesson in immunology and infectious diseases. And I would just second what you're saying, that the university needs to invest, I think, more in all aspects of infectious disease and immune response. And you know, the university has certainly supported it, and you know, promote supporting both our centers here. But,
well, 2 centers, and I guess the provost office is supporting the initiative, and then but Phil also, that's an ORU, right? So
yes, it is.
Yeah. So I think it's almost like it's the right time to really look at all of our efforts and see how we can do this better.
We should be building up our faculty on this as well. This is an opportunity to actually, you know, bring people in with these specialties, both the basic science side of things and in the healthcare and public health aspects.
Also, just bringing in like psychiatry, I know has been, because half my appointments in psychiatry, and they've been really dealing with what Allison's talking about, the mental health impact of COVID, just working so hard dealing with that.
No, absolutely.
Yeah.
This has brought, I mean, it's brought an awareness of the disparities that we have in our society.
Sue Ellen, you look like you want to say something.
Oh, I wanted to thank you and everyone for organizing it. And I will, as far as the sustainability of and increasing the visibility of these infectious diseases, I also think people may quickly forget the pandemic, as hard as that may be to believe, but climate sensitive infectious diseases will be forthcoming. Even Eric was working on the valley fever potential. I mean, fungal disease. I'm sure there'll be lots of climate sensitive infectious diseases, and it's also good to know what you're doing. I worked with Dan Geschwin 20 years ago, or just to hear what's going on with the children, because I do interface with the schools and the families. So I'll keep an eye out when I'm interfacing on the educational side about what's keeping abreast of everything that's going on. And as well as I didn't emphasize enough in my talk, the structural determinants of health, and how really messaging should also be targeting employers about work policy leaves. Otherwise, people won't be incentivized to stay home when they're sick, and they do spread things to nursing homes and things like that.
Yes, well, and you bring up, sorry, Eric, go ahead.
I was just going to say, you also brought up important issues, Sue Ellen, in terms of vaccine denialism and people who just don't want to hear the truth. They want to hear, their own echo chamber, and end up being, the sort of notion that I can't remember who brought this up earlier, but the idea that wearing a mask, social distancing, taking care of people in your community becomes this incredible political battle when it should be, as obvious as can be.
As somebody who lined up in 1955 to be shot with polio vaccine, there was no dissension about that in my neighborhood, in Seattle area. It was absolutely terrifying. for parents.
Of course.
Well, I mean, I really like the idea of maybe including the climate change into this equation too, because yeah, I mean, a lot of these zoonotic diseases are going to happen more because where territories are being encroached upon, and so it makes, you know, it's prompting us to look at more like bigger pictures of yeah, the intersection between climate and health as well, and that's a whole other thing that we really should look at. There's an ongoing Ebola outbreak in West Africa right now. Yeah, that's believed to actually be, yeah, another. And this is interesting because the genomic sequencing says that it's extremely closely related to the same virus that was circulating in 2014 to 2016. And so they actually think that one of the survivors, it may have reactivated one of the survivors and being passed down through sexual transmission, which is just then completely changes the playing field for how, you know, filoviruses with a 40 to 60% mortality rate at best is going to be transmitted. So
we also had that scare, when was it, 3 years ago with the Zika virus?
Yep.
So, you know, wreaked
5 years ago now.
Is it 5 years, 2015? Yeah.
So I don't think infectious disease outbreaks are, I think we're going to see more and more of them, and they're going to occur at the same time.
That time, but you know, something like that certainly could. There were plenty of mosquito-borne.
Yeah.
Alongside all of those,
there's going to be more, right?
Yeah, and alongside climate change and all of these other infectious diseases is going to come people worried about the spread of those diseases. Again, like I said this morning, you know, they're invisible. You can't see them. You know, it's going to create the ripe opportunity for people to have mental health issues. And in fact, I have somebody in my family who's currently interested in studying the issues of the mental health crisis that's going along with the climate change, the consequences of climate change in the world. So I think I'm just going to weave it back in. We have to think about, when we're talking about the public health and the well-being of our country and of the world, we have to think about the mental health side of that.
No question.
Well, I think, I mean, I am hopeful for the future, but I really think that this was a good opportunity for us to all come together, get to know one another, hear about what we're working on, which I would have, you know, that was such a great I understand that it's the tip of the iceberg in terms of research that's happening at UCI, but it was a really good tip of the iceberg to see just the amount of diversity and of work that's happening. And I want to thank all of you for agreeing to speak today and to be here. And I thank everybody for attending, and thank you, Pramod, for supporting this. And we look forward to the next series.
Right.
Yeah, well, thank you guys for putting it all together.
Yes, it was great.
Thank you, everyone.
Thank you very much for you spending the whole day doing this.
Bye, Pramod.
Have a great weekend, and we will do another such event sometime in June, May or June.
Okay.
Yeah, good.
Bye.
We'll help promote this.
Yeah, look, well, I count on you. I can do it.
Thank you.
All right.
Bye.
Thank you.
Bye.
Thank you.